day yesterday, which had best of the sessions, orations, symposium, CPC, and also we had the AGM, election, and a inaugural function, felicitation, and an inaugural dinner, which has been thoroughly enjoyed by the delegates and the faculties last night. Maybe again it's last night's effect. People are a little delayed, but I am sure we have around 400 delegates still, and they'll reach soon after the breakfast. So I welcome all to day 3 program, and it is the last day. So in agenda, we have very interesting presentations. We have medicine quiz in Hall B. We have the presentation by the invited faculties and very interesting topics like overlap syndrome, like hanging, and you'll listen a complete different story this day. So I welcome all and request Professor Manoranjan Behera to give a sum up of the events yesterday. Professor Behera.
A very warm and heartiest welcome to all. Very heartiest good morning. Yesterday was a very scintillating and brainstorming day. You started at 10 a.m. and our scientific agenda ended at around 6 p.m. followed by annual general body meeting and cultural program. And it was very nice to see all the family members, all the faculties, PG students, and non-medicinal departments participating in our cultural dinner. So today is the last day. So I am just briefing what are the proceedings of yesterday. We started with a symposium on dengue fever, and we had got our eminent faculties from AIIMS Bhubaneswar, like Professor Baijantimala Mishra, Ashutosh Biswas, Anupam De, and they told us about the laboratory diagnosis, pathogenesis, and treatment of dengue fever. One important thing they have told that though the NBVDCP Government of India guideline has told us for NS1 antigen up to 5th day, followed by IgM dengue, but recently to avoid the missing of secondary dengue fevers, she had told that we can do both NS1 and IgM on day 3rd onwards. It was followed by Indian lipid guidelines by none other than the lipid man of the country, Dr. Raman Puri from New Delhi, and he briefed us the recent guideline led by the Lipid Association of India, and enumerated that for the high risk patient we can go up to LDL less than 50, even up to less than 20, and the various guidelines and the management. Anju Mahesh sir told about the back of basics, reminded us our William Osler's quotations, and how we are forgetting our clinical science, and how we are forgetting all the laws and all the things. And he reminded us to have a good fellow feeling, to share all the day-to-day proceedings with our fellow colleagues, so that we will not be pulled up to the court of law. Then it was followed by Dr. Krishna Saradi on exogenous Cushing's disease, and we have got our National President, Dr. Shyam Sundar. He told us his journey in leishmaniasis. But because of shortage of time, we skipped the API Odisha chairman's address, was to be delivered by Professor Jayant Kumar Panda, the chairman organizing committee, and but we are hoping that today his session will be held. For the first time, we have started R.K. Parida Memorial Gold Medal Oration. It was delivered by none other than Professor Dr. Siddharth Das. He told us regarding the proteinuric to non-proteinuric nephropathy in type 2 diabetes mellitus. There is a paradigm shift, and he showed us how a person having normoalbuminuria is having gradual declination in the eGFR. So, and other non-diabetic comorbid conditions leading to kidney disease in diabetic patients without having albuminuria. Then we have a very brain scintillating and mind-throbbing CPC done by Department of Primatology under the moderatorship of Professor Vidyut Kumar Das. There is a nice case of systemic lupus erythematosus with non-bacterial thrombotic endocarditis, autoimmune hemolytic anemia, and extrahepatic portal vein obstruction. Then Dr. N.K. Singh, Dr. D.P. Khaitan, and Ketan Mehta told about the reality of precision medicine in type 2 diabetes mellitus 2022, EC changes in supraventricular arrhythmia, and vitamin D3 hope or hype by Ketan Mehta. Ketan Mehta told mostly in favor of hope than hype. And then followed by Dr. Abhay Kumar Sahu and J.B. Kanwar on the management of how the management has been changed after semaglutide and in the individualization of insulin therapy, positioning right insulin for diverse patients. And the end, last session was the mixed basket, where Dr. Sambhu Datta apprised us regarding the approach to acute febrile illness in emergency ward, and Arpita Priyadarshini told us regarding the sleep as a prescription, which make awake to all. And there was a fine case discussion by Dr. Bharat Panikre, how a middle-aged person with bilateral submandibular gland, lacrimal gland, and parotid gland was initially suspected to a case of Sjogren's syndrome, finally turned out to be a case of IgG4-related disease. So, and the session was ended by Dr. P.K. Thatoi, who told on use of bempedoic acid in dyslipidemia management, how to add if you are not reaching the LDL target with statins and ezetimibe, how to we can add bempedoic acid to reach the target. So at 4:30 to around 5 p.m. we had our GBA meeting, then followed by inauguration of the conference, and that was followed by cultural dinner. Thank you all.
Thank you, Professor Behra, for a detailed report for yesterday. And I request our scientific chair, whose dream is being executed, is in the day 3, so he will detail about today's plan. Professor K.N. Podheri.
Now, today we have got both outside speakers and inside speakers, and there has been some leftovers from yesterday, and important, that is our state chairman's oration could not be conducted yesterday, it will be done today. We will try to find out time. And because we have already started late, one of our outside speakers has got flight in a particular time, and we will try to finish his talk fast, and we will include him in the first session. And I will allow him to take the first speaker, then we will continue that first session, and in this way we will continue. We will finish at lunch. There will be valedictory function. There will be prize giving ceremony. During the valedictory function, there is charge handover from the new new executive committee, from the old committee. All these things will be there in the valedictory function. So without a delay, let us start the first session.
Thank you, sir. We have Dr. Manoj Chotra here, our president-elect now. He'll take over as president because yesterday he was nominated and elected in the election. Please give a big hand for the president of 2023, and I welcome him on hall. And this session is a very interesting session, as Professor Podheri has told. I request the anchors to invite the chairpersons. Actually, Professor Pradeep Mohanty is here, and we'll have Dr. Keshi Mahanta joining him to start the session. We'll start with Dr. L. Srinivas Murthy, followed by our usual schedule of the anoxic encephalopathy, enteral parenteral alimentation, and the overlap syndrome. Anchor, please.
Time untied, waits for none. Yesterday we had started and today we are done. A very good morning, one and all. Myself Sitanshu Shekhar Pradhan, second year medicine resident.
I am Dr. Shairi Chakrabarti, second year resident. Welcome you all to the final day of Apicon Odisha, the 42nd chapter.
The last 2 days have been exceptionally phenomenal and has imparted us with rigorous scientific deliberations, thought-provoking debates and symposium, and latest update in the field of medicine.
It was only possible because of the relentless and thoughtful efforts of all our respected dignitaries. Let us start the day with the first session, a mixed basket. I would like to invite upon stage the chairpersons of today's first event, Dr. P.K. Mohanty, Professor of Medicine, Vimsar Bulla, Dr. Anchal Sahu, Assistant Professor of Medicine, SCV Medical College, Cuttack, Dr. Saknika Tripathi, Associate Professor of Medicine, Vimsar Bulla, Dr. K.N. Padheri, Professor of Medicine, and Dr. K.C. Mohanto from Rourkela.
So on the today we invite Professor L. Srinivas Murthy. He is from Life Care Hospital Research Center, Bangalore, and he has got a lot of laurels, as you see here on the this slide. He is the Governing Council member, National RSSDI, Governing Council member, SCP India chapter, Vice Chairman, API Karnataka, and all the laurels are there in addition to his involvement and publications, as you see here. So I request Professor Srinivas Murthy to continue with his topic. Thank you.
Good morning. Thank you, sir. Thanks very much. Indeed, it's a pleasure, honor to be here because it's my dream to see Puri and Jagannath Sarji give me darshan yesterday because of Dr. Jayant Panda, sir. And in case, sir, thank you very much including this in the scientific session. I think the mic, we can remove this table. Thank you. Thank you, sir. So I'm really obliged, again accommodating me first in the session, and welcome all. Good morning to everyone, and let's look at the choosing the ideal single pill combination, the SPC, the single pill combination now available in our armamentarium for the treatment of hypertension. Most of us tend to forget that treating hypertension will give us more mileage in preventing the complications to the patient. We try to chase the FBS, PPBS, HbA1c and lipids, which do not impart the number of advantages or the percentage of advantage by than giving the control of hypertension. And thank you, chairpersons, for the kind introduction. And I am the Vice President of National RSSDA, so that was my old introductory slide. Thank you very much. And let's look at the blood pressure survey. Why is it important that to treat and control hypertension, which gives us more advantage than treating any other disease? As you can see here, 1 in 3 adult Indians have high blood pressure. 1 out of 3. That's most important. And the prevalence is almost double when you compare for the same age group to the US. And that's the scary part, that the silent killer will not give us any scope to prevent complications if you don't tackle that at the earliest. And this is the data across 24 states, about 1.8 lakh patients, and you can see the prevalence, which is double than that of US. Here, you can very clearly see the so-called treated patients and percentage of untreated and the complications. As you can see, the red one are the treated but not controlled ones. That means they are coming to us, but we have the inertia of up-titrating the medications or adding on a new molecule, then resulting in the complications. You can see CVD, heart disease, or cerebrovascular disease. All three components are worst with the treated but not the well-controlled group, as you can very clearly see in all these three. Now look at the new data from the SPRINT trial. We know the SPRINT trial proved that the lower the BP, the better for the patients. It was 25% lesser of all-cause mortality when people were in the intensive arm. And that's the best part. And you can see here, across the age group, sex, race, and the previous history of cardiovascular disease, it has clearly shown, you can see the forest plot to the left, that it is going to be advantageous. It was a 25% reduction with just a tight control of your hypertension, and that's the primary outcome of this. Now, this slide clearly shows some of the major outcome trials required more than 2 drugs to attain the target BP. That means in the clinical trials, I conduct a lot of clinical trials, and it's a controlled environment where literally we call the patients once a week, telephonic, or once in 2 weeks, physical appearance in the clinics. In spite of that controlled environment versus your OPD, when you say patient to come back after a month, they'll come back after 3 months. And that's the OPD setting, real world setting. But a clinical trial setting is a very controlled environment. And you can see, including your EQPDS, heart trial and IDNT, where you require more than 2 drugs to control the BP. So this is a very clear-cut message that most of us as physicians have got an inertia to up-titrate or to add a new molecule. And 60% of the patients are uncontrolled who are on hypertensives. And that's something need to be very, very clear. So 60%, whether it's men or women, and that's equal, the gender inequality is not seen when it comes to the uncontrolled hypertension. So the need for better adherence is the basic problem, because when we say there are pills for patients, they definitely do not adhere. As you can see here, the 6 or more drugs, 80% of them are non-adherent. When there are 6 or more drugs to a given patient. This is one of the studies which papers, risk factors for non-adherence in antihypertensive treatment. So if you put more than 6 drugs of whatever, dyslipidemia, diabetic, thyroid, anything, more than 6 drugs, then the 80% of them are non-adherent. Either they skip one of the pills. And that's a proven evidence what I'm showing. So suboptimal adherence, another problem. So these problems can be overcome, and that's why WHO and the essential medicine list has told treatment with a single pill combination is the emerging best practice. And that's how now, including ADA, has come out with the triple drug approval for anti-diabetic therapy also. That's the best part about the SPCs. So 60% of them are uncontrolled despite treatment in India. This is the data. So this is in large due to the fact that most treated patients only receive monotherapy, despite guidelines recognizing that the large majority of patients require combination therapy. And this is all the onus is on treating physicians, treating clinicians. And that is why the importance of combination therapy is emerging now, and the guidelines are up-titrating, are upgrading to recommend the SPCs. So 81% diagnosed with hypertension are treated. In that, only 40% are controlled. So less than 50% in the treated group are controlled. And this is a very interesting figures, which is out of 26 countries, all the 5 continents are covered. This by a cardiologist registry, wherein about 18,000 patients were picked up. And all those people have got EMRs in the West, so very easily you can pull out retrospective analysis can be done. In that, you can see 30%, this is a cardiologist registry, mind you, 30% of them require more than 3 drugs for the control of hypertension. And this is again, I'm emphasizing the fact that more and more drugs are required to reach the target of 130/80. So with the triple drug single pill combination, more patients achieve. You can see 1, 2, and 3, the green one, definitely the systolic or the diastolic, and prevention of this is most important. Most of us treat our patients not to push them into these complications of stroke or ischemic heart disease. And that's what is happening here, that you can see very clear reductions when somebody is on a triple drug combination. And that's the most important thing we should recognize. So the strategy for improving hypertension control require more than 2 drugs. And this is what all the international bodies are talking about, including our Indian Society of Hypertension has recommended. And let us look at some clinical evidences for this. So the recommendations from major hypertension guidelines. You can see this is the ESC guidelines, ESC, ESH, where the first pill, this initial therapy, should be dual combination. So they are straight away recommending at step 1 that you combine ACE or ARB plus a CCB or diuretic based on the patient. Monotherapy only in low risk grade 1 hypertension when it is systolic is less than 150, or in every old patient more than 80 years or frailer patients. So this is the only condition where you have a single drug. Otherwise, invariably, you need to start on a dual combination drug. This is a ESC, ESH latest guidelines. Step 2, directly go to the triple combination. ACE or ARB plus CCB or a diuretic again. And step 3, triple combination or add on a spironolactone, which is a resistant hypertension. And the aim for BP control would be less than 140/90 within 3 months for the patient. So this is our target in the OPD practice. Please try to bring down in a span of about 12 weeks the BP to less than 130/80. And that's where you prevent the complications, which SPRINT trial I showed you clearly showed us the evidence of bringing down the BP in the intensive harm. And using long-acting drugs that require once daily dosage is recommended. Again, why? Because of the compliance, the adherence problem which most of us face in our daily routine. So very important, choose the right drugs, choose the combinations in the earliest as far as possible. So the ISH 2020, the International Society of Hypertension 2020 guidelines recommend triple combination needing 3 drugs, and this is what they are combining ACE or ARB and CCBs is a thiazide-like diuretic. So this is the combination which is recommended, and as again emphasizing, step 1 would be dual low-dose combinations of this. It's a combination therapy, International Society of Hypertension. So the clinical evidence to choose the optimal hypertension treatment strategy. Again, the evidence here, 24-hour blood pressure management in India, a position statement by Indian College of Cardiology I am showing, because every time we show, the evidence will be of the Westerners' data. So we have very limited data in our country because most of us, again, have got an inertia to do clinical trials or the researches or to publish papers, and most of us do not incorporate EMR so that you don't retrospectively extract data very easily. That's one of the things I would advise and urge all of you to use the EMR so that we can publish more and more data, because the number of patients we see are enormous. We have enough data, but it's not organized. So the management of BP should be aimed to control BP effectively, 100% drug-free ratio, these drugs we need to choose, the sustained activity of longer duration. That means once a day pill is recommended again by ICC. So it's a multi-dimensional approach. Rapid and strong blood pressure, this is what I said, rapid and strong blood pressure control. Again, ICC is recommending, that is within about 3 months you need to bring down the BP to 130/80. True 24 hours coverage due to 100% the TP ratio. Cardiovascular, renal protection, please look into that category. And of course, any drug, we always look about the adverse events. It has to be safety and well tolerated. So this is the combination which is available now in the market, the perindopril, indapamide, amlodipine, single pill combination, and look at all the evidences with individually. Remember, indapamide is the only diuretic which is proven in the IVET trial, elderly patient, the cardiovascular safety and mortality benefits. This is the only diuretic which has got that. None of the other diuretics have got a CVOT trial, and this is one which is there. Amlodipine, we know, time tested. Again, in the ASCOT, Advance, Progress, IVET, these are the molecules which are studied, and when you put them into one single pill, definitely there is evidence. What is the evidence? This is called as a proof study, and there is one more called Pianist study, where about 1,600 patients were uncontrolled, stable on previous, including 3 drugs. They were also on 3 drugs, the category, where they were switched to this perindopril, indapamide, amlodipine combination, and this is the baseline characteristic, 61 years mean age, 165/96. Majority were obese, 19% of them had diabetes. So this is what we see also in our routine clinical practice, uncontrolled on more than 2 or 3 drugs, obese, most of them, 20% of them are diabetics, and 3 months later, what happened? When you switch over to this triple drug combination, about 40 millimeters and 20 millimeters systolic and diastolic BP reduction respectively. And mind you, we know that data, just bringing down the 10 millimeters of systolic blood pressure will reduce the cardiovascular risk by 50%. Just 10 mm. That's why initially in my opening remarks I said, chasing BP will give us more advantages for the patient safety comparing to chasing HbA1c or FBS PPBs. So please remember that bringing down BP will give us more advantages. So strong BP reduction irrespective of the previous therapy, because as I said in the inclusion criteria, there are patients who are on triple drug also. But switching over to this combination, look at the previous treatment at baseline. People were on AS diuretics, AS CCBs, diuretics, CCBs, and triple drug also, and all these categories, permutations, combinations, what you can see, it was brought down. And this is, again, Indian data. I was one of the investigators for this. Dr. Siddharthan Shah, late Siddharthan Shah, were the principal investigator, and it was published in JAPI in 2020, December. 218 patients, this was basically for DCJ approval study, we did it. 218 patients, grade 2, grade 3, and you can see the male to female, the mean BP 160/95, BMI 25, 32 patients with dyslipidemia, 50 patients were about 50 patients were diabetes, hypertensive since 41 months, mean age was 48 years, and what were the results? Look at the result at the end of 2 months, it was 90% of them achieved the target of 130/80. And if you remember the proof study which I showed, which is a French study, wherein similar reductions of 24/12 systolic diastolic was there at the end of 1 month. So immediately after 1 month, because if you remember, most of the patients are referred to us as specialists. So when the patients come to us, they expect their BP or sugars to be under good control because you are an expert person. So this is where the advantage you get at the end of 2 months, 90% of the patients achieved the target. And as I was telling, it's a multidimensional approach. You need a 24 hours action because the TP ratio has to be 100%. And look at all the 3 molecules have got this peak trough ratio. And this is the segment where early morning we need to be more careful because most of the patients succumb to this higher risk of MI or stroke in the early mornings. And this 24 hours control is very important. And you can see all the other available molecules do not except the telmisartan, which is about 90%, which matches with the indapamide half-life. So again, the proof study I'm showing, look at the comparison between the Indian study and the French study. And this was again with the ambulatory BP measurement. In our study, Indian study, ambulatory BP was not measured. But again, you can see the reductions, both morning and evening BP with this ambulatory BP, ABPM study. So the perindopril, which is a very well widely studied molecule, and it has got documented evidence in more than 50,000 patients across these molecules. You can see the evidence of olmesartan and telmisartan, only this on target had got some positive outcome in the CVOT part, but otherwise perindopril, 50,000 patients across all these and studies. So let us look at the study called ADVANCE, where about 11,000 patients with perindopril indapamide was there, 14% of CV reduction, and in the ADVANCE CCB arm, there was about 3,000 patients with this triple drug combination and 28% risk of the primary endpoint. That's what we should look at, and this was a very long study of 4.3 years. So no ARB-based combinations offer these significant outcomes when it comes to the evidence-based. And new evidence further suggests that benefits of this perindopril indapamide amlodipine combination reduces the LVH. And that's another important point because most of our patients will have the LVH changes, especially when you do a baseline ECG. And this is again Indian data I'm showing you, published in the Journal of Hypertension in 2021. Albuminuria in patients at baseline at the end of 3 months with this triple drug, you can very clearly see just at the end of 3 months there is a reduction in the albuminuria as well. So in this phase 3 study, patients reported 91% compliance because of the single pill, 3 drugs in 1 tablet, and 91% compliance, 99% satisfaction to this molecule. And look at this cough, 1 patient, and ankle edema, 3 patients out of 218 patients, what we did for the Indian study. So another real world data, I have 1 minute, I'll just try to complete it. This is called as a Brisighella heart study. Again, this is a real world data. 8 years followed up was done in this study, and look at the percentage of patients reaching BP of less than 140, and reduction in the new onset of diabetes and CV outcomes. You can see the new onset diabetes with ARB, ACCB, thiazide, and switching over to this combination, all these factors were reduced. And the key finding, this study is one of the first which showed the long-term effects of different triple antihypertensive treatment strategies. Perindopril amlodipine indapamide group was associated with a significant lower diastolic BP reduction, more protective metabolic profile, importantly better target protection, and lower number of MACE events. That's something very, very pleasing to see. So to conclude, 1 in 3 adults in India have hypertension. 60% of them remain uncontrolled. 30% of them would require single pill combinations. Various guidelines have clearly showed us that the triple drug as step 2 treatment, and perindopril indapamide amlodipine is a globally available synergistic combination with global and Indian data available. It's the only triple drug which has got a proven outcome evidence and long-term efficacy and safety data established over 12 years. Thank you very much for again the opportunity and patient hearing. Any questions? I'll be very happy. I think I'm on
Any
time.
questions?
Ma'am, I'll take up sir's question then. Sir.
Mic on.
So this question is, which is the best time to prescribe antihypertensive? New evidence is emerging now to give it in the nights. But classically, conventionally, all of us have been using this in the mornings. But there is a lot of evidence now coming up. There's one trial, which I don't remember, it is going to be published in 2023, that is comparing the timing, the duration. I don't know if Panda sir remembers the trial name. It is publishing next year, sir. It's a huge trial. It's about
if it is a diabetes there, can you give it a night?
Still, indapamide has not shown the increasing frequency of your urination in the nights also. There is a study called Tiani study which has been given in the nights.
Madam,
Ma'am, you had some question.
mic.
Sir, congratulations for the good presentation. I would like to know what is the cost, whether you have the cost benefit analysis with a parallel group study, one. Second is, when we are going for combination, any combination should be taken as a new drug molecule. So this is only, this will only hold good for this combination, or you have some other option of, we can try for other options of the first line Gen 8 guidelines. Whatever you are telling, it is for this combination only, because it is a single drug and we should have sufficient evidence with us, particularly in Indian scenario, to recommend this thing.
Correct. So the question madam is asking is about any evidence for others. So we do not have evidence for others, especially with the long-term CVOTs. So this is the one new combination which has got evidence now to have about the CVOT advantages, which I shared, both the real world and the controlled arm. And any new molecule, the DCJ will ask for a new study. For example, recently I completed for your DAPA, CETA and metformin. I just completed about 1 month back and now it is launched already. So in any new combination, DCJ would want. Another rule is there that if it is more than 3 countries approved, the DCJ can give a direct approval for many molecules like that. For example, there is an injectable SEMA which is approved, but it's not available in our country. Because it's already there in more than 3 countries approved, like EMEA, FDA, they have gotten approval for your injectable SEMA, but still, of course, the pharma company has not made it available, just to quote an example. So any new molecule has to be studied on Indian patients, because I conduct a lot of trials, that's why I'm telling that is a rule in DCJ. Now, cost-benefit ratio definitely will not be done in the initial phase. We always look at, see, any new molecule, the pharma would invest so much money. I mean, just to tell you, out of 100 molecules in the research lab, 1 molecule comes out, 100 billion USD is the amount spent for 1 new molecule to come out. That's the amount of cost involved. Of course, I'm not supporting the pharma, but I'm just saying that's how they try to recover the cost until the period is over. Now, that's why the CETA now off patent, DAPA now has come as generic, all that. That's all because of the patency issues. So definitely cost-benefit ratio will be costlier for any molecule. I'm not trying to defend this molecule, but it is across the molecule, it will be costlier whenever a new molecule comes into picture. So that we need to explain to our patients. For example, most of us are prescribing GLP-1s, and we were prescribing SGLT2 when it was a 40 rupees a tablet. And why were we doing so? Because we are explaining the patients the pleiotropic benefits of the molecule. And that's what we should do.
Sir,
when
if you don't mind, we want to stop here.
Yes, sir.
About this question, this particular question, because I want to also ask one more question.
Sir.
As you know, as you already told, hypertension is one of the neglected diseases. The attention it receives is much less than diabetes. And the devastating scenario it causes is much more than diabetes, particularly in this, with regards to stroke. But one problem is that nowadays you do not get mercury sphygmomanometer to measure. And the rest of the things in the government setup, we see somebody measuring in a dial, somebody with a some other electronics, automated electronics measurement machines, and somebody with a mercury equivalent. So what do you recommend? Should you brought it to the fore or not? That there should be one sphygmomanometer with which blood pressure should be measured, because in control setup like randomized trial, you do practice different thing. But in a OPD setup, one person will see the blood pressure of 160 by 90, then he comes to me, I'll be seeing 140 by
Got your
80.
question, sir.
So,
So
what do you
WHO
recommend?
WHO has banned all mercury-based instruments about 5 years back across the globe. It is not for India.
Whether it's
So-
scientific,
No, that is next question. That we are not, this is not the forum. But WHO has banned all mercury-based instruments about 5 years back. Sure. So there is no question, no debate on that. So obviously we are left with the electronic. The problem with electronic, most of us do not calibrate. Again, because I'm in the trials, as you said, randomized control trials, I conduct phase 2 and phase 3 trials, we have to calibrate as per the GCP every 6 months, all the instruments, your weighing machine, your height scale, your everything, whatever instruments. So we calibrate the BP machines also, the electronic BP machine. That is the only thing which is recommended now. None of them are recommended. Calibration costs about 450 rupees whenever you do it. So
it is
patients, single use.
impractical. It is not practical.
Why not, sir?
Uh,
Can you not spend 6 months once 450 rupees on your instrument?
Not in a government setup where large number of
No,
patients.
that is
are-
next question. That is next question. I'm saying the recommendation. See,
Right,
following in government setup, we do, because I have also studied in a government setup. My MD, MBBS, everything. But we know what goes on there. That is not the point. The recommendation to our patients, once in 6 months, they need to calibrate at least single use once in a year. In a clinic setup, I would strongly recommend once in 6 months, all of us have to calibrate our instruments because that, based on that, we are treating our patients. When somebody is using for their own, one single person in a family, it is fine still once in a year, they can calibrate.
One more question, just a simple question,
Sir,
sir. At times, the patient, suppose if he is come with a blood pressure of 120, 190 by 120, and you have given some medicines thinking that it will be good. After 70, the patient comes, this time my blood pressure is not controlled. So when to escalate the dose? After how many days the dose should be escalated?
So the recommendation, every 2 weeks you can up titrate, down titrate, every 2 weeks. At least you need to give 2 weeks. And somebody is not responding like 190, 120, what you said, you need to look for secondary causes, obviously, with your routine approach if he's not responding.
Yes,
But
yes.
within about 3 months, that's our target to bring it down to less than 130, 80.
Okay, thank you.
I think Madam has got.
Sir, excellent presentation. Sir, what is the, when you treat with antihypertensive, what is the goal of BP? Below which you should not go? One question. Another question, if patient is taking on AC inhibitor or ARB, not controlled, when you add amlodipine, patient develop edema. Obese patients cannot tolerate. And patient is also having uric acid high. We cannot give diuretics. In those patients, AC inhibitor, ARB not controlled and BP is very high, what would be the next drug of choice in those kind of patients?
Yeah, thank you for the question. And amlodipine, perindopril, indapamide, the ankle edema was 0, literally 0, because of the synergism. Okay, in fact, amlodipine acts in your lungs to bring down the dry cough associated with the ACE inhibitors. Again, there is a paper on that which is proven. So that is, ankle edema can be neutralized with indapamide. Hyperuricemia not seen with indapamide. Again, there is evidence. So for both your questions, the answer would be perindopril indapamide combination with amlodipine plus or minus SOS. Okay, and the lowest BP you are asking, usually we do not bring down. The guidelines have clearly showed less than 120 you should not bring it down. Less than 120 systolic only. They are not mentioned about the diastolic part. Systolic, do not bring it down below 120. That's the recommendation.
Thank you, sir.
Thank you, sir. Now, thank you for your presentation. Nice presentation. I'll request you'll be.
Thank you. It was a nice presentation and the beginning of the day 3 program. And Srinivas is very kind to come so far and participate. He is a, I'll tell, the promising, uprising faculty of the country. And so many queries he has taken, and he can take still more, but we don't have adequate time for this session. And in fact, he is the man who does maximum clinical trials and best of the drugs he has tried. That's why Professor Trupti Shwai was invited to chair his session because it was preponed. Madam will chair the next session. I request the chairpersons to felicitate Dr. Srinivas Murthy with a bouquet and the Uttariya.
Subhanshu, our next.
So, so it is time to invite Professor Subhranshu Patra, who is the professor in medicine and vice principal, Kalinga Institute of Medical Science of KIT deemed University, Bhubaneswar. He has more than 80 publications in various national and international journals. He has trained medical officers in various government-run programs like RNTCP, PPTCT, and NVVD CP. So, in addition to all these, he has been a student of ours. So, we are very proud to see him here. I think he will be doing justice to this topic, the anoxic encephalopathies, hanging and drowning. Thank you, Dr. Subhranshu. You can start with your presentation.
Thank you, sir, for your kind words. Respected chairpersons, my teachers, my seniors, and dear colleagues. So I've been given by a topic anoxic encephalopathy in relation to hanging and drowning. That means we'll be covering about the anoxic encephalopathy that happens in hanging and drowning. Before that, we must know what is anoxic encephalopathy. We will be covering this topic under these headings. So if you'll see, anoxic encephalopathy is a complete interruption of supply of oxygen due to varied causes, leading to disturbed functioning of brain immediately and may lead to irreversible damage quickly unless intervened at an earliest. The process, most of the cases, because it has been studied in post-cardiac arrest most probably, so most of the studies are done. So it's a process begins with cessation of cerebral blood flow, leading to destructive or degenerative changes due to high metabolic demand. So the different literatures, they describe this term, they synonymously, interchangeably, these words are written: anoxic brain injury, hypoxic ischemic encephalopathy, hypoxic ischemic brain injury. So this picture depicts the different hypoxic ischemic and encephalopathy. If we come to the background, the most common cause of hypoxic ischemic and encephalopathy is in adults is mostly cardiac arrest, which is mostly secondary to myocardial or cardiac arrhythmia. Based on different studies across globes, the incidence of cardiac arrest is around 50 to 100, because we are just discussing about anoxic encephalopathy. Asphyxia comes next, which encompasses hanging, strangulation, suffocation, choking, and drowning, which is our topic today. The asphyxiation suicide rate has increased by 45.7% because the Western study between 2005 to 2014. According to World Health Organization, drowning is the third leading cause of unintentional injury and death worldwide. So we'll go to the Indian demographic in suicide. In India, around 1.5 lakhs were recorded in 2020, which was around 10,000 more than that of recorded in 2019. Most of them were, the male preponderance was there, and the age group was between 21 to 30, that means young people. Apart from the other modes, drowning is also a serious and neglected health problem in India, in our scenario. Maximum number of drowning deaths occur in urban. You will see the graph, the hanging is the number one and the drowning is in almost third. You will just go through the etiology. Most common is the hypoxic anoxic encephalopathy of cardiac arrest. The second one is a respiratory failure, mostly the respiratory tract compression in the form of tracheal compression, obstruction, drowning, hanging, aspiration of gastric contents. The difference between drowning and hanging mostly is that drowning, first there is suffocation, the anoxia, but in hanging it is mostly the ischemia leading to anoxia in the first phase. Later on the pathophysiology is almost same if that continues. Then respiratory muscle weakness, reduced oxygen carriage, and histotoxicity, that we know. If we go to the pathophysiology, there is a two-hit model. Any anoxia, two-hit model, the primary injury because of anoxia, there will be immediate cessation of cerebral blood flow in case of cardiac arrest. In other cases, oxygen because of less availability, followed by a secondary injury of hypoxic ischemic brain injury in hours to days. Mostly in cardiac arrest, or else following anoxia, when the reperfusion occurs, the injuries are known as secondary injuries. So primary injury mostly immediate cessation of cerebral oxygen delivery, and the secondary injury is the post-resuscitation or when the resumption of spontaneous circulation occurs. If we will go to the primary injury, the cessation of cerebral drug flow, when there is decrease, there is neuronal ischemia and cell death because of neuroglycopenia and metabolic crisis, ATP depletion giving rise to cessation in the energy-dependent ion channel function. So these three boxes, intracellular sodium accumulation giving rise to cytotoxic edema, because these are the future targets to manage anoxic encephalopathy. Anaerobic metabolism, cerebral leading to cerebral lactate, giving rise to intracellular acidosis, giving rise to cellular edema. Then a release of many excitotoxins stimulating NMDA receptor, thereby increasing the calcium influx. This calcium influx activates lytic enzymes and mitochondrial dysfunction, so vicious cycle continues. So finally, excitatory neurotransmitter activates the lipases and proteases, which leads to apoptosis. So the death is cellular death. Is first phase is necrosis, followed, and the second is mostly apoptosis. You will see this picture. That picture depicts about the pathophysiology. You will go to the primary hypoxic brain injury, which occurs in the primary phase. If you will see the mechanism of anoxic depolarization, because of the anoxia, the cellular changes occurs, increase intracellular sodium, intracellular calcium, activating calcium-dependent processes, ATP depletion giving rise to lactic acidosis, glutamate release stimulating the excitatory enzymes and the cascade pathway giving rise to lipase, activation of lipases, and free radical formation and nitric oxide production. In total, they cause hypoxic brain injury. If it will not be halted, then probably it will give rise to anoxia, tissue necrosis within few minutes, around 3 to 4 minutes. Now this is the insult, just graphical into primary energy failure occurs in minutes, which I've described. So this is the area, the therapeutic window where you can intervene. That is the immediate cause of necrotic cell death. If you will not intervene, probably irreversible damage will occur. After that, the secondary phase, after the reperfusion starts, then it will be aggravated. This is a delayed thing, occurs between hours to days, 6 to 24 hours, and giving rise to apoptotic cell death. So the secondary injury which occurs after reperfusion, either because of resuscitation or because of reflow of the blood. So immediately after returning of the spontaneous circulation, ROSC, the short-lived period there will be hypermia, the increased blood flow will be there, and giving rise to delivering more oxygen to the tissues, thereby the oxygen radical production will be more, causing vicious injury. There will be global and multiple hypoperfusion, because when the hypermia will be there, the cellular edema will increase, thereby it will compromise. So there will be no reflow phenomenon. So first a hypermia followed by a no reflow phenomenon. So the blood flow will be restricted to almost 30 to 50% as compared to the hyperemic phase. So these are the secondary brain injury: microvascular dysfunction, cerebral edema, anemia, impaired autoregulation inside the cerebral system, carbon dioxide, either hypocapnia or hypercapnia. Hyperoxia, first phase, giving rise to more free oxygen radical production, and hypothermia because of the loss of function of the temperature regulation center because of during that in anoxic phase. So we'll come to the clinical feature: mild sustained hypoxia, there will be cognitive impairment, confusional state, delirium. When the period lasts for few more seconds, it becomes syncope or acute generalized seizure activity. When it becomes sustained, the coma with residual neurological deficit in the form of dementia, vegetative state, brain death, seizure activity may prolong. And the most compromised areas will be watershed infarction if it is a vascular. If it is primarily hypoxic, then globally the tissues which are having high metabolic activity will be involved fast. So mostly the cerebrum, cerebellum, and the active portion of the basal ganglia will be involved. And there will be post-anoxic demyelination, which is a late complication. So these are the summarization of clinical feature: headache, confusion, difficulty. Almost all parts of the brain may be involved. First, the tissues which are active, they will be involved, their loss of function, followed by the other parts if the anoxic process continues. So if we go to the post-hypoxic late sequelae, if the anoxic procedure continues and we don't intervene, then probably the complications will be the late phase in the form of PRES, retrograde amnesia, Korsakoff psychosis, neuropsychiatric manifestation. There will be spasticity, there will be intentional myoclonus, and delayed white matter injury, that is post-anoxic leukoencephalopathy. The post-anoxic leukoencephalopathy is known as Grinker's myelinopathy, very rare, but it has been described in the literature. With this, we will go for the evaluation, because evaluation is important and early intervention is essential. So the clinical history is the primary thing, followed by, because there are some confounding factors like when there is urea, there is renal failure, hepatic failure, that may also mask. They may involve the metabolic encephalopathy. So during evaluation, there should be thorough investigation about the confounding factors in the form of metabolic abnormality, serum electrolyte, ammonia, blood gas analysis, hemoglobins to be done. Then the main thing is that toxins may be causing all those things. So toxic or urinary toxin screening should be done, though that doesn't exclude all toxin ingestion, but routinely it should be done where there is the incidence is high. In case of cardiac arrest, hypoxia, post-cardiac hyperexia, we must go for cardiac biomarkers. Just we'll see some pictures, NCGT. When the first, there will be, if you go for NCGT brain, there is diffuse loss of gray-white matter differentiation because of the anoxic tissue will have cellular edema, so the gray matter becomes hypodense. So there will be loss of white and gray matter difference. This is one of the signs. The choroid nucleus, the basal ganglia, some part of the cerebellum and the gray matter, they are most active cells. So the cells will be involved fast. There will be cytotoxic edema and the cells will be hypodense because of cytotoxic edema and cellular edema. So low density of choroid nucleus, lentiform nucleus. Then if this condition progresses, then because active cells which are involved fast, there will be necrosis. So this necrosis will be seen in the areas where the higher high active cells are there, mostly the cortex, so there will be laminar necrosis that is mostly described as, and adding to that basal ganglia may also be involved. But mostly the gray matter necrosis that is laminar in pattern. The cortical layer 3rd, 4th, 5th have higher metabolic demands, so there will be cortical laminar necrosis, and there will be gyriform high attenuation because of the associated hemorrhage, or there may be accumulation of denatured protein in dying cell. That will be the later part. So when there is necrosis starts. So cerebral edema leading to decreased parenchymal attenuation, what I have described. When there is cerebral edema, the venous congestion will be there. When the venous congestion will be there, the venous engorgement inside the sulci will be there. That will give you a picture in CT scan that is like pseudo subarachnoid hemorrhage pattern. So one is white matter, gray matter differences will not be there. These are the waterside areas which will be affected if it is hypoxia is because of the primary is cardiovascular. So the compromised areas will be this. So we'll go to the MRI finding because this in the beginning phase the cytotoxic edema will be less. So MRI cannot differentiate in the very early phase, or the CT scan cannot differentiate. So in the first phase there will be diffusion restriction, that is DWI, diffusion weight image special variety MRI, where the diffusion restriction of the water particles inside the cell will be there. More the restriction, more will be the diffuse restriction intensity. So DWI will be giving a very good picture in the early phase or very acute phase of cytotoxic edema or anoxia. Followed by the T2 MRI, when the fluid picture of necrosis or some cavitation will come, either the T2, T1 or the CT scan can disclose, then it can be seen in the radial image. If you see the axial T1 weighted MRI image, bilateral high density cortex of lower of the occipital pole, quite late when the necrosis already started, so it is seen in axial T1. If you see the increased signal in basal ganglia, the arrow depicts, because here the cytotoxic edema is more, so more of cytotoxic edema, so T2 is a ideal investigation procedure to detect. The next one will be evaluation. The main purpose is that early age will intervene, the necrosis can be prevented, the anoxia can be prevented, the prognosis will be better. So the patient is comatose, so we need to know the brain activity. The continuous EEG can be used for prognostication of brain injury severity, diagnosis, titration, treatment, or titration for treatment of seizure activity. So EEG has been used as a prognosticate severity. There are certain criteria in the EEG which are known as burst suppression of EEG activity, isoelectric pattern, profound background attenuation, and loss of reactivity to stimulation. These are bad prognostic signs. If you see this is a normal EEG, if you see this is burst suppression, one person burst, the other part is suppression. The third one is somatosensory evoked potential. These are electric responses in the CNS due to somatosensory stimulation. The bilateral absence of N20 component after medial nerve stimulation, the wrist is seen in the first week of injury. If bilateral absence is there in anoxic patient, probably the prognosis is very poor. Now this in the second picture, the negative wave is N20. In the first picture, this is the abnormal. The second picture is normal. So in the absence of this negative wave in the first picture. Now there are certain other biochemical parameters which can give some added clue that is neuron specific anoles, which is a marker of injury to neuron. And if the level is more than 30 microgram per liter, then we can predict a poor prognosis. In addition to that, for research purpose, different studies show that tau protein and glial fibrillary acidic protein can give the prognosis can be decided in the very beginning phase if the parameters are high. These are studies which show that these parameters, these are future prospects. Now if we come to the management, there are two arms. One is emergent medical stabilization, and the other one is seizure and myoclonus management, which cannot be, sometimes it is not visible to outside. Though the first thing is the therapeutic hypothermia, the intracranial pressure management, general intensive care, and prognostication. As we know, the normal thing is that if the underlying disease should be treated, stabilization of hemodynamics, correction of metabolic parameters, initiating antibiotics in case of sepsis, and reversal of toxic injection or drug overdose. Emergency medical stabilization, we know the ABC. Then we will come to the second part, the seizure and myoclonic management, because the seizure will increase the activity of the whatever brain cells are there, compromised brain cell will have further anoxia, the vicious cycle will continue. So seizure management is estimated that the incidence of non-convulsive status epilepticus, which is not almost visible to outside, is as high as 20% in hypoxic ischemic encephalopathy following an anoxic event. So there is insufficient evidence to recommend prophylactic use of anti-epileptic drugs, but it is reasonable to use less sedating agents. Will continue, sir. So less sedating agents or those with short half-life like midazolam, levetiracetam and phosphotate, because they are non-sedative, short-acting, so their activity will go very soon, so we can assess the neurological function very soon. Then these are the promising things. Targeted temperature management. Everything is that because of the seizure, because of chemical liberated, there will be hypothermia after these things. Once there is hypothermia or once there is some muscular activity, the metabolic activity of the cells will increase, further anoxia, and the vicious cycle will continue. So the targeted temperature management is around, the body has to be kept after this anoxia. When attached to hospital, the target temperature will be around 36 degrees centigrade. So before that, we have to go for a therapeutic hypothermia. The person will be kept around 32 to 34 degrees centigrade with an average of 33, so that the metabolic activity can be lowered, so tissue requirement will be less, so the vicious cycle can be halted there. And after 24 hours, gradually rewarming will be done with an increment of 0.3 to 0.5 degrees centigrade per hour of power hours. Though by lowering the body temperature, we can inhibit apoptosis, excitotoxicity, mitochondrial dysfunction, and decrease cerebral metabolic rate. We can the blood-brain barrier can be stabilized, and thereby the cerebral edema can be reduced.
Quickly
Yes,
wind up because time is already over.
So these are the papers, but the only drawback is that in hypothermia we will have severing, so we have to take care of severing. Hyperbaric oxygen therapy is needed because if you give more hyperbaric oxygen, the oxygen will be dissolved in plasma, so even the hemoglobin capacity is not that much also the tissues can get. Now the post-hypoxic pharmacology, we can give barbiturates, we can antagonize glutamate receptors, we can give calcium channel blockers, thereby we can inhibit the entry of calcium. Role of idravin is experimental. Now another one is autologous bone marrow mononuclear cell transplanted. These are emerging thing. Then the prognostication following therapy, no pupillar or corneal reflex at more than 72 hours, bilateral absent N20 SSEP, highly malignant EEG for more than 24 hours, and NSC, NOLAS is more than 60 microgram per liter at 40 or 72 hours. Status myoclonus, a diffuse and extreme anoxic injury in CTMR. These are bad prognostic signs. Sir, just same with only special hypoxia. And hanging. Everything is that with hanging, but it's a suspension, lethal suspension of a person by a ligature. It's asphyxia secondary to compression or constriction of neck structures. So the blood, in contrary to belief, everybody thinks that the airway will be compressed. It is not like that. When the pressure is less, the veins draining blood from the brain will be compressed, so there will be stagnant hypoxia. Followed by, if the pressure is more, the carotid artery will be compressed, there will be tissue hypoxia, arterial hypoxia. After that, only the airway will be compressed. So near hanging, if you'll see the studies, almost all studies of hanging suggestive of hypoxic encephalopathy. Now drowning also the same. Here, drowning remains the significant worldwide public health problem. It ranks about third unintentional injury death. The varieties of drowning is dry, wet, cold, what will not go into detail. But the thing is that in pathophysiology, involuntary grasp, when somebody is drowned, involuntary grasp, the laryngeal spasm will be there, oxygen cannot enter into. After that, there will be anoxia. Once there will be anoxia, the patient will be unconscious, there will be relaxation, the water will re-enter and it will go to lungs, further aspiration, further hypoxia, further lung injury. So the vicious cycle will continue. Treatment is same with some special attention to be given to the primary causes.
So quickly wind up.
Brain-oriented intensive care. The tidal volume should be less than 6 ml per kg, PEEP sufficient to inflate, oxygen saturation to be maintained between 94 to 98% so that ROAC can be taken into consideration, hemodynamic, seizure management, electrolyte should be taken and target temperature management. So to conclude, despite advances in medical service, brain injury remains the main cause of disability in anoxic encephalopathy. As complications are common, early intervention is of crucial importance, although a great amount of medical resources are required. The results of research in various neuroprotective strategies have been discouraging, with the exception of hypothermia, target temperature management, which seems to be successful, worthwhile, as well as therapies focus on seizures. So effort must be placed on creating new hospital protocols that emphasize the importance of achieving mild hypothermia within the first few hours so that the further necrosis can be prevented. Thank you. These are my references.
So we can allow one question.
Professor Subhanshu. Yeah.
Yes.
Regarding anoxic brain injury, first treatment is ABC, airway, breathing and circulation. That should be highlighted. How can we, the audience must know, before starting, cold saline to maintain hypothermia, the simple way is put the patient at least airway. If airway is not available, it should be any other measure where 100% oxygen can be given, and positioning of the patient. By that, we will supply the enormous oxygen to the brain. Simple, because patient is living at that time. It's not dead. Okay. And hypothermia, etc. will come quite late. So airway, breathing, circulation. How can you? I have seen a patient hanging, and we almost in GCS3 people dilated. We put in a ventilator for 7 days. After 7 days, you will able to revive the patient. So only giving airway, breathing, circulation.
I've already described that anywhere in the management of hanging or drowning, the primary treatment, the intensive treatment has to be done fast. I have already told. In addition to that, these are extra treatments.
Because if he goes into details, it will
Yes.
be too much to cover here. Thank you for asking the question. Any more question?
Sir.
Sir.
This is a very bad condition, particularly in ICUs. And you tell the prognostic indicators
Sir.
for hypoxic encephalopathy for the postgraduate students.
Sir. Which one, sir? I told.
Repeat the prognostic indicator. Repeat the prognostic indicators. Don't show the slide, only repeat.
Yes. So in anoxic or any other thing, sir? Hypoxic encephalopathy, bilateral pupillary, absence of bilateral pupillary reflex, brainstem reflexes, then sensory somatic sensory nerve evokes potential, the absence of bilateral absence of negative N20 wave, then enolase enzyme, neuron specific enolase enzyme should be more than 33 per liter, but if it is more than 24-40 hours, it should be around 78. Then Sir, I should say all these things have to be, because the first thing is that first you have to go for imaging. These are all corroborative. These are all corroborative things. The first thing is that evidence-based medicine. Evidence-based medicine means we do not know what is the time of anoxia and when the patient reached. So once we will know that the patient, there is not much of injury. So for that we have to go for DWI imaging. And if for PG student, it is the clinical picture. Clinical picture, if you will go for reflexes or give deep painful stimuli, no response, extensor, flexor response, then respond to deep painful stimuli, as our motor response, that only applies. If no response to deep painful stimuli, that means the prognosis is grave clinically. If the extensor, little bit better. If responsive flexor, still little bit better. So in this way. That is clinical. And pupillary reflex, oculocephalic reflex, those are the brainstem reflexes which we can, from that clinical, we can know how grave is the prognosis.
Thank you, Dr. Patra.
Sir.
I want to tell something that it can have two parts. One is at the site of incident. Suppose a boat capsized in the Chilka Lake or in the Hirakud water resort. So what the people around, what they will do immediately. And then once the patient brought to the hospital, then what you extensively told, that is the role in the hospital. So these things can be divided into two parts.
Maximum catastrophe happen during carrying the patient from the incident point. They do not know how to carry the patient. I've seen many, one hanging at Jacuz 2 years back, one hanging of a great reporter from Mahanadi. Okay, so carrying the patient from the incident side, that the public or the,
Co-passengers.
yes, co-passenger and the policeman, rescue team, they must not listen
So-
about BLS.
Sir, what we are discussing here, we are discussing about the anoxic encephalopathy component of hanging and drowning. So we are discussing about that.
Thank you, Dr. Patra, for your this exhaustive lecture. Thank you very much.
And it is a new topic.
Yes. So thank you very much. So nutrition in ICU patients is always a challenge, and we are having with us. Just Dr. Patra, please.
Wait. प्रभात BLS को छाड़ियो नहीं से जोर से छाड़ियो नहीं BLS.
So again, coming to the point, in fact, nutrition in ICU patients is always a challenge, and every day we are facing this challenge. And to deal with this, today we are having great speaker, Dr. Pragyan Kumar Rautray. He is a critical care specialist and heading the Department of Critical Care in Care Hospital, Bhubaneswar. I request Dr. Rautray to kindly deliver his lecture.
Very good morning. Thank you, chairpersons, for nice introduction. Thank you, Padhiyar sir and Jayant Panda sir, for inviting me here. Respected seniors, colleagues, beloved teachers, and juniors. It gives me immense proud to stand here and give this lecture on parenteral nutrition. So being here for last 10 years or so back, did my MBBS and MD over here, so it's a proud privilege. So topic today I'm going to discuss is parenteral nutrition in ICU. So topic is really vast. So, and we heard two very diverse topics before, and they were fantastic. So I would like to justify my stand over here. So I would like to answer 5 basic fundamental questions, and other things we can take over during question answer session. Question number 1, should a critically ill patient be fed? How many of you think you should be fed? It's a very easy question. All of you think, great, fantastic. If yes, when would you initiate feeding? We'll answer that. How much would you feed? What type of nutrition, enteral or parenteral? And nutrition in specialized situations. We'll go one by one. So coming to basic pathophysiology, as we eat, glucose goes in. It's alma mater, we need glucose. There occurs glycogenesis, there occurs protein synthesis, there occurs lipogenesis with the hormonal array of increased insulin and the counter-regulatory hormone glucagon. If somebody goes for starvation, like a lot of people are going for intermittent starvation, or they are marooned on an island or something like that, there occurs decrease in glucose, decrease insulin, increased glucagon, that causes glycogenolysis, causing more glucose formation, gluconeogenesis by protein breakdown, there occurs catabolism, and hence what happens, our basal metabolic rate goes down. So it's a protective phenomenon that our BMR goes down to accommodate less nutrition and less glucose. And there occurs hypolysis, and it in turn does all its effects. But critical illness is a totally different array. There occurs cytokine release, there occurs ischemia, there occurs hyperperfusion, there occurs lot of new hormonal assays like increased glucagon, increased insulin, increased ACTH, cortisol, catabolism. So all these hormones along with cytokines and a hyperdynamic circulatory states cause something different than starvation. So let us come into the picture. Somebody with a stress of critical care and as well as starvation together. Like somebody in ICU with a severe sepsis, septic shock, as well as we are not giving him feed. What happens? Same thing happens. No more glucose in the body, but this time there is increase in insulin, increased glucagon, increase in all the counter-regulatory hormone. So in turn, what happens? Our BMR, basal metabolic rate, increases. So in starvation, it was decreasing, but here it is high. So there is increased demand of food, nutrition over here. Glycogenolysis continues, gluconeogenesis continues, as well as lipolysis decreases. So what happens in the turn? We are at a really cachectic phase with increased catabolism. So there are different phases of critical illness. Day 1 to acute phase, or we tell it as early period. Day 3-7, late period, or there's a late phase. So in early period, it's defined by metabolic instability and severe increase in catabolism. We call it as ebb phase. In late period, it is defined by a significant muscle wasting and a stabilization of the metabolic disturbances. But more important is post-acute phase after 7 days or so, where occurs improvement in rehabilitation or persistent inflammatory and catabolic state with prolonged hospitalization. We need nutrition. The importance of nutrition lies in all the phases, which we will discuss one by one. So no wonder malnutrition diagnosed by nutrition assessment was independently associated with increased ICU length of stay, ICU readmission, and risk of hospital mortality. So more feeding you are giving to the patient, you are decreasing length of stay, you are decreasing mortality. All the papers have proven that. So malnutrition is independently associated with poor clinical outcome in ICU. So definitely nutrition is required in ICU. So if you ask about nutritional supplementation, we divide into enteral nutrition and parenteral nutrition. Combinedly, we call it as medical nutrition therapy. So what does medical nutrition therapy do? It addresses previous and induced malnutrition. It takes care of mild to moderate to severe catabolism. It takes care of insulin resistance and insulin glucagon ratio reversal. It takes care of fuel utilization. It takes care of protein catabolism. It takes care of intestinal bacterial translocation. All these things can be taken care of medical nutrition therapy. So question number 1 is answered. All of us are convinced here that yes, critically ill patient should be fed. Question number 2. When would you initiate feeding? That is a very controversial topic. There all of us falter. Not we, across the world, everywhere we delay a little bit of starting nutrition because we say that patient is very sick, patient is a NORAD, patient is vasopressor, patient might die tomorrow. So many things. So early versus late feeding is a big debate in last decade. So why they say that, what is the fear of early enteral feeding? Absence of bowel signs, frequency of gastroparesis, potential of aspiration, potential for anastomotic deficiency in surgical patients, like you have done intestinal surgery and you are afraid that it may descend. But advantages are huge. Better nutrition, less infectious complications. So after bowel surgery, there is a very beautiful study which was published way back in 2001. They have said that if you start early nutrition within 24 hours, you decrease anastomic deficiency, you decrease infection, you decrease pneumonia, you decrease intraabdominal abscess, you decrease death. Only thing, what you incur only little bit of more vomiting. So wider meta-analysis early versus late, they have shown that if you start early, there is definitely reduction in infection, there is definitely reduction in length of stay. But mortality benefit has not been proven. But decreasing stay and decreasing infection also adds a lot to morbidity of the patient. So this is a very beautiful paper published in the last decade. They proved that early nutrition is definitely associated with reduced mortality. And neither feeding route, like if you give oral, enteral or parenteral, or non-early calorie intake was associated with any mortality. So this proves that early nutrition is definitely required. And a lot of guidelines have incurred in their guidelines that what is the definition of early enteral nutrition. So 24 to 48 hours after admission by Canadian Critical Care Guidelines, ASPEN's American Society of Parenteral and Enteral Nutrition, which I will be quoting time and again, 24 to 72 hours, and Australian guidance definitely 24 hours. So we should be starting feeding at least within 72 hours of admission. All of us agree, all guidelines agree with that, sooner the better. But of course, patient should be relatively hemodynamically stable. He might not be, a huge amount of vasopression might be a contraindicating factor, but apart from that, smaller doses can be started. So question number 3 is answered. Early feeding is definitely required, enteral or parenteral, that we will be discussing. How much would you feed? So we have a lot of things to feed. Like we have to take care of calories, we have to take care of carbohydrates, proteins, fats, water, electrolytes, and some vitamins and micronutrients. So way back in 2003, there's a beautiful study by John Hopkins that opened eyes, and after that a lot of guidelines came into picture. ACCP had recommended at that time that we should be giving 25 kilocalorie per kg per day, and as you can see, majority of the 187 patients taken into the study are underfed. You can see across 20-25 days also they gave them feeding roughly 50% of what has been recommended by ACCP at that time. So another study came out, they tried to do indirect calorimetry in a medical ICU. They found out that roughly 1/3 of the patients are underfed, 1/3 are okay fed, and 1/3 are overfed. That is also interesting. But how do we do indirect calorimetry? There are some interesting equations like Harris-Benedict equations or irritant-Jonas equations. These are the equations are discussed in every conference over here, and everywhere you go, they'll try to depict it. But in my practice, incurring this equation to find out what calorie are going to the patient is like finding the wire in a Calcutta street. No, which wire go to which street? So that's a difficult. No, so equations are funny, but practicality is this actually. So how to make sure that you are going to what amount of feeding you are going to give to your patient? So how to assess calorie requirement? So this is an Indian guideline published in 2018 by Indian Journal of Critical Care Medicine. They shared that nutritional status of Indian malnourished patients can be easily assessed by systemic global assessment. There's a scaling parameter with some of the rough, like your weight, height, your lab parameters, you can find out what should be whether you are malnourished or not. It should be done by well-qualified and trained nutritionists. That is a luxury at times, but definitely if a physician takes interest, he can also be part of it. They have said that nutritionist to critically ill patient ratio should be 1:25. Again, it is a luxury in some centers, but again, depends on your individual interest. CT or ultrasound can be used to assess the lean muscle mass. So coming to the guideline which I am going to tell again and again, this is a guideline by ASPEN, American Society of Parenteral and Enteral Nutrition. So energy intake impact clinical outcome. Whether energy intake impact clinical outcome? Yes. So we should suggest feeding between 12 and 25 kilocalorie per kg in the first 7 to 10 days. So start feeding early within 24 to 72 hours. Try to achieve 25 kilocalorie per kg within a span of 7 to 10 days. That's what new ASPEN guidelines of 2021 have said. Coming to protein, yes, the protein target is 1.2 to 2 gram per kg per day. Try to achieve within 7 days. In a hypercatabolic state like somebody with burn, trauma or pancreatitis, you can target a little bit more. But standard is 1.2 to 2 gram per kg of protein, and calories 25 kilocalorie per kg. Overfeeding, yes, this is a problem. At times we can a little bit be jealously feeding more. It can cause hyperglycemia, it can cause excess CO2 production, it can cause electrolyte problem, and it can cause hypertriglyceridemia. If you are giving TPN for longer duration, it can cause azotemia as well. So you have to take care of all these things if in some cases you are going to give feeding a little bit in the higher part. So question number 3 answered, how much feeding should be given? Calories, yes, 25 to 30 kilocalorie per kg, 25 is a target, 30 in a very, very hypercatabolic patients like a burn injury or trauma patients. Protein 1.2 to 2 gram per kg. Now coming to question number 4, what type of nutrition, enteral or parenteral? So this is a way back study, 2 decades back. They have done the study over rats actually. They have compared oral versus TPN, oral TPN, enteral TPN versus IV TPN. And all the studies have proven that oral is little bit better at par with enteral, because TPN is little bit bad in terms of immunosuppressiveness, in terms of gut-associated lymphoid tissue exaggeration, in terms of bacterial translocation. So they have proved that oral nutrition little bit or almost equal to enteral nutrition, they are little bit better to parenteral nutrition in rat model. What is the problem with parenteral nutrition? Problem is not with the nutrition, problem is the device with which we are giving. What we are giving? We are giving through central line. So central line, interesting part is that, so here we have a central line going into the vein. There is a skin colonization. There is every chance that the skin colonizing bacteria will enter into your bloodstream through the central line. So central line associated bloodstream infection becomes a real problem when you are giving TPN. And TPN is consisting of some amount of calories in terms of carbohydrate, protein and lipids, which are also bacterial carrier. So TPN on a long run at times exaggerates or increases your chances of central line associated bloodstream infection. You have to take care of that. Coming to, there's a very beautiful study. They have found parenteral nutrition versus enteral nutrition. There's 30 RCTs. It's a meta-analysis. They have found out When you compare parenteral nutrition with enteral nutrition, there is little bit increase in infective complication in parenteral nutrition, increase in non-infective complication in terms of pneumothorax, etc. in parenteral nutrition. Hospital length of stay is little bit more than parenteral nutrition. Only disadvantage of enteral nutrition is there is little bit increase in diarrhea. So unless you have a bowel obstruction or a bad paralytic ileus or intestinal ischemia or a severe clinical shock, gut is a good mode. Enteral nutrition is preferable. The disadvantages are diarrhea, or could be RT tube malposition or blocked tubes. But there are a lot of complication with total parenteral nutrition in terms of pneumothorax, hydrothorax, arterial puncture, hyperglycemia, hypoglycemia, fatty liver in the long run. So complications a little bit more in TPN. So depend on the center you are working, rather saying that. So TPN, if you can take care of all these complications, TPN is as good as enteral nutrition, apart from the cost factor in settings like ours. So coming to my aspirin guideline of 2021, so what is better? Parenteral nutrition versus enteral nutrition as the primary feeding modality in the first week of critical illness to impact clinical outcome. So the recommendations are very, very strong. This is one of the strong recommendations. There was no significant difference in clinical outcome between TPN versus enteral nutrition, because similar energy intake provided as parenteral nutrition is not superior to enteral nutrition, and no difference in harm were identified. We recommend that either PN or EN is acceptable. So it means that within 7 days, if you can start enteral nutrition or parenteral nutrition and you take care of some of the complications, both are equally clinically good, as well as in terms of side effect. If you can take care of smaller complications, both are equally good. You can start with EN or you can start with PN, both are equally good. Coming to our scenario, parenteral nutrition, enteral nutrition seems to be more affordable, we can go for that. What is supplemental nutrition? Supplemental nutrition is something like enteral nutrition and parenteral nutrition combination. They said that if you are unable to achieve the calorie requirement within enteral nutrition in the coming 7 days, go for this supplementary nutrition. There's a very beautiful paper that came way back in Lancet actually, which said that if you're unable to achieve calorie requirement with enteral nutrition within 7 days, although patient is accepting but not accepting in a greater way, you should start some amount of parenteral nutrition. That is why the studies came out where they find add a IV parenteral nutrition along with enteral nutrition. But the recent guidelines as per the ASPEN 2021, they have suggested that SPN as compared with no SPN, that is supplemental parenteral nutrition as compared with no supplemental parenteral nutrition during first week of critical illness, does it impact clinical outcomes? They say no. Based on finding of no clinically important benefit in providing supplemental parenteral nutrition early in ICU admission, we recommend not initiating supplemental parenteral nutrition within first 7 days of ICU admission. So if you're starting an enteral feeding, slowly try to achieve your target of 25 kilocalorie per kg or 1.2 gram per kg of protein within a span of 7 days. No need to hurry, no need to start a IV parenteral nutrition along with your enteral nutrition. That makes it very clear. The question number 4 is answered. What type of nutrition? Enteral preferred. If you are unable to achieve through enteral, go for parenteral because both have equal benefit. Nutrition in specialized situation, immunonutrition, that's a very, very big controversial topic. In ASPEN 2021, they have said that mixed oil IV lipid emulsions versus 100% soybean oil emulsions, both are almost equal. We can start wherever parenteral nutrition is indicated. Coming to fish oil containing IV lipid emulsions as compared to non-fish oil containing IV lipid emulsion, both are almost equal. So any type of lipid emulsion can be equal, but on all those patients where parenteral nutrition is indicated, where patient is not accepting enteral. Glutamate nowadays not indicated, only in cases of burn and trauma. Arginine no, fish oils I have discussed. Nutrition in advanced lung disease, previously they used to say that you have to decrease carbohydrate intake so that your
Dr. your time is over.
Yes,
please
sir,
wind up.
I'll conclude, sir. So immunonutrition, a lot of studies have done, there is not much benefit. Wherever there is a active in enteral nutrition intake of less than 700 ml, you can think of doing something, otherwise continue with your normal feeding. So last question answered. I think a gentle thought about nutrition every day during your rounds can bring a huge change in your practice. Thank you so much. I would love to take up any questions.
Thank you. Thank you, Dr. Rautrai, for giving justice to the topic. Now we can have 1 or 2 questions.
Most important problem for oral nutrition is if there is toxic induced gastroparesis. That is the most important problem actually in the initial hours. Gastroparesis.
Gastroparesis, then we have to find out the cause, or Actually, if you are doing enteral nutrition, we are telling rice tube feeding the sense. So gastroparesis, we have to have some definition for gastroparesis. So as per Aspen guideline, they say that you have to, whenever there is a RT residual of 500 ml, below 500 ml, you should continue RT feed, adding some prokinetic drugs. As per Indian guidelines, that is 300 ml. So even if you are getting RT as per 300 ml, you should continue some amount of trophic feed. Some amount of feed should continue. More than 500 ml, yes, you should stop. You should find out other cause or wait for 24 hours.
Yes, yes.
Sir. Yes, and yeah, and for the meanwhile, you can change it with trophic feeding, like 20 ml per hour. That is also trophic feeding is also indicated, but some feeding should be given.
Or skip 1-2 meals in between, or make a difference,
Sure.
or give some prokinetics. So it's all, or check potassium level or other level to know the cause of, etc. So my question is something on refeeding syndrome. If you'll block feeding for 7 days, don't give it, after 7 days you'll give bolus of feeding. So there is chance of refeeding syndrome. So we can highlight on that refeeding syndrome, one, and the mass must know, because a lot of them are PG students and working in a small set of hospitals like sub-divisional hospital or district headquarter hospital. If a 50 kg person comes with anything, let it be sepsis or anything in disease, admitted to hospital, and his enteral part is okay, how can they start feeding? Is a 50 kg person. So if 20 kilocalorie, then it comes around 1000 kilocalorie. So we can break like that. 1000 kilocalorie, 50% come from carbohydrate. So each gram of carbohydrate gives 4 kilocalorie. So 500 kilocalorie will come from 125 carbohydrate. Then, 30% from protein. Then each gram protein 4 kilocalorie. So 300 kilocalorie comes around 75 gram of protein. So that comes around 1 to 1.5 kg per. So 75 gram protein. Then 20% from fat. So each gram of fat gives 9 kilocalorie. So 200 kilocalorie, the person has to take 20 gram of fat. So very simple, 20 gram of ghee or 25 gram of protein, which is calculated, and 125 gram of carbohydrate. Mix it, divide the doses, give parenteral. Very simple formula. So that should be practical take-off message, and something on refeeding syndrome.
Thank you, sir. So refeeding syndrome is very important. Like somebody starving for a longer duration, if you are immediately starting feeding, there occurs refeeding syndrome. So how to prevent it? So in enteral feeding, it is a little bit rare to get, but parenteral nutrition, it is because we are achieving calorie immediately. Like somebody who is starting enteral feeding, you will achieve slowly. You will start 100 ml 3 hourly, 200 3 hourly. So refeeding syndrome is little bit rare. But when you are starting parenteral nutrition in somebody who has been starving for last 7 days, refeeding syndrome is a problem. So how to stop it? We know the electrolyte arrays actually. We have to check magnesium, phosphorus, sodium, potassium intermittently. We have to find out what is happening with the patient. So it's a different chapter per se.
Thank you,
sir.
Thank you, Dr. Rao,
Thank you,
for
sir.
your
Thank
elaboration.
Magnesium is a myth. Thank you, sir.
Magnesium and phosphate.
Phosphorus.
That can be given in practically enema.
That way, sir, I ask and also answers. Thank you, sir.
Now our third topic is overlap syndrome, and the speaker is Professor Manoranjan Patnaik of SC Medical College, Kottayam, head of the Department of Pulmonary Medicine. And this overlap syndrome, I think when we were reading, there was a chapter, asthmatic bronchitis. So it was neither it is asthma nor it is bronchitis. But it was a chapter, it was there in Davidson textbook of medicine in the name of asthmatic bronchitis. And in the bedside also our teachers were teaching about asthmatic bronchitis. But in the meantime it disappeared, and now it has reappeared in the name of overlap syndrome. So I request Professor Patnaik, he has got extensive experience in pulmonary medicine. He is a member of National Technical Expert Group, NTP, Government of India, special member, National Board of Examination, member of National Task Force, past chairman, Zonal Task Force, NTP East Zone, chairman, Zonal Committee, NTP East Zone, chairman, State Task Force, NTP, and many other achievements, including 2 awards. So I request Professor Patnaik to start his talk.
Thank you, sir, for your nice words. Actually, when I got the topic overlap syndrome, as you know, from the pulmonary perspective, so there is now different overlap syndrome included in pulmonary medicine. So as you know, sir has told that asthma, chronic bronchitis. So now the term is come to ACOS. So COPD, asthma, overlap syndrome. Then comes the another topic, important topic, when the sleep medicine improved in the internationally in America. So they found that there is overlap syndrome with the chronic COPD and obstetric sleep apnea. Now again, another syndrome has come also, that chronic bronchiectasis and COPD. As you know that 20% of chronic bronchitis has COPD and 20% of COPD has this cystic bronchiectasis. Then comes the another thing, ILD. COPD and ILD, overlap syndrome. So there is a lot of overlap syndrome. So again, we will go to the overlap syndrome definition. It's a multiple disease states occurring together to produce a unique clinical phenotype and disease behavior. As we see more number of asthma COPD overlap, OSA COPD overlap, we'll discuss in this forum. So what is the definition? Patients who have persistent airflow limitation, with clinical features that support both asthma and COPD. So how will you diagnose? What is the characteristics? Spirometry, defined persistent airflow obstruction, significant smoking or inhalation exposure history, diagnosis asthma before 40 years of age, significant bronchodilator response or related phenotypes such as bronchial hyperactivity. So it is a controversial topic. No single universally accepted definition given by the Gold 2015, as there is a more different type of definition we found by different authors. So this is the common picture you have seen. The COPD, emphysema, COPD includes emphysema, chronic bronchitis and small air disease, and there is a asthma, which all lead to the airflow obstruction. Prevalence, the prevalence in general population is 0.9% to 11.1%, but you will find in asthmatic patient, the prevalence is 11.1% to 61%, and COPD, it is 4.2 to 66.0%. It differs significantly due to different definition and different population characteristics. What is the clinical presentation and outcomes? This ACO usually occurs in the younger and higher BMI compared to COPD patient. Women are at increased risk, more asthma-related comorbidities such as allergic rhinitis and GRD, greater symptoms burden. In comparison to the asthma, there is a more greater symptoms are there, worse quality of life. In compared to the asthma, quality of life is worse, more frequent and severe respiratory expression. That leads to hospitalization in ACOS in compared to the asthma patient. Lower lung function as measured by the pre-bronchodilator FEV1 compared with an age-matched subgroup of asthma. All-cause mortality is significantly higher compared to asthma or COPD alone. Bronchodilator reversibility, blood eosinophilia, and atopy in COPD is associated with a better clinical course. So this is the pathophysiology. So ACOS is commonly found in an individual who have a genetic and early life factors. that, and also there is a childhood atopy and asthma, and who this patient who smoke in the adult life, and they're exposed to the indoor and outdoor pollution, they are developed the echo. So this side is keeping. So approach. So how will you approach for the diagnosis? Diagnosis of chronic airway disease? If yes, then we'll ascertain the features for asthma and COPD, and as per the features, we will decide whether it is a bronchial asthma or is COPD or a ECOS. So this is the features, as you know, these are asthma features, COPD features, and ECOS features. I have discussed about the ECOS, what are the characteristic features of ECOS. And this is again the features for the fever, asthma, and COPD. So there is a 6 box. So if I got the 3 box for asthma, 3 or more, we diagnose asthma. If I got 3 or more for COPD, we diagnose COPD. If it is more than favoring this, more than other thing, then we diagnose a ECOS. This is spirometry. This is a normal and restrictive and obstructive. So what is the role of chest imaging in this obstructive airway disease? So airways, usually in CT imaging, we found the airways narrowing, bronchial wall thickening, and respiratory gas trapping. But what is the characteristic for this ECOS? There is a segmental airway wall thickening found in the echo in the 3rd and 4th generation. And you find less of emphysema in case of a echo. What are the biomarkers? Definitely serum IgE and peripheral eosinophil counts have been included as a minor diagnostic criteria in several guidelines. Although the sensitivity and specificity of the individual inflammatory biomarker are relatively low, combination biomarker result in higher specificity in diagnosis of echo. Management, definitely the important thing, the exercise training. And as you know, the gold standard of treatment is from the beginning in case of asthma is inhaled corticosteroid. So it is also recommended in the echo. Triple therapy is an ideal regimen for echo, like starting from the ICS, LABA and LAMA. Advanced treatment beyond inhalers, roflumilast as a anti-inflammatory drugs. As you know, it is recommended in the recurrent exacerbation. Azithromycin as a immunomodulator. Montelukast is a drug of choice in bronchial asthma, but there is no robust data for this. Metformin, the mechanism of action is the decrease the inflammation in allergic inflammation of bronchos. That also require more works, and as usual in biologics also there is a less work in the echoes. So we have also established a thing in the bronchial asthma. Then this is the treatment policy. So recommendation treatment is the triple therapy. Till we are in the inhaler therapy, we have not gone beyond that because there is no robust data. Then we will come to OSA, COPD. This is a very important thing. As you know, if you go through the data in America, 30% of the population, general population, are having a OSA. But India, this data is not available till that. And the good thing is that because we are lack in the sleep medicine specialist, now there is a meeting. Also, I was in that board meeting in National Board exam meeting. So from the next year, there will be also a fellowship program in sleep medicine, recommending for 2 years fellowship medicine will start from India. That will be very good for the future. So OSA with COPD overlap. Actually, this is first coined by the Friendly 1985. Coexistence of apnea, hypopnea during sleep, secondary to obstruction of the airways with COPD, increased risk of cardiovascular events, particularly pulmonary hypertension and atrial fibrillation, new onset atrial fibrillation, increased risk of mortality than in patient with isolated COPD or OSA alone. So this is a very dangerous thing. So high mortality. So how are the clinical consequences? So most important factors is the obesity and smoking. So that causes OSA, obesity and smoking OSA, COPD, that leads to hypoxia, and hypoxia leads to release of systemic inflammatory mediators and endothelial dysfunction and atherosclerotic plaques formation. That lead to cardiovascular disease and pulmonary hypertension. So pulmonary hypertension is one of the deadliest complications in this COPD and OSA. Role of sleep in COPD. Poor quality, so in COPD patient, there is a poor quality of sleep with daytime fatigue. Sleep is the third most common for quality of life after dyspnea and tiredness. Difficult in COPD, there is difficulty in initiating, maintaining sleep, decreased REM with frequent nighttime arousal. 70% of COPD patients report isolated nocturnal hypoxemia with daytime normal saturation. What is the definition of isolated nocturnal hypoxemia? PO2 less than 55 or oxygen saturation less than 88% for at least 5 minutes. Sleep, what is sleep hypoventilation? PCO2 more than 55 for 10 minutes during sleep or increase in PaCO2 by 10 millimeter above the awake line. So what is the physiological effect of sleep on respiration in COPD patient? So there is a negative effect of on respiratory control, respiratory muscle function, and lung mechanics, which lead to hypoventilation, hypoxemia, and hypercapnia. Role of COPD in sleep impact on respiratory control lead to poor central sleep drive, impaired respiratory muscle function, both intercostal and diaphragm muscles, impaired lung mechanism, decreased FRC, and there is a reduced intercostal muscle activity and chest wall mobility. Epidemiology, prevalence 2.9 to 65.9% in COPD, 1% in general population, high level OSA in patient with moderate to severe COPD. So what is the promoting factor? COPD promoting factor. So promoting factor for OSA, rostral fluid shift. What is rostral fluid shift? As you find in a congestive cardiac failure or renal failure, there is a, in the daytime you find there is a edema of the leg. When this is effective to gravity, when the patient sleeps during night time, so that fluid is shifted due to gravity. Even sometimes they are present in the neck. The fluid in the neck, that causes more pressure over the airways, upper airways, that leads to obstruction, and that leads to also this OSA. And what is the protective phenomena? So definitely in severe COPD, likely emphysema phenotype, you find that there is associated a low BMI, long hyperinflation, diminished REM sleep, old age, and medication like theophylline can be a protective for from OSA point of view. This is the pathophysiology. Nocturnal oxygen desaturation occurs in COPD. That leads to, due to alveolar hypoventilation, decreased ventilation, perfusion mismatch, and decreased end expiratory volume. What are the inflammatory markers? There are also, because it is a systemic, it is an inflammatory disease, now the mediators like CRP, IL-6, NF-kappa beta, TNF-alpha, IL-6, all are released. That also related to this pathophysiology. Clinical, how you assess clinically? Higher prevalence of hypoxemia, hypercapnia, and pulmonary hypertension compared to OSA or COPD. So this syndrome has got more hypoxemia, hypercapnia, and pulmonary hypertension. So overnight oximetry is the simple screening test to detect nocturnal hypoxemia. Definitely the polysomnography is the gold standard test. So what is the treatment? What should be our aim? Aim is to maintain nocturnal oxygen, reduce episode of hypoxemia and hypoventilation, behave and also improving the sleep quality. So what is the lifetime modification is the one part of the treatment, structured exercise program and pulmonary rehabilitation. Behavioral modification, that means cessation smoking. Smoking is the one of the important factors, so cessation smoking. Supplemental oxygen therapy, not recommended. Only supplemental oxygen therapy, the nighttime desaturation, oxygen saturation will improve. But what happens if you give long time oxygen, there will be hypercarbia. So that leads to also respiratory failure and death of the patient during nighttime. So bronchodilator and corticosteroid. Corticosteroid is not recommended. Definitely CPAP is the answer and it is recommended everywhere. NIV effective during acute hypercapnic respiratory failure, not in a chronic capnic respiratory failure. Thank you.
Thank you, Professor Patnaik. Now, the topic is open for discussion. If anybody has got any question or clarification.
Sir, regarding the long-term use of corticosteroids as inhale, because in the overlap syndromes, particularly when overlaps with COPD, what is the amount of steroid and what is the duration to avoid HPA-axis suppression?
Sure. So actually recommendation is 1800 microgram. So last word 1800 microgram budesonide and 1000 microgram of the fluticasone. If you give more than 2 years, then it is HPA axis suppression. But one problem with this corticosteroid, that leads to also development of this OSA. How? So actually corticosteroid side effects is that there are also atony of these muscles, upper ear muscle, pharyngeal muscles. That also atony and paralysis, sometimes also paralysis muscle. That atony will lead to collapsibility and that leads to the OSA. So if a patient has a OSA, we find out other type of treatment minus the ICS. So ICS will be the problem for those patients. And recommendation is that every COPD patient nowadays should have, this is a future plan, should have a screen for OSA and all the OSA patients should have screen for the COPD patient. Because COPD, stage 1, stage 2 may have the OSA. And the mortality rate is more high. And any COPD patient with a pulmonary arterial hypertension should have screened for the OSA. That is the recommendation. And future also, the more research we should have taken in the sleep medicine, on COPD and these things for OSA. Yes, role of CPAP is only as you know that BiPAP is the boon for the COPD patient. So CPAP, I will tell that CPAP is a boon for the OSA patient. So it's the only possible treatment where the patient has great morbidity and mortality can be prevented in also this COPD patient with OSA.
I don't think there is any other question. Thank you, Professor Patnaik.
Thank you, sir.
Thank you for enlightening us about 2 overlap syndrome. We thought of that he will be confining to 1, but he has covered 2 overlap syndrome. Thank you, sir. Sir, please come.
Thank you all our esteemed chairpersons and speakers for this wonderful session. I would now like to request all our chairpersons to proceed to the memento podium for felicitations. Moving on to our next session of the day, it's again a mixed basket. For this, I would like to chair this session. I would like to invite Dr. B.K. Behra, Professor of Medicine, SC Medical College, Cuttack, Dr. Trupti Swai, Professor and Head Department of Pharmacology, SV Medical College, Cuttack. Dr. Sanjay K. Jangid, Professor of Medicine, High Tech Medical College, Bhubaneswar. Dr. Umakant Mishra, Senior Consultant Physician, Bhubaneswar. Please come on the dais and chair this session.
So, in this Miss Basket, we have the first session is about malaria, which is a common problem in Odisha, and the topic is story of toll and malaria. And to deliver the topic, I have the honor of inviting Professor Manoj Kumar Mahapatra, who is the Professor and Head of Medicine at Vimsar Burla. Sir is a known academician and a researcher having more than 100 publications. He is the recipient of very prestigious M.J. Saha Award for Tropical Medicine in the year 2009 as well as 2001, and then Best Paper Award of RSSDI 2000, Indian College of Cardiology 2001, Mehta and Patel Best Original Article Award by JAPI 2010, and then he is the author of 5 books in Odia and on medical research, and he is also recipient of very prestigious Ronald Ross Award on Malariology 2011. So I invite Professor Manoj Kumar Mahapatra sir to deliver.
So good morning everybody. At the outset, I am very thankful to organizing chairman, organizing secretary, chairman scientific committee for inviting me to deliver on this topic. Now this topic is a little bit different from the topics which we have listened for last 2 days. So it will take you to a different sphere of research which you may like or you may not like. So let us start. What is the story of toll and malaria? Now since 1985, 37 years ago, I was a postgraduate student here from 1983 to 86. So during 85, the rollback malaria was very rampant here. Now during that time, I have indirectly made a tryst with malaria, and in a romantic word you can tell that I have started dating with Miss Anopheles. Now in the same year, why I am telling this? Because at the same time, in the year 1985, which has a relation with this topic, toll word has been not originated, it was very important among the geneticists and also the immunologists. Toll is a German word which meaning in English is the great. The word came to importance in the year 1985 when these two scientists, German scientists, they have worked, they are doing research in embryogenesis or embryonic development of fruit fly and found that the mutation of a gene caused, this is normal fruit fly, has some abnormal look of this fruit fly. Due to this unusual look of the fruit fly, they have exclaimed in German, "Das ist ja toll," which translates in English as "that's great." Now the gene responsible for this toll is known as toll gene, and they have received Nobel Prize in the year 1995 for this discovery. Now the story does not end here, because in year 1989, Janeway made a hypothesis that in our adaptive immunity, before adaptive immunity, there are some PAMPs, or you can tell patterns or pathogen-associated molecular patterns which recognize, in body recognizes these PAMPs, and these patterns are not mutated of the microorganisms, so that they have made a group immunity. And this is known as PAMPs, and the receptor which usually accept these PAMPs is known as PRR, or pattern recognition receptor. So it was a hypothesis by Genway in the year 1989. Now, this is the PAMP I am telling. During that time, it was not very much used. Now, in bacteria, in gram-positive bacteria, in gram-negative bacteria, in viruses, in parasites and yeast, there are some common chemical structure which is not changed. So, in 1996, again the toll comes into picture. Now, in Drosophila, they have found out the genes which are responsible for this abnormal embryogenesis. When the fruit fly is infected with a fungus, mutation of this gene gives rise to the death of the parasite due to the fungal infection. And they have found out that the same genes are responsible for a protein, that is drosomycin, which is antifungal in nature. So now they have found out the same gene which is responsible for embryogenesis is also responsible for immunity against fungal infection. Now, why does it happen? So in 1997, the toll pathway has remarkable similarity with mammalian interleukin-1 pathway that leads to activation of nuclear factor kappa beta. Due to this similarity, it was proposed that the toll-like path might have been involved in mammalian innate immunity. Now, what immunity we mean that it is adaptive immunity, humoral immunity and cell-mediated immunity. Here comes about the innate immunity. Now, in 1995, when the Human Genomic Project was very much in United States of America, they have found out that a family of proteins which are structurally related to Drosophila toll, and so in other words, after 10 years of Genway's hypothesis, the first PRR, that is pattern recognition receptor, is known as toll-like receptor, has been found out. Now, this is the story. Now, what is its importance? We know that in our body, two types of immunity, that is innate immunity and that is adaptive immunity, is working. But our emphasis is always on adaptive immunity, that is B cell and T cell. Now, when innate immunity starts within 0 to 4 hours of the infection, and usually with this innate immunity, the process of inflammation starts, and you will find interleukin-1, 6 and other cytokines by NF-kappa beta activation, which is a transcription factor. Now, this innate immunity has a channel which activates the B cell and T cell immunity later on, because there is no barrier. So these are the dendritic cells. But we are very much, the majority of the research of immunity was on B cell and T cell. The innate immunity research was ignored for a long time before the discovery of this toll gene. Now, in our human body or in invertebrates, so we have a toll-like receptor. These receptors, there are 13 receptors and 10 on the cell wall and 3 in the internal, I mean the intracellular, to activate the intracellular antigens. Now, what occurs in TLR signaling? Now, the attachment of PAMP or your PAMP to TLR, then there is attachment of adapter protein, MYD, the name of the protein. Then in step 3, there is activation of a protein kinase. This protein kinase activates transcription factor, nuclear factor kappa beta. Then this entry of transcription factor to the nucleus, and you have a gene transcription, and in step 5, release of the cytokines and other pro-inflammatory proteins that mediate inflammation. So this is the TLR signaling path which occurs prior to your humoral immunity or B cell and T cell immunity. So this is the story of Drosophila toll. The discovery is an example of startling nature of scientific discovery, illustrating how important discoveries can come from the most improbable places. The discovery of toll gene regulates the embryonic development, is found to be the key player in innate immunity, and is inherited from invertebrates to vertebrates. Now here lies the philosophy of evolution. or you can tell the spiritual aspect of evolution, how the invertebrate, the small insects, has given their gene to human beings so that they have their own immunity. It is not the insect. The same gene is found in plants, in all animal kingdom, and it has been inherited from this small insect to us, so we should be indebted to our predecessor. Who is our predecessors? The insects and the plants. So at this point, to summarize this complicated story, that innate immunity is the inherent immunity that is inherited from invertebrates to human being. Toll-like receptors are pattern recognition receptors that activate the innate immunity, receive the name from the similarity of the protein coded by the gene toll detected in fruit fly that regulates embryogenesis. All vertebrates and invertebrates have this gene. Plants and humans, we have 13 genes, and which is equivalent to the rat. Rats also have the same 13 toll-like receptor gene. So we have no difference between rat and man. Probably that is the reason why rat is found in the Lord Ganesh. Now what is its role in malaria? Now here our work and the other works I will tell you that, as you know, everybody knows that the pathogenesis of cerebral malaria, I am directly going to the topic, that two schools of thought, that is school of sequestration, where we know the sequestration is the cause of cerebral malaria, and another is the school of inflammation. Both almost hypothesized in 1994, but the school of inflammation has down due to the lack of evidences of activation of B cell or humoral immunity. Now in 2005, it again get momentous, and now we have a new hypothesis for that we will discuss, and how the cytokines and local inflammation is more important than the systemic inflammation, unlike our bacterial and viral infection. Now this is to recapitulate: severe malaria, that is sequestration hypothesis, that is nerve formation, stage of cytoadherence, stage of rosetting, sequestration, hypoxia, and your cerebral malaria. Now what is the inflammatory hypothesis? Inflammation, what are the negative points regarding inflammatory hypothesis in malaria? Inflammation is not an overt manifestation of malaria, unlike bacterial and viral infection, due to its life cycle that evade the host immunity in all possible ways. Now another important thing, why it evade? That MP or malaria parasite never crosses the intact capillaries. So it remains, and it remains in the blood supply or the blood circulation for a very, very short time. So what about the role of innate immunity here? Now in the year 2005, which I told you, in 2005 it has again reinforced. PAMP in malaria is discovered in 2005, that is glycosyl phosphatidyl inositol of P. plasmodium falciparum, acts like a PAMP and activates TLR2. Malarial hemogen is another receptor or another agent or antigen, you can tell, which act on the toll like TLR9 and mediate innate immunity in malaria pigment hemogen. So TLR is involved in malaria 2 and 9, these are the major TLRs, and TLR4, which is found in both extra and intracellular, have a minor role, and TLR1 also helps the TLR2 having a minor role. So these toll-like receptors are very important for malaria pathogenesis, and that revamped the immunologic hypothesis. Now this is the site of the GPI, this is the parasite. Now this is the hemogen. This is the intracellular agent which stimulates TLR9. So where is the missing link? So malaria parasite can evade adaptive immunity but not innate immunity. So that was the missing link in our inflammatory hypothesis. Now this is in short where these toll-like receptors, the most interesting fact is one of the important site of TLR2 is the endothelial cell. Now as you know, endothelial cell is the main stage where the drama of cerebral malaria occurs. Now here it's a combination hypothesis I am giving you, where we are getting, not only that we are not getting adhesion and cytoadherence, yes, we are getting inflammation, adhesion, coagulation, cytoadhesion, and in addition to it, we have also this component which also influences our pathogenesis. Now what is TLR2? Because we will discuss about the TLR2 now, that it is located in chromosome 4, 3 exons, 784 amino acids. So we have different polymorphism. out of which the 22 base pair insertion deletion polymorphism is very important as regards to malaria. So in 2013, we have made a paper, even if we are at Burla, and it is a summer project, 3-month summer project for the undergraduates. So in that we have found out, and it has published in Journal of Infectious Disease, that IDD, that is insertion deletion polymorphism, protects from multiple complications in falciparum malaria. Subsequently, in 2015, with the help of North Odisha University and ICMR, we have also made a similar extension of the similar study, which is published in Immunology Research. Now, where we have found out that how TLR2, this is the signaling mechanism in TLR2 and malaria, which we have proposed. This is the real thing, but it has not come written in the book like this. So in step 1, GPI, cell wall, TLR2 present on the cell wall, so it is attached to the TLR2, then it activates MID88 protein, then protein kinase, nuclear factor kappa beta, transcription, cytokines, and that causes the blood-brain barrier destruction by which we get the cerebral malaria. Now in Uganda, they have made a similar study in 2012, where also they have also found this deletion polymorphism is also associated with prevention of MODS. Now this is the picture of the TLR2 gene abnormality, which we have done in the ICMR lab with the help in our first presentation. Now what is the mechanism? The mechanism which has been proposed, that insertion deletion occurs at the site 60 base pair downstream of the NF kappa beta site, which is also present in chromosome 4. So your TLR2 present in chromosome 4, NF kappa beta site is also present in chromosome 4. So here is the site. So this is the critical for the transcription. So probably due to this abnormality in the polymorphism, NF kappa beta is not synthesized, the transcription factor is depressed, so we are not getting pro-inflammatory response, less pro-inflammatory response, and less incidence of MODS, including cerebral malaria. Then we have, this is about the extracellular TLR2, then we have done a work on the intracellular TLR9, which is due to the hemojoins. Now we have found the TLR4 and TLR9 in the clinical outcome. Now TLR9 is an intracellular TLR toll-like receptor, whereas TLR4 is found both extra as well as intracellular. There we have found a very interesting story. This is about the short anatomy of TLR9, which is found in chromosome 3. Here we have found, this is the signaling, that is attachment of hemojoin to TLR9, it is in the endosome because it is intracellular. Then again MID88, then these are the cytokines. Now TLR2 polymorphism influences cerebral. So the interesting finding we have found out that the TLR9 mostly influences the non-cerebral complication. The article is in press, which will be published recently. Now then we have made another, that is toll-like receptor 1. Though it is a minor receptor, we have very interesting finding that toll-like receptor 1 polymorphism is associated with high parasitemia. So our work is now how this complicated 1, 2 and 9, they intermingle because all the receptors are present in one person. So what type of polymorphism is beneficial for the person and what type of polymorphism is detrimental for the person. So at present we are here that GPS acts on TLR2 and hemojoin on TLR9. TLR2 polymorphism prevents severe malaria. TLR9 polymorphism associated with non-cerebral complication, and TLR1 is associated with parasitemia. So the conclusion is it is an ancient disease, evade the adaptive immunity but not the innate immunity. So that is a very important lesson we should learn. So this is a multi-scheme hypothesis which I have shown you, that we have got both innate as well as your inflammatory hypothesis. So for this I have the PJ Mehta oration in this year at Jaipur. So this is my oration. So this is my team at Burla, with which I am working. Now lastly, I can tell Miss Anopheles at candlelight. Now we are also getting mosquitoes here in daytime. So at candlelight, no kiss please, so that you can prevent malaria. Thank you very much.
Thank you very much, sir, for your in-depth analysis through your research, knowledge and presentation. Now the session is open for discussion or any questions. there is no question. So, sir, I have one small doubt, like what is the any beneficial effect of chloroquine with relation to suppressing immunity with toll-like protein?
Sorry, that answer I cannot give because I don't have that type of work. I have not done.
Okay.
So, but the literature shows that it may influence the immunity in many ways, but I cannot answer.
Through hemoglobin pigment suppression?
Yes.
There,
Because,
it is only in the experimental stage only.
right.
Yeah. Thank you, sir. Thank you very much.
Good afternoon, everybody.
Sir, please be here. Sir, please.
Good afternoon. Now the topic is involuntary movements, the common involuntary movements we come across like ataxia, chorea, tremor, Parkinsonism and many others. And we face much difficulty for its diagnosis and treatment. For this, we are speaker Dr. Lulup Kumar Sahu. He is Associate Professor, Neurology, IMS and Sam Hospital, Bhubaneswar. He is having publications more than 20 to its credit. And his special interest is Parkinsonism, atypical Parkinsonism, botulism, deep brain stimulation, etc. Now I request Dr. Lulup Kumar Sahu to elaborate on the topic, involuntary movement, diagnosis and treatment.
Thank you, Chairperson, sir. And I'd like to thank you, Professor Padiyar, sir, and Professor Jayant Panda for inviting me. And it has been a privilege to present in front of my professors, Professor Mahapatra there, Sasi Mahapatra sir, and Manoj Mahapatra sir is there. And Professor Mahandi sir is also there, and Professor Kullu. So they are my teachers, and Professor Malik sir is also there, who is my DM mentor in during my neurology. So this is my topic. So this will be my flow of lecture. So what is movement disorder? So basically movement disorder is divided into, it may be a hypokinetic movement disorder, or it may be hyperkinetic movement disorder, or it may be a combination of both hypo and hyperkinetic movement disorder. So these are the basic example of hypokinetic movement disorder like Parkinsonism, apraxia, blocking tics, catatonia, and hyperkinetic movement disorder include tremor, tics, myoclonus, dystonia, chorea, athetosis. So this is the classification given by Abdo et al. So basically hyperkinetic movement disorder we can divide into two, whether it is a jerky or a non-jerky. So if it is jerky movement, then most common is a myoclonus or excessive startle response, or chorea movement including balismus, those are also jerky movements, including tic disorder. And non-jerky movements are dystonia, including athetosis and tremor movements. So before going for examination of any movement disorder, we have to do a label-wise examination of movement disorder. So first label one is what is the phenomenology of the movements. So these are the 5 headings we should examine the patient. So what is the speed of movement? Whether it is a hypokinetic or it is a hyperkinetic. If it is a hyperkinetic movement disorder, then you see for speed, the fastest one is the myoclonus, hyperecclesia, hemifacial spasm. Also these hyperecclesia and hemifacial spasm are also a part of myoclonus also. Then intermediate speed are chorea, balismus and tremor, and slowest are the athetosis and akathetic movements. Then second part is what is the rhythmicity of the movement, whether it is a rhythmic or non-rhythmic. Third one is the what is the distribution of abnormal movements. Fourth one is the whether the abnormal movements are present only at rest or during any action or during both rest and action, or is there any suppressibility or not. So according to rhythmicity, the most common rhythmic movement disorder is the tremor and sometimes myoclonus. So palatal myoclonus particularly is rhythmic. So now also it is classified as a palatal tremor. And arrhythmic are chorea, abolishment, atherosis. And regarding the distribution of abdominal movement, you can ask for what is the starting of the movement, whether it started from the leg or in the face. So these are the movements like DIT1 dystonia or doparisome dystonia. Those movements used to start from the leg region, particularly in the adolescent child. And hyperkinetic affecting face are usually hemifacial spasm, blepharospasm, oromandial dystonia, usually affect the facial region. Then third part is what is the syndrome. So we have to see for whether that movement is only a specific type of movement or they are in a combination of like dystonia or chorea or some Parkinsonism with other associated signs like pyramidal signs. Those things we have to be taken into account. Then whether the syndrome is continuous or it is paroxysmal. Then last part is what is the etiology. Regarding, according to the patient age, family history, and on the investigation like copper study or MRI, or genetic study, we can give a etiological diagnosis. Coming to the hyperkinetic movement disorders, so it includes most commonly Parkinsonism and atypical Parkinsonism like PSP, MSA, and CBS. This is the MDS diagnosis criteria for our Parkinson's disease. As you can see, the most essential criterion for Parkinsonism is the bradykinesia. So that should be there, along with at least one of the rigidity or tremor should be there for calling it a Parkinsonism. Then other parameters we have to see for diagnosing a Parkinson's disease. So these are important red flags are there, like wheelchair bound within 5 years of onset of Parkinsonism or absence of progression even after 5 years of onset of disease or early bulbar dysfunction, early stridor or insipidus high, or red flags like autonomic failure within first 5 years, which can occur in MSA lesion, recurrent falls within the 3 years of onset of disease, or dyspnea anterocolis or contracture, which usually seen in MSA patients, or absence of any non-motor features of Parkinson's disease in the initial 5 years. That are the red flags for Parkinson's disease. So this is the time flow of Parkinson's disease patient. As you can see, these are the pre-motor symptoms. Even 10 to 20 years prior to the onset of motor symptom, patient may have constipation, RBD. If these two features are there, then we can, if you have a doubt of Parkinson's, then you can call it as Parkinson's disease based on this presence of these non-motor symptoms. Then as the time progresses, the initial, this is the initial window, honeymoon period where the motor response is very good and patients usually respond better to the levodopa. Then after that, advanced Parkinson's happens where motor fluctuations used to occur. So this is a YPD patient, advanced Parkinson's disease of 8-year onset. You can see this is the drug of condition with the levodopa. You can see there is a significant tremor, almost grade 3 rest tremor in the bilateral lower limb. And the patient is tilting backward. The patient is severely bradykinetic. And you can see patient is, has to be fed by riles too because of severe swallowing difficulty during off period. And he can't get up from chair also with any support also he can't stand up from the chair and also can't walk also. And sorry. So this is the on period. You can see after taking levodopa there is improvement in the facial expression. There is coriform movement in the eyebrows you can see. And the tremor subsided, but there is some dystonic posturing there that may be part of dyskinetic movement due to levodopa. So there is significant improvement in the levodopa, and according to the MDS criteria, there should be at least 30% improvement in the EPDRS scale after levodopa to call it as a Parkinson's disease patient. And also the dyskinesia suggests there is advanced PD with motor fluctuation is there. So how will you approach for treatment of motor symptoms of Parkinson's disease? These are the formulations or medication, those are available. Levodopa preparation is the most common, most used drug, are the immediate release levodopa carbidopa 100 by 25. So minimum dose you have to give it 3 times a day, or minimum 300 plus 75 milligram per day levodopa has to be given. And it has to be titrated slowly and over 3 days to 5 days so that there may not happen any nausea or orthostatic hypertension with the levodopa. Or controlling levodopa carbidopa is also available. Then non-ergot dopamine agonists like pramipexole, ropinol, and injectable apomorphine is also available. But one thing is you have to titrate and build up slowly so that no side effect happens. Then MAO-B inhibitors like selegiline, rasagiline, safinamide, zonisamide, then COMT inhibitor, entacapone, opicapone, tolcapone are available. But in India, we have only entacapone only. And others are anticholinergic like trihexyphenidyl, amantadine, estadifylline is not available in India. And clozapine also you can use when there is a disabling dyskinesia. So this is the approach of motor symptoms. If initial medical therapy, we should start with levodopa, carbidopa, along with dopamine agonists we can use, or rasagiline, MAO-B inhibitor we can use. But if it is only tremor dominant, we can start with only trihexyphenidyl. But better to not to give trihexyphenidyl, particularly in elderly patient, elderly male patient who may have underlying prostatic enlargement or may have some cognitive impairment or behavioral issues that may happen with trihexyphenidyl. And subsequent therapy in advanced stage, or there is wearing off and motor fluctuation, we can add dopamine agonist, we can increase COMT inhibitor, and amantadine for dyskinesia can be used. And in advanced stage, we can go for deep brain stimulation surgery, or for tremor, we can go for thalamic DBS. So DBS first approved at FDA in 1997 for BMDBS for tremor dominant Parkinson's disease, and recently it has been approved for early DBS, mean within 5 years of onset of PD also we can go for deep brain stimulation. Both ST and DBS, ophthalmic nuclear DBS, and globus pallidus internal DBS, both are approved by the FDA. So you can see this is the patient. Actually, this video is actually running. Patient severe akinety rigid and very bradykinety, not able to tell at all. You can see there is mild tremor is there in the both hand, mild postural raised tremor is there in the both hand. And after taking levodopa, you can see how much motor fluctuation. They are severe dyskinesia. They are not able to. He's becoming on, but he is so much disabling dyskinesia that he can't do any work during the on phase also. So at this stage, this patient went for deep brain stimulation. This is the post-DBS drug off, and DBS is on. Patient has not taken any medication, and DBS is working. So again, the facial expression improved, tremor is improved. And he can move his leg, those things which are not possible before the DBS. And this is the test, classical test, finger tapping test for examining the bradykinesia. So this is grade 1 bradykinesia only. So, and apomorphine pump is the recent addition in our Indian market for advanced Parkinson's disease. Those patients who are having severe dementia, or elderly patients having severe atrophy, then we can provide an option of apomorphine pump for these patients. Coming to the atypical Parkinsonism, you can see this is the PSP-RS. This is the rocket sign called in PSP patient. As he gets up from the chair, he tends to fall backward. And this is the diagnostic criteria given by Hogling-Rettel by the MDS in 2017. They have labeled 1 and 2, 3 they have made. And 4 parameters they have chosen for diagnosis of PSP. O means ocular dysfunction, classical is vertical spinal glass palsy. P for Parkinsonism, which is usually postural instability or happening within 3 years. Akinesia, progressive gaze fatigue within 3 years, which is maybe levodopa resistant. And C for your cognitive dysfunction. According to this, we can classify PSP-RS, PSP-P, PSP-CBS. So this is the hummingbird sign. You can see severe atrophy of the midbrain, and also this is morning glory sign or Mickey Mouse sign seen in the midbrain region. So this is the MSA, which is also atypical Parkinsonism. You can see this lady, how she is walking. She is having tilting of trunk to one side. This is called PISA sign. So this PISA sign is classical of MSA, but can be seen in Parkinson's disease patient also. And this patient used to have postural imbalance, so used to have spontaneous fall also. And following on, you can see sometimes MS patient improves with levodopa, but that improvement is not so significant like that of Parkinson's disease patient. You can see there is classical perioral twitching is there. This is classical dyskinesia. That is not classical of PD dyskinesia. This type of perioral dyskinetic movement following levodopa is usually classical of MSA patient. So for that reason, sometimes MSA and PS patient very difficult to diagnose in the early phase. So once you track the patient over 4 to 5 years, they may develop footfall features of other atypical Parkinsonism. So coming to the second part is dystonia. The definition of dystonia is it is a neurological syndrome carries sustained or intermittent muscle contraction causing abnormal, often repetitive movements, postures, or both. So usually it is a pattern and twisting movement. You can see this is the Wilson disease patient in status dystonicus. So you can see there is lingual dystonia there, patient having spontaneous protrusion of tongue there, and severe dystonic contracts are also this patient has developed. And severe dystonia, if patient is in dystonic storm. And this is the classical KF ring. For every child with dystonia or any movement, you have to check for KF ring. If naked eye is not visible, you have to send for slit lab exam to the ophthalmologist. And MRI, if you are finding this type of feature, usually most likely it is Wilson disease. And sensory tricks or just antagonists, these usually features, if present, then we can confirm the diagnosis of dystonia. So classification wise, it may be focal, segmental, multifocal, or generalized. Same focal means only one body region, segmental means two contiguous body region, multiple two non-continuous, and generalized trunk and at least two other sides are if involved. So this is the focal dystonia. We call it a blepharospasm. Frequent blinking of eyes is there. And the second video you can see there, along with the frequent blinking of eye, there is perioral twitching is there, greening of the face is there. So this is a segmental dystonia. I call it as mixed syndrome. So it's a combination of blepharospasm along with oromandibular dystonia. And this is the classical cervical dystonia. This is left torticollis. So there are multiple types of dystonia. There are cervical dystonia there. It may be anterocollis, retrocollis. This is what patient is doing. This is the classical sensory trick. What I am telling. There is some improvement once patient keeps some mouth or only touches only that part of the body region. Then that will improve. So if that is there, then we can call it as a dystonia. In the second video, you can see there is retrocollis, the head is going backward and also the trunk is twisted. So it is segmental dystonia, this one. The retrocollis along with truncal dystonia. So this is a case of generalized dystonia. We have published this one. This case of GM1 gangliosidosis with severe generalized dystonia. And you can, there is mineralization in the basal ganglia region. This is called wishbone pattern of mineralization seen in GM1 gangliosidosis. This is a paroxysmal kinesiogenic dyskinesia. This is intermittent type of movement. You can see once patient is running, some exhaustion is there. You can see there is some twisting of the left hand and also posturing of the head and also some twisting of the left great toe is there. So this is classical PKD. With drug of choice is carbamazepine, you can try. There is significant improvement with the carbamazepine patients. And this is writer's cramp. If I may ask for some 2 to 3 minutes. So treatment of dystonia. So this is the ABCD formula we used to remember during our DM time. Anticholinergic, THP, baclofen, clonazepam, dopamine-related drugs like it may be levodopa or tetrabenazine, which is a dopa depleter, or intervention like botulinum toxin and surgery like palliatomy and GPI DBS are also recommended for dystonia. Come to the third part is the hemifacial spasm. So it is a continual, rapid and brief repetitive spasms. It may be clonic form or maybe a severe spasm causing tonic form of hemifacial spasm. So eyebrows tends to elevate and is a peripherally induced movement disorder, and it is classified a type of myoclonus. So you have known about Babinskind. This is the other Babinskind we used to examine in patient of hemifacial spasm. So you can see this eyebrow is elevated. So this is the classical feature that distinguishes hemifacial spasm from blepharospasm. In blepharospasm, the eyelid will not be elevated. Because in hemifacial spasm, the frontal is also overactive. You can get an elevation of eyebrows. That is called other Babinski sign. Treatment is carbamazepine, clonazepam, botulinum toxin is the most important and significant improvement with the botulinum toxin. And in some resistant cases, we can go for microvascular decompression. This is the myoclonus. It is a sudden brief shock-like involuntary movement. You can see this girl is a case of progressive myoclonic epilepsy. This sudden jerk, spontaneous myoclonic jerk is happening in this patient. The classification, same focal, axial, or it means spontaneous or action. Treatment-wise, according to the origin of myoclonus, you can divide it cortical, drug of choice, levetiracetam, valproate, clonazepam, subcortical valproate. And you can see for segmental dystonia, segmental myoclonus, clonazepam and carbamazepine can be used. This carbamazepine we can't use in cortical and cortical subcortical myoclonus because that may aggravate the myoclonus in cortical condition. Chorea, the definition is involuntary, irregular, purposeless, irrhythmic movement, and the term is flow randomly. So this randomness is the phenological feature of the Korea.
Dr. Sahu, we are just going to cross the time
Sorry,
limit.
sir. Just wrapping up, sir. Only 1 minute. So I am skipping this one. This is the Korea. You can see this is the, if perioral region is there, then you can think of Apicon, Lubbock, Tardif syndrome, and also neuroacanthosis in upper forehead chorea, classical of Huntington disease. Hemichorea, you can see structural lesion like polycythemia, Sydenham's chorea, and hyperglycemic hyperchorea chorea. So this is the hemichorea hemibalism syndrome. This is left hemichorea hemibalism syndrome. The classical feature in CT scan is hyperdensity in the contralateral bas ganglia and the coated region. And this is neuroacanthosis. The classical feature will be, we call it rubber man gait or bouncy gait type of, and the patient used to have acanthocytes in the peripheral smear, and there is caudate atrophy in the brain also. And this is chorea gravidarum, usually occurs in pregnancy, generalis chorea. The second one is the Huntington disease, where the patient used to have generalis chorea along with some dystonic component may happen with some motor tics, and phonic tics also may happen in the patient. So treatment-wise, you can use typical antipsychotic like haloperidol, olanzapine, or tetrabenazine, also helpful in these patients. And I'm skipping this one. Balismus, this one video I want to show. So this is the Balismus is most common is stroke, but second most common is the overdose of levodopa. This is an advanced Parkinson's patient who, after taking levodopa, there is significant jerky movement and flinky movement of the right lower limb predominantly. So this is hemibalismus levodopa induced in advanced PD patients. Tremor, I am skipping. This is a classification. So this is the palatal tremor. You have to check in a patient with the brainstem hemorrhage and brainstem stroke. This is a classical palatal tremor used to happen. And this is a classical Wilson tremor. Any young patient tremor, you have to evaluate for ceruloplasmin and copper study. So this is a classical rubral tremor seen in Wilson disease patients. Treatment I am skipping. This is tics. Usually, you have to remember it is often suppressible. If suppressibility is there, then we can think of tic disorder. The treatment I am skipping. So this is my conclusion. This is for residents if they are. You can see the videos. So this is my last slide. You can see there is perioral movement is there, some chewing movement is there. And the second lady also you can see. And for the residents, you have to guess what may be the cause of these movements. The same thing, chewing movement is there in the patient. In the third video, there is jaw tremor is there. And you can see in the first video, there is some bradykinesia there. Patient is also so, along with some perioral involvement movement, there is also bradykinesia there. In the fourth video, the first and fourth, these are CKD patients. So there is also perioral or orobucolingual dyskinesia. So anybody guess what may be the cause of this type of movements? So this is a levosulfide movement disorder. So better not to give levosulfide to any patients, particularly any patient of CKD or any patient on dialysis, any patient of chronic diseases. Then you have to think of not giving this levosulfide because sometimes these are irreversible. The medicine doesn't respond for all these patients. We have to give botulinum toxin. Thank you. Thank you all for your patient hearing.
Thank you, Dr. Sahu, for the nicely dealt the topic. It is a very difficult topic, but well illustrated. You have elaborated everything. Now it is open for discussion. If anybody wants any clarification.
We physicians most often come across with a writer's cramp.
Yes, sir.
What is the treatment of writer's cramp?
The writer's cramp treatment choice is usually botulinum toxin. So, but sometimes patients are not so much eager for botulinum toxin because of cost factor and all. So, we can use baclofen, clonazepam, trihexyphenidyl for this patient. And we can advise some change in the pain, particularly big grip pain, so that dystonia will not happen. Sometimes we can use a left-handed, we can use the other hand. So sometimes over course of time, the other hand also used to develop writer's cramp. But treatment choice is your botulinum toxin. Sorry, sir? So levodopa, because levodopa in initial stages can cause nausea, orthostatic hypertension and all. So you have to start with, basically I used to give levodopa plus carbidopa 100 plus 25. There is, brands are available which have 100 plus 10. So that is not ideal dose. Or ideal dose is Syndopa plus we used to give 100 plus 25. We start with half tablet BD for 3 days, then half tablet thrice a day for 3 days, then half of one. So over 15 to 20 days, we used to make the tablet in minimum dose of 3 tablets per day. Then maximum I have given 1200 to 1500 I have given. So that depends on the patient's responsiveness and patient tolerability. If there is no side effect, no dizziness, particularly this PSP patient and MSA patient, PSP patient doesn't respond to very low dose of levodopa. Only PSP patient gets some relief, 20 to 30% relief with levodopa. Other variant doesn't get any relief. So sometimes PSP patient we have to give for 1000, more than 1000 milligram also.
If there is no other question, now we close the session, close this topic. Thank you, Dr. Sahu. Now it is time for moment of.
Thank you all, esteemed chairpersons and speakers for this informative session. Now I would like to request all our chairpersons to proceed forward to the memento podium for felicitations. Moving forward to our next session, which is again a mixed bag kind of. To chair this session, I would like to call Dr. Shashikant Mahapatra sir, ex-professor of medicine, past chairman API, Odisha, Dr. Reena Mahanti, Professor Department of Medicine, MKCG Barampur, Dr. Satish Chandra Pradhan, Chief Medical Superintendent and Consultant Physician, Railway Hospital, Dr. Uma Shankar Mishra, Professor and Head of Department, Sri Jagannath Medical College, Puri.
Good morning, everyone. The first topic of this session is nocturia, clinical implications. I will invite Dr. S. Ramanathan Iyer to come up to the dais to deliver his lecture. He is a consultant physician in sleep medicine, diabetes, geriatric medicine from Mumbai. He is the fellow of ICP, Geriatric Society of India, Indian Sleep Disorders Association, and past president of Geriatric Society of India. Sir, I invite you to deliver your lecture, sir.
Good morning, everybody. I wish to thank the organizers, particularly Dr. Jayant Panda, for giving me an opportunity to share my views on this subject, which is a common problem, but it is goes undiagnosed, underreported, and not treated. The sun is rising on the eastern horizon for several years, to awaken us from the world of ignorance. When we are sleeping, we are ignorant, and this awakening is heralded. You going to the toilet to pass the urine. But during sleep, if you get up in the night to pass urine, that is disturbing the sleep, and this is a highly prevalent lower urinary tract symptom. It's having a complex mechanism, it's multifactorial. Somebody yesterday remarked that the only cause we know is benign prostatic hyperplasia, but it is not so. The physicians are very much involved in this pathogenesis and understanding of this problem. Now the physiologically, there is no urge to urinate at nocturnal times, and there are several hormonal and neurological mechanisms which are taking control in the night. But nocturia can affect any age, and it's a considerable economic burden to the patient. It is underreported, undertreated, and poorly recognized. Nobody takes the history. Most of the physicians do not record this history that are you getting up in the night to pass urine. Now, nocturia has been defined as the need for an individual to wake up one or more times during night to void. Each void is preceded and followed by sleep. This is the definition, and it imposes a burden on the health-related quality of life and also on the partners who are occupying the room where the patient is sleeping, and this may even influence the decision to institutional care. And this may be so bothersome that they may decide to shift the patient to elderly home. It may be difficult to conclude that nocturia is a normal part of aging because it is not universally present in all older adults. Now we have to distinguish between global polyuria and nocturnal polyuria. Global is excess urine day and night, more than 40 ml per kilogram 24 hours, and the classical example is diabetes mellitus. The nocturnal polyuria is the nocturnal urine output of more than 20% of a 24-hour urine volume in younger adults and more than 33% in older adults, the morning void urine being included in nocturnal urine output. So that is nocturnal polyuria. The prevalence varies markedly depending on the definition and age group surveyed. In general, prevalence of nocturia increases with age ranging from 4% in children to aged 7 to 15 years, and approximately 70% of adults aged more than 60 years. The pathogenesis of nocturia is complex and sometimes multifactorial, involving several organ systems. Abnormal increased urine production, decreased bladder storage capacity, or disturbed sleep pattern leading to waking at night, and it is an important symptom of chronic kidney disease where there is inability to concentrate the urine. The pathophysiology of nocturia can be seen on this slide, where there are three major components, that is decrease in the bladder capacity, increase in the fluid intake, or there is diuresis. The common causes which we encounter in clinical practice is prostatic disease, diabetes, sleep apnea, which can be central and obstructive, or both, then salt retaining or edema forming states like venous insufficiency, varicose veins, where when the patient goes horizontal, there is absorption of the fluid from the legs, and that results in nocturia. The same applies to patients in heart failure and kidney failure, patients having uncontrolled hypertension and resistant hypertension, then drugs like diuretics, calcium channel blockers, SSRIs, steroids, theophylline, which is commonly used in asthma, phenylephrine and lithium. Parkinsonism and autonomic neuropathy are the other conditions where nocturia can be seen. In the nocturnal polyuria syndrome, you can go a bit step ahead and say it is congestive heart failure, obstructive sleep apnea, nephrotic syndrome, urinary tract infection, kidney disease, venous insufficiency, and neurological diseases. The sleep disorders and nocturia has been shown to be associated with poor sleep quality and several types of sleep disorders, obstructive sleep apnea being the prominent, periodic leg movement disorder, and it's always an independent predictor of self-reporting insomnia. So when there is nocturia, the patient can come and complain of insomnia. Then the sleep is always fragmented when there is nocturia. There is disturbance in the architecture of sleep, and there is a high risk of fall, and sometimes patient of insomnia, when they don't get sleep, they often go to the toilet to urinate, and in our own study, 75% of elderly OSA patients had nocturia. The nocturia and the clinical and the cognitive decline are the prominent symptoms of OSA in elderly. This is important because the elderly population is increasing, and snoring is not a prominent symptom due to reduced stage 3 and stage 4 of sleep in the elderly. There is reduced daytime performance, daytime sleepiness, and also depression and uncontrolled hypertension. Now, the short and fragmented sleep has been associated with poor sleep quality, fatigue, daytime sleepiness, impaired daytime performance, and increased risk of cardiovascular disease events and premature death. There is increased risk of falls in the bathroom when they go to the toilet in the night. The hypertension and nocturia main renal defense against surges of blood pressure is actually nocturia and the symptoms of uncontrolled hypertension. Hypertension induces natriuresis with diuresis. There is a pressure natriuresis relationship, PN relationship, and this relationship is reset in hypertension, causing higher urine output at night than during day. So even hypertensive patients have the urge to pass urine in the night, which can be bothersome. Then compulsive water drinking. Some people in our country have the feeling of drinking water to wash out the toxic elements, and their water is kept in a copper vessel. And this, they get up in the time of Brahma Muhurat in the morning, and that can lead to sleep deprivation. And this excess water consumption leads to excess urination. And also the problem of today's modern lifestyle, that patient can plan the next day while going to sleep, that initiates anxiety. And when there is anxiety to get up early in the morning, that can also initiate nocturia. The obstructive sleep apnea, which causes nocturia, may be result of resistant hypertension, then proteinuria, and OSA, resistant hypertension, and CKD have common pathogenic associations. There is volume overload, excessive RAS activation, hyperaldosteronism, endothelial-derived vasoconstriction, inflammation, increased reactive oxygen markers, and proteinuria. Now, these are all the mechanisms which occur in OSA and have got the effect upon the nocturnal urination. Then in OSA, there is stimulation of atrial natriuretic peptide secretion through hypoxic-induced vasoconstriction, causing increased right atrial pressure. Now, this is very important because this release of atrial natriuretic peptide can occur at a specific time in the night, and this is responsible to prevent the rise in blood pressure in these patients in night. And this can occur at specified times in the night, like an alarm clock. Now, there is the situation of non-dippers, and this non-dippers patients who have in the night, they are having high incidence of nocturia. Now, nocturia, as I discussed, it can relieve the hypertension in night, and it is a manifestation of OSA, and blunted circadian variation in ADH may also contribute. So ambulatory BP recording and polysomnography are valuable tools in this situation. The repeated arousals because of nocturia can lead to rise in blood pressure and nocturia, and this can be a vicious circle. In chronic kidney disease, there is a risk for OSA. While OSA hastens the progression of chronic kidney disease, they are having a relationship, and this is also a vicious cycle, and therefore all patients of chronic kidney disease should be evaluated for obstructive sleep apnea, which can worsen the kidney function, but this is rarely done. Then when you want to evaluate a patient on nocturia in your clinic, there are clinical examinations to be done, the sleep consultation, there will be 25 questions in sleep, urine analysis, cardiovascular evaluation, volume charts, determines the type of nocturia and associated causes, and full polysomnography level 1 study. Now this is the frequency volume chart where you can differentiate between the different types of the nocturia. Then we must not forget that hypertension, nocturia and OSA, it is a sangam where you can see the hypertension and nocturia, but you may not see the OSA. It is like the river over there in the Sangam. Now, management of nocturia, behavioral management, restriction of fluid couple of hours before going to sleep, warm bed and also surroundings, avoid taking caffeine, alcoholic beverages in the evening, empty bladder before going to sleep, don't plan the coming day while falling asleep, avoid arguments, anxiety and depressive thoughts in the late evening, avoid viewing the mobile. And we thank the Lord for the day. If this is followed, there may be a lot of calmness, and also it may reduce the episodes of nocturia. Now the treatment of nocturia, as per the reduction of bladder capacity, increased fluid intake and also diuresis, you can take care by taking measures to treat these conditions. For lack of time, I cannot discuss all points, but in general, we have pharmacological interventions like antimuscarinics, botulinum toxin for regarding bladder capacity, alpha blockers for patients of BPH, then increased fluid intake, the change time of fluid ingestion, treat diabetes, diuresis, you must treat diabetes, and then nocturnal polyuria with having patient who are having OSA, CPAP and BiPAP, and change the time of the diuretic, and for venous insufficiency, we have to take care of the varicose veins. Then full polysomnography, and in this, if you take a photograph of the patient before putting the CPAP, that is always better because there is a change in the face after using the CPAP. And what we need to do is to follow up these patients regularly, whether they are using the CPAP or the BiPAP regularly. The correction of sleep apnea by CPAP abolishes nocturia, and this we have experienced in all our patients. There is improvement in cognition, lowering of blood pressure, increase in ejection fraction, and overall improvement in quality of life. But if there is persistent nocturia after using the CPAP, you must consider the mask leaks, the PLM disorder, and associated urological disorders and the drugs. Not only you treat nocturia, but if you treat nocturia, you save a lot of water, and the patient doesn't use when they go to the toilet in the night. And early awakening at the Brahma Muhurat, which we have discussed. Lastly, I would like to state that sleep is possibly unconscious meditation, and meditation is possibly conscious sleep. So waking up in the early Brahma Muhurat is a good practice, but not at the expense of good quantity and quality of sleep. You have to sleep early at 8 p.m. so that you can get up at 3 a.m. Thank you very much for your kind attention.
Thank you, sir, for your excellent presentation. The topic is open for discussion and question answer. If there is no question, we will move up to the next topic.
Now I invite Professor Ashok Kumar Mallik, Professor and HOD, Neurology, SC Medical College, Cuttack. Felicitation.
Here is an important announcement. We are going to organize the Medi Quiz in Hall B. Interested candidate, postgraduate student and delegate may attend there, and we have got 3 prizes also for that. Thank you, please.
So the next topic is melidiosis. It will be delivered by Professor Prashant Ranjan Mahapatra. He is the Dean Academic and Professor of Pulmonary Medicine and Critical Care in All India Institute of Medical Science, Bhubaneswar. He has 270 publications to his credits, 11 book chapters, and 3 out of them 3 is in API textbook of medicine. So I'll invite Dr. Prashant.
Thank you, sir. Thank you, Satyasai. And good afternoon, everybody. My regards to all my teachers. And but I thankful to the organizer and particularly Dr. Joyant who inviting me for the topic. I think it may not be interesting for many, but I think end of this presentation one can know where the topic stands, where we are going. Have you heard this term? Yes. Definitely sure. But I think what I mean to see that 2005 world never probably not been knowing the term. So I am going to outline of this presentation some few cases, looks very natural cases. I mean, it's true cases and few cases. I have series of cases, but I cannot show that. And others related clinical or including prevention. This is a case typically presents like tuberculosis, long-standing tuberculosis, never been healed, never been treated. It's developed pleural effusion, given tuberculosis to ATT, then almost 6 months. Never been AB positive. So I'm just giving this treatment from Odisha. Then April, he was given a chest tube, then chest tube was removed. then ultimately, this normally happens, most of the patient looks like, and some feel that it might be malignancy, but patient has fever. So what if patient has gone to us, I think one day he's coming with a very cachectic person, come to at around 3 p.m. to us with a stretcher. So just thought, what can be done? We just admitted him, and we aspirated some, this is pedal edema, aspirated some fluid. Patient was actually in moribund condition with respiratory distress. So that by the time diabetes was improved over 6 months, definitely, but not much. But no other much contributory finding. This was the pleural fluid aspirated. AB was never positive. So this way I can show that there is a renal abscess. There is a renal abscess. There is a prostatic abscess. And there is liver abscess. So, splenic. You want to see splenic? Splenic abscesses. Yeah, that's what the C is splenic abscess. And so, this is a middle-aged male with poorly controlled diabetes and fever for 6 months, bilateral pedal edema, empyema, progressive on ATT. So what is possible in my mind, our mind, it's either liver, kidney, and multi-organ abscess. So we thought a possibly drug-resistant tuberculosis not been diagnosed, or maybe disseminated infection, or maybe septic pulmonary embolism, or maybe infective endocarditis giving multiple, but patient was never AB positive. Actually, what I meant to say, the diagnosis is already in topic, already part of topic. So this patient could have never been diagnosed as a melioidosis if our microbiologist could not give him supportive diagnosis. That is the clue of this patient. We have nothing much to do. We'll keep on moving here and there, but patient died. Many patients like this dying in the multi-organ failure, ventilator, and I mean this is a common scenario. I'll show it how it's common. So this case I'm not skipping this audience. I think audience know but much more than I can say. So patient was given meropenem and followed by cotrimoxazole. So just like antitubercular, there's an intensive phase of treatment and 2 months, but not 2 months, it's 3 weeks. Then followed by the cotrimoxazole, high dose cotrimoxazole for 4 months we were given. Look at the patient discharge at the admission and discharge. So this I'm saying this our that time there's an order, standing order for a hospital, a ministry order that every day change bed sheets to different color. So that's why the 2 different color of bed sheets. So the hospital bed sheets. So look at how much improved. This was improved condition. Then later on, while discharge, this CT was during mid treatment. So the last was at the time of discharge. This effusion is gone with residual fibrosis. This was the initial renal abscess. The renal abscess is gone with treatment. So what I mean is that even if prostatic abscess is gone, I missed that slide. Prostatic abscess is that also gone. So what I mean to say, this melioidosis we know as a biological weapon, and this is the Burkholderia pseudomallei, so the causative organic. So it's that's a part. That was known for it was not known for India for a long time. So modes of transmission and incubation period, it transmitted by percutaneous, inhalation, and ingestion. So I can say that inoculation, inhalation, and ingestion. Incubation period is highly variable. It is 1 to 21 days, but I will discuss how this is pathogenesis. So roughly pathogenesis, that means it looks classically like tuberculosis. So that can be percutaneous inoculation or inhalation. So go to the lymph node and bacteremia, and finally it's reactive, may dormant for a long time, may reactivate. So all this is one of our publications. So coming to history, this of disease, this is a history, come back to the 1948, I mean Indochina war. I'm not going to Indochina, my purpose is not Indochina war. So this is something like icebreaker I'm discussing. So this is something, what has happened during over 3 years, many American soldiers, I'm coming to next slide. This is American war in Vietnam. War against, you must be, maybe my generation and senior people knowing there is a cold war between Vietnam, North Vietnam, the war against American to save nation. This other one, this Russia and China, they are other side. And ultimately what has happened, this means US, basically they lost, that means more, at least 58,200 US Armed Force died, and maybe due to disease and mostly due to war. So disease soldiers they died, and many are means not been identified how they died. So this is why I mean to say. So this is how they died. So this is inhalation. This they mostly America they got just like they have gone to the recently they Afghanistan. So basically they withdraw their soldiers. Before that, this long time they have sent many soldiers. So they used to use aircraft, helicopters. Lot of dust when helicopter lands. I think everybody know the rotors bed. So many soldiers they inhaled that organism through dust. So later on, they died long time going back to America. And they are not able to know how people are dying. And later, many soldiers died over the time. They know that it's a series of publications. Mainly, one of just I picked up one of the. This is a Vietnamese time bomb. This is known as Vietnamese time bomb. So the time bomb is not confined to Vietnam. It was confined to the box from terrorism. At least kills 90,000 in a year. That's 2016. Sorry, I think it was published in Nature Microbe. So that at least 165,000 infected. So that is estimation. I'm telling you recent last year, even during COVID, the lavender spray, they're supposed to freshen home, it kills 2 people in America in Texas area. This is the publication in March 11, I think, this year. So multi-stage outbreak of associated with imported aromatherapy spray, that means imported spray. So basically what happens, the aromatherapy, that means perfumes are used, home perfumes are used, and that in America in many places, and was purchased through Walmart, and it was imported from India. So that means it is a news in CDC, worldwide news. So everybody must have heard somewhere, in maybe WhatsApp, some other group. So that means, and finally was there. So that means they forced to take back, the Walmart has to, all these perfumes are taken back under the CDC order. So they have to, it has again come back to India. And so recalls Better Home, that all aromatherapy were due to the organ. So what has happened? I'm telling the real problem. With the use of identification method, Maldi-top is one of the top, very good organ. I don't think any Odisha don't have a Maldi. Maldi, I think AIMS is going to buy. I think it's becoming common nowadays. So this is need to, even in Maldi, they are not able to detect, even 60 years ribosomal RNA sequencing could not miss that one. Again, Vitec 2 also missed that one. Even if ultramodern, they misidentified the bacterium. Usually what happens, this machine used to give the identify the organism. They missed it because the organism was never factored in the software. So this was again, that was the problem in America. The healthcare provider encouraged to reevaluate the patient. That is the exact quote I am taking from the NEJM, and that's the isolate identified automated system. That means they want to say that this mimic like Cepacia, Thailand, other bacteria. So that is mostly for microbiology. Again, another fact come that another story of same year. That has come to freshwater home aquarium. That was imported from Thailand. Again, some people died in America. CDC Health Advisory, it was very recently, I think 2 months before, it's July 27th, that melioidosis is locally endemic now in America. It was a disease, not to be just a tropical country, it's now endemic. So I'm telling again a story of, I think this is 3-4 days back, this come out in 4 days before, this story that aromatherapy, that these organisms never died. It has been, that means that raccoon was there, they got diseased and it was poured in somewhere near the home. And they identified that was the raccoon, was the environmental sample of the location of raccoon. The CDC investigated, and this is surrounding all this soil. That's want to say that is, I mean, it's spread disease. Even if patient died, the patient cured, disease gone. Months after that, that organism is in soil. So this is, and what I mean to say to the audience, that is tip of the iceberg. We do not know what we have. So this is one of the publication. My publication is this. This is one of the publications. So I'm going to. I think you remember that Delhi there is a plague in 1996. There is a controversy how people are dying. They could not diagnose exactly. So this is a paper of T. Jacob John. So and it's a criticized lot of international journal. So that was possibly. So this is a publication, I think 3 years back, 2019. By the time we have a lot of cases, and by the time our institution has almost diagnosed more than 200 cases of melioidosis, and our medicine faculties are there, they are witnessing more cases. So this is one of my publications published in Lancet this year, that I found out how many publications in PubMed this coming up from melioidosis from India. I look at this, how there is sharp rising in publication. So far, the data from India is just by case report. This is one of the publications, JAPI, and this year. So this is again rising cases of melioidosis. So this is challenged by since our country. We have no actual data. The fact is we do not have data. Our climate, tropical country is a very favorable place. And there is swift increase of cases who are under diagnosis, and there is a delay in missing diagnosis. Many patients are unable to get diagnosis because we do not have, somehow microbiologists are unable to give diagnosis, or the too late for a patient diagnosed after death. So an economic burden due to morbidity, because a lot of antibiotic, and mortality, and long-term this is the area, actually this is the estimation by it's published in Nature. So look at the very red area of the India is purely endemic. Maximum cases are there. So these are the tropical area where India comes, and particularly coastal area, and part of southern, middle, mostly coastal area, maybe western or eastern area. So risk factor I discussed, that travel to history of any patient travel to endemic area, but look at this American never traveled to any country during COVID, but I think our sample has traveled to America to give them disease. So maybe sample from Thailand. So this is some of the cases I'm saying, this is not the whole story. And this is maybe occupationally we are doing gardening, but I think we have to be very careful using gloves. So at least we can prevent, to should not the contact of the soil. And this area, this is more common heavy rainfall, aerosolized, more of humid area, and flood, particularly again more after the cyclone. There's a route of infection, so direct, this is the possible way of, you can understand how it hinges on how direct inoculation during cultivation. So these are the way that you can say how it spreads. And cyclone, I think after Fani, we have got a lot of cases that says that how many cases. So most of the has a acute, this is again, look at this case, most of the are 88% of the acute disease, and around chronic 8 to 9%, and around 2 to 3% are latent disease. This is CDC, and classically, it's again I'm taking quoted from the NEJM, that classically characterized by pneumonia with multiple abscess with a mortality of up to 40%. It's an important cause of community-acquired sepsis in Southeast Asia. So these are the multiple organ can be involved. I'm just skipping it. So these are the risk factors I discussed. And I think this one way can mimic like tuberculosis. So very, very commonly it's mimic like tuberculosis. So these are some cases of perhaps skin, subcutaneous abscess, bilateral effusion, cavity. And one of the author is sitting also, Dr. Sujata is sitting also, one of the patients post-COVID vaccination. So we have a Burkholderia long abscess. And we have another patient, I think this September, with a patient with both Burkholderia and there's a osteomyelitis, and there's a co-infection of leptospirosis. So this is one patient. If the patient survived, actually it was very bad condition sepsis, Another patient told, I think some days back, it was there with just having cavity, small, we do not have much to say, just we mimics, we never, it's come by culture positive. Sir, I'm finishing it, sir. And so this is again, this is largest series from London, Australia. The next recently come up to be published in 2023. This come 2 days before. So this is again, the largest series is from, that is from Thailand. These are the symptoms. I'm just skipping those slides. This can be bacteremia without evidence of focus. I'm skipping. So it can be big, great mimicker or musculator like from tuberculosis. Even, I think one of the big, great ID specialist published recently in this year. So they said even after 1,000 they could not diagnose that is a, so it's a wide range of clinical presentation, highly variable incubation period, great mimicker, it's enigmatic. So that means it's a, I mean, you don't like COVID, it's a very enigmatic. So I can say read it up in a mystery inside an enigma. So what I mean to say to the audience, this mind, what mind doesn't know, I cannot catch it. So we need to be very careful, thinking what alternative. Investigation, I think, do not have to skip. Culture is the only one. And treatment is which drug, how long, and what is the duration. Treatment is, and this, I'm telling the classical, where you suspect, these drugs are inherently resistant to any bacteria having like Pseudomonas or gram-negative bacteria, inherently resistant to aminoglycoside, polymyxin, and colistin. As a culture report getting, then suspect microbiology report. You need to modify, possibly that's a clue, and treatment is very straightforward. Start cryptogenium, septagenium, moripulum, or imipenem, and followed by the 2 weeks to 4 weeks, depends on the organ involvement, and to be like tuberculosis, you have to give a maintenance treatment. So prevention is one of the best way I can say that you can prevent. The health education should be at least get prevented. This is again published a few days before. I'm skipping this slide. Vaccination is possible, but not at come. So this is one of the publications. We have published 7-page article in the regional health. So this can be freely available. And with our faculty, I took around 21 faculty from our institution with different cardiology, many other departments. We collected this book is coming, this clinical mediodosis. I think the first clinical book to come available on this topic. With this, I think I should. So one of the issues that this number is too low, it's yet to be known as entity, not on when it's actually truly issue that truly it is unrevealed endemicity. So it is yet to come under entity. That means there is a publication. So what is our effort? Our effort to raise my effort is to raise awareness, and it will continue, and to reveal the unrevealed. So this is what means we think it's possibly tuberculosis, sepsis. It may be, Mike says, can be melioidosis. With this, I conclude that the cases are increasingly reported in India. Data is not available because we do not have data. I've been saying cases are diagnosed from Hyderabad, but never even diagnosed in coastal Andhra. This means disease is not there. I think largest series in 3 boards, Thailand could publish around 2,500 cases of, we do not have, but I think climatically is no way different from the coastal area in Thailand, and geographically also same region. So disease burden likely to increase because more diabetes are there. You know that India is diabetic capital of the world, and cyclones are very prevalent. Global warming is going on, and more of the technology of diagnosis, I think MALDI and other diagnostic techniques are coming in India, and lab are microbiologists are more aware of this disease. I mean to say, give an example from the students who have passed out from AIMS Bhubaneswar, even they are going Sambalpur and the Baragarh, they have diagnosed series of cases now. Disease is there. We are unable to pick up. This is my way of saying. The burden of melioidosis, this last one is burden of melioidosis that reveals the gaps in dealing with the disease. That is truth. With this, I thank you. Sorry for 2-3 minutes late. Please, you can ask. I may not answer, but I try to answer.
Thank you, Professor Prashant, for highlighting the importance of melioidosis in our society. Actually, in a 2016 model study, they have found that the world yes would be 1,65,000, whereas it is reported only in 1,300 cases. So in India, they are predicting, according to that model, it should be 52,000 per year. But hardly we are reporting in EA. So what he told, what mind does not know, probably eyes do not see. So this is a eye opener. So any questions or?
It's a nice presentation. Thing is that why people are not picking up, this is the microbiologist support. The institute having microbiology support can do it, because there is no card test. There is only you can suspect multiple abscess in a person, multiple abscess, maybe liver, maybe spleen, maybe prostatic, lung abscess, multiple abscess. So think of melioidosis. Not only we are thinking of Staphylococcus aureus, melioidosis and lab backup, particularly microbiologist backup.
Yes,
so
true.
this is the credit of microbiologist. In the institution having microbiologist poor, that is very difficult to pick up.
Even if microbiologists, if they don't know also, they will not pick up, because you have to culture it for a longer period. If you are picking it up in third day, you will probably think it as E. coli.
Issues again, as I forgot, the slide was there, I could forget. So even if with the best culture technique, the yield is around 60%. That is fallacy. So if, that means 40% case means like COVID. It is less than COVID also, like artificial COVID. And we are going to miss it. Again, it's clinician awareness. Unless clinicians support, we can say. See, patient has multiple abscess. You take bowel sample, you take liver aspirate, you take splenic aspirate, you take whatever aspirate, prostatic aspirate. So send multiple sample. And there is one lateral flow test is coming up. So that is really going to help the getting diagnosis. So even if the microbial support is must, but most important is clinician to give microbial. I am suspecting, in my own department, we suspect that I am suspecting melioidosis, one of the differences. It is the clinician to hit microbiologists that we need the diagnosis.
Yes, but that can happen only in big institutes like maybe SCV.
Yes,
in
that's
SCV, we are thinking to aspirate, but it's very difficult to aspirate, you know, there are a lot of hazards.
Issues,
so
I know.
clinically, many physicians are intensive. They straight away start from meropenem, 10 days, 15 days. By that also we are missing a lot of cases.
I am telling two doctors, one medicine specialist. He come with a bilateral highlight lymph node, thinking of tuberculosis and ATT. Fever didn't go out. And we did a EBOS, endobronchial ultrasound aspiration, and aspiration material culture come positive. And that patient, that means doctor was really, happy to know that he could diagnose and get treated. It's only 1.5 years back. And the case was published.
Congratulations.
Shall I ask?
Yes, Doctor.
Share my something.
Yes, you have also good experience with us. You are in our team.
Recently, one patient present with PO-like presentation. 3 months, 2 months fever, nothing is there. Means reports means only LFT drains little bit. Everything we are thinking maybe something lymphoma will come. Always we across PO-like presentation, always think something NHL will come. Then I send all liver biopsy. Then gradually bicytopenia is there. Then we send bone marrow biopsy, and as there is liver enzyme deranged, then I also patient platelet is low. Then we thought maybe patient is going towards HLH, hemophagocytic lymphohistiocytosis. So for that we have evaluated. It was positive. 5 criteria was positive. Bone marrow sent, and then little bit as to save the life, as patient is deteriorating, we are not conclusive because all the reports, blood culture, everything sent. Then little bit because so many patients who lost. Because NHL, before we diagnose the case, we almost lost. So I have started dexamethasone 4 mg BD. Then platelet improved to 1 lakh, and pancytopenia, bicytopenia improved. Then immediately I have done liver biopsy. Then liver biopsy, then patient fever improved for 4-5 days. Then after 5 days, the report came to be Burkholderia pseudomallate, blood culture report. But patient liver biopsy report said that it is HLH. Bone marrow biopsy is not HLH, but liver biopsy showed it is HLH. So we have treated with Rexona. That's why patient responded. Patient improved. So then again fever appeared because of there is Burkholderia. Then you have started with antibiotic. Patient improved. Patient is now also in our hospital now. Then this is a septicemia form of Burkholderia, which is presently like PO. And now after 15 days, patient is complaining my hip is paining. So he developed septic arthritis of the right hip.
Exactly.
Maybe during the illness, during hospitalization only.
And it's,
So
see,
this is-
1 year before also,
So this is also a
we have
form
also
of
HLS and
septicemia.
Diagnosis is important in the sense because we are giving meropenem thinking of most of the gram-negative septicemia and
Yeah.
the importance of diagnosis is that how long and then to
Exactly.
treat with
exactly.
cotrimoxazole for another 3 to 6 months. That is more important because the recrudescence and recurrence is very high.
Yes, if you give only few days and patient will come back after 2-3 months with problem. But madam, we have also same, we have HLS plus Warcoldria, 1
Sir,
year, 1.5
HLS,
years.
this is the first case.
No,
actually
we have a
diagnosed.
case, we had
And
a
that
case,
also-
he is
okay, you are
publishing,
having-
my SR is
That
publishing.
also diagnosed by liver biopsy, not also this.
That
Okay.
case
bone
we
marrow
got
biopsy.
it from BAL, that cause
Sir, another case is there, neurowarcolderia. This is
Neurowarcolia
presented-
is very common, very common.
Not sir, it is not also very common. We got 2 cases. One case died just 1 year back, but now patient is now we are having one case. Neurowarcolderia that mimic totally like tubercular meningitis. Sees a picture like lymphocytic tubercular meningitis that came to be Warcolderia and treating patient is improving now. Hemiplegia presented with hemiplegia. And all.
I discussed with neurologist because my side ward was side ICU was neuro ICU, and they were so much interest to extension. I think 1 year many patients has been they have series of cases of neuromyelitis. Please, Dr. Mahanta, please.
Sir, thank you, Dr. Prashant Mahapatra, for presenting this case. I am a pediatrician. I think I am the only pediatrician here attending this conference. I wanted to know if you have encountered any melioidosis cases in children.
Many cases are published, but we do not deal with pediatrics. That is the issue. But cases are there. I'm saying cases are there in SCB, rural area, everywhere there. Cases are there. Cases, no less. But whether able to diagnose the patient are ultimately dying. Mortality is 90% if you don't treat. I mean, it's not like that pneumonia or TB automatically ठीक हो जाएगा. वो बात नहीं है. So, the patient is ultimately going to die with a chronic disease.
Okay, we will close this session
Sir,
because we are running out of the time. The sir will.
Hello. Now invite Professor Ashok Kumar Malik, Professor and HOD Postdoctoral Department of Neurology, SC Medical College, Cuttack. He will speak on memento. Last. He will speak on subarachnoid hemorrhage. I will tell something that in our undergraduate days, subarachnoid hemorrhage was diagnosed by severe headache. Then another was there is a meningitic syndrome, lumbago sciatica syndrome. We started our life with this. We do a serial lumbar puncture where you will do the blood, then you centrifuge it, see the RBCs, see the color of this and that. At that time, CT scan was just starting. Even in CT scan, the many cases of subarachnoid hemorrhage, if there is small amount, it could not be diagnosed. Now the time has changed. Now Professor Malik, who has a huge experience, he has a long years, he has stayed here. And the imaging technique has advanced very much. The treatment has changed extensively. I know many experiences of being interesting cases of subarachnoid of VIP patients, how they are diagnosed and how they have been cured. And everything has now changed in subarachnoid hemorrhage. Whether it is a medical disease or a surgical disease, neurosurgical disease, that is a highly, there are indications everywhere. I invite Professor Malik to speak on this subject.
Thank you, Chairpersons, Professor Mahapatra and Satish, and respected teachers of the dais and on the dais, my students and colleagues. So, actually, subarachnoid hemorrhage is a surgical emergency, and many patients presenting with subarachnoid hemorrhage to the neurology department or medicine department, if they are referred in due time, many lives can be saved and mortality and morbidity will be very less. But nowadays, as Professor has told, there is much advance in the diagnostic procedures and treatment also after coming neurosurgical clipping and endovascular coiling. So there is a very gross improvement in the treatment guidelines also. So previous guidelines, now previously the treatment and clinical diagnosis as before it was there, but now there are many new drugs for treatment of vasospasm and delayed cerebral ischemia are on the trial and many are on the pipeline. So I will mainly focus on these drugs as well as the newer modalities of treatment and what are the newer modalities of the investigations. But before coming to this, so let us know what is subarachnoid hemorrhage are mainly of two types, spontaneous subarachnoid hemorrhage and traumatic subarachnoid hemorrhage. Spontaneous subarachnoid hemorrhage, that is included in the intracerebral hematoma, like intracerebral hematoma, intraventricular hematoma, spontaneous hematoma, that is hemorrhagic stroke, as well as subarachnoid hemorrhage, and sometimes they are mainly due to aneurysms. And some subarachnoid hemorrhages are also non-aneurysmal rupture also, and very many small aneurysms are there. In chronic hypertensive patients, the commonest cause of intracerebral hematoma or site of intracerebral hematoma is basal ganglia. And what happens in basal ganglia, that is supplied by the perforating branches of the middle cerebral artery. And in chronic hypertensive patients, that undergoes lipohyalinotic changes and amyloid angiopathy. So that also causes sometimes very small aneurysms. That is also known as Charcot-Bouchard aneurysm. These aneurysms also rupture and give rise to intracerebral hematoma. But that aneurysm rupture is not included in the subarachnoid hemorrhage. That is mainly due to aneurysm rupture. And so basically this is a layer. So this is the so blood in the subarachnoid space is subarachnoid hemorrhage mainly. So there are classification of strokes already I have told. Then mainly subarachnoid hemorrhage etiology, excluding head trauma, the most common causes of subarachnoid rupture of the saccular aneurysm. Other causes include bleeding from vascular malformation, arteriovenous malformation, and dural arterial venous fistula, extension into the subarachnoid space from a primary intracerebral hematoma, sometimes also cause subarachnoid hemorrhage, and mycotic aneurysm due to infection, and infected embolism due to bacterial endocarditis also cause septic degeneration, arteries and subsequent dilatation and rupture, that is also included in subarachnoid hemorrhage. And coming to saccular or berry aneurysm, so these are the three types of aneurysm. This is saccular aneurysm, this is fusiform aneurysm, and this is the rupture aneurysm. This is the dome of the aneurysm has ruptured, and that causes bleeding in the subarachnoid space. And this is also another, that is saccular aneurysm. This is the dissecting aneurysm of the aorta. This is the fusiform aneurysm, and this is sometimes known as dolichoectasia, that is the tortuous dilated blood vessels. That also causes sometimes blood in the subarachnoid space. So why an aneurysm is formed? That is the mechanism of formation of aneurysm. One theory is that they result from a developmental defect in the media and elastica. Other theory says that aneurysmal process is initiated by the focal destruction of the internal elastic membrane caused by hemodynamic forces acting at bifurcation are left with major neurological deficit as a result of initial hemorrhage, cerebral vasospasm with infarction or hydrocephalus. Then what is the cause of saccular vein aneurysm continued? If the patient survives but the aneurysm is not obliterated, the rate of the rebleeding is about 20% in the first 2 weeks, 30% in the first month, and about 3% per year afterwards. Then what is a giant aneurysm? A giant aneurysm, those more than 2.5 centimeter in diameter, account for 5% of the cases. The three most common locations are the terminal internal carotid artery, middle cerebral artery bifurcation, and top of the basilar artery. And their risk of rupture is 6% in the first year after identification and may remain high indefinitely. So what is the pathophysiology? Then saccular aneurysm occur at the bifurcation of the large to medium sized intracranial artery, and rupture is into the subarachnoid space in the basal cisterns and often into the parenchyma of the adjacent brain. Approximately 85% of the aneurysms occur in the anterior circulation, mostly under the circle of Willis. About 20% of the patients have multiple aneurysms. Many are the mirror sites bilaterally. So these are the commonest sites of the aneurysm. Anterior communicating artery 40%, internal carotid artery 20%, middle cerebral artery bifurcation 34%, and posterior cerebral artery, that is 4%. So this is the aneurysm rupture, rupture from the dome, and it causes the compression of the vessel wall. So these are the blood RBCs, and there occurs vasospasm at these sites. Then coming to clinical manifestations, most unruptured intracranial aneurysms are completely asymptomatic. And aneurysms can undergo small rupture and leaks of blood into the subarachnoid space, so-called sentinel bleeds, which are asymptomatic sometimes. Symptoms are usually due to rupture and resultant subarachnoid hemorrhage per se, although some presented with mass effect on the cranial nerves or brain parenchyma. So, what is the clinical manifestation? So, with rupture, blood at high pressure gushes in the subarachnoid space, resulting in following three patterns of presentation. So, it's a severe headache. Patient will present with severe headache, generalized headache, and that is the first headache, in a severe excruciating headache. And patient may present with neck stiffness. Due to the blood in the subarachnoid space, the patient will present with signs of meningeal irritation, mainly neck stiffness. Rarely, patient suddenly becomes unconscious with any preceding complaint. If the bleed is massive, but patient may die in minutes to hours. So, in these patients, evolving cases, the bleed is so massive that intracranial pressure approaches systemic blood pressure, thus severely compromising the cerebral perfusion. That is why there occurs coma. So, in less severe cases, consciousness is lost. Residual drowsiness, confusion, and amnesia accompanied by severe headache may persist for several days. So, this is the diagram showing a severe occipitonuchal headache, severe excruciating headache. So, pain at other sites may occur due to subarachnoid hemorrhage. So, occipital and posterior cervical pain may signal a posterior inferior cerebellar artery or pica or anterior inferior cerebellar artery aneurysm. Pain in or behind the eye and in the low temple can occur with an expanding MCA aneurysm. At the moment of aneurysmal rupture with major subarachnoid edema, the ICP suddenly rises. This may account for sudden transient loss of consciousness that occurs in nearly half of the patient. In 10% of cases, aneurysmal bleeding is severe enough to cause loss of consciousness for several days. Patient will be in coma. So, what are the clinical manifestations? Focal neurological deficit. Although sudden headache in the absence of focal neurological symptoms is the hallmark of aneurysmal rupture. Most of the cases of subarachnoid hemorrhage, patient will have severe headache without any neurological signs except the signs of meningeal irritation, that is neck stiffness. An anterior communicating artery or MCA bifurcation aneurysm may rupture into the adjacent brain of subdural space and form a hematoma large enough to produce mass effect, that is due to subdural hematoma sometimes. And the common deficits that result include hemiparesis, aphasia, and abulia. Then most common is third nerve palsy. That is ptosis, diplopia, dilatation of the pupil and divergent squint indicates an aneurysm at the junction of the posterior communicating and posterior cerebral artery. A sixth nerve palsy may indicate an aneurysm in the cavernous sinus, but unilateral bilateral palsy could be because of raised ICP. Unilateral blindness indicates aneurysm lying anteromedially in the circle of Willis, usually at the origin of the ophthalmic artery. So these are some localizing signs of diagnosing aneurysm. Then the size of aneurysmal rupture may be indicated by monoacular pain, unilateral preponderance of headache on unilateral pre-retinal or subhilar hemorrhage, that is known as torsion syndrome. Then patient headache, differential diagnosis, thunderclap headache due to migraine headache. So severe explosive onset may also be caused by ingestion of sympathomimetic drugs, and those patients having ingestion of tyramine containing foods in a patient who is taking MAO inhibitors. And sudden severe headache may also be a symptom of pheochromocytoma. These are the different. So other conditions which may present as severe headache need to be differentiated, like cerebral venous thrombosis, diffuse vasospasm, and pituitary apoplexy, hypotensive encephalopathy, intracranial or extracranial arterial dissection. And CSF examination assumes great importance in differentiating these conditions from subarachnoid hemorrhage, because subarachnoid hemorrhage, if you do the CSF, there will be uniformly hemorrhagic blood in collecting 3 samples. There are 4 major causes of delayed neurological deficit, rupture, or these are the complications, maybe complications of the subarachnoid hemorrhage, rupture or rebleed, hydrocephalus, and symptomatic cerebral vasospasm and hyponatremia. So this is the tendency for the hemorrhage to recur from the same site in more than 1/3 of patients. The incidence of re-rupture of an untreated aneurysm in the first month following subarachnoid hemorrhage is 30%. And re-rupture is associated with 60% mortality. And coming to hydrocephalus, 3 types of hydrocephalus may occur: acute hydrocephalus, subacute hydrocephalus, and chronic hydrocephalus. So acute hydrocephalus can cause stupor and coma and can be mitigated by placement of an external ventricular drain inside the ventricle, but that is in EVD. So more often, subacute hydrocephalus may develop over a few days or weeks and causes progressive drowsiness, slowed mentation, abulia with incontinence. It may clear spontaneously or require temporary ventricular drainage. And chronic hydrocephalus may present like normal pressure hydrocephalus, that is manifestations of the gait difficulty, incontinence, and impaired mentation. So patient may require ventricular shunt. Then coming to delayed cerebral ischemia. So cerebral vasospasm after subarachnoid hemorrhage is the delayed occurrence after the hemorrhage. So cerebral vasospasm most frequently occurs 7 to 10 days after the hemorrhage and is therefore also called delayed cerebral ischemia. Vasospasm initiated by the release of oxyhemoglobin, one of the blood breakdown products, and chemicals such as free radicals, lipid peroxidation, and release of endothelin-1. These are some of the mechanisms of vasospasm. Then there is another complication is hyponatremia. So hyponatremia may be profound and can develop quickly in the first 2 weeks following subarachnoid hemorrhage. There is both natriuresis and volume depletion with subarachnoid hemorrhage, so that patients become both hyponatremic and hypovolemic. Both atrial natriuretic peptide and brain natriuretic peptide have a role in producing the cerebral salt twisting syndrome. So what are the systemic changes that is manifested associated with subarachnoid hemorrhage? So some ECG changes. Though ECG changes may be QRS complex change, ST elevation, and there is evidence that structural myocardial lesion produced by circulating catecholamines and excessive discharge of sympathetic neurons may occur after subarachnoid hemorrhage, causing these ECG changes and a reversible cardiomyopathy, but after treatment the patient may recover. So coming to the investigations, so more than 90% cases have enough blood to be visualized in a high quality non-contrast CT. Scan obtained within 72 hours. So these are the bleeding sites. There is a hematoma also. Say a good quality CT scan can diagnose 95% of the subarachnoid hemorrhage if done within 6 hours. So this is the this is the subarachnoid bleed. So this is the perimesencephalic cistern. This is the Sylvian cistern. So you should see blood in all the systems like prepontine system, suprasellar system, perimesencephalic system, sylvian system, sometimes in the sulci also, and sometimes in the interhemispheric fissure. So blood, it is a plain CT scan of the brain. This is the hyperdense lesion. This is the calcification. This is the hyperdense. Then other imaging protocols are CT angio, MR angio, but CT angio is better than MR angio. If we can't diagnose by all these methods, so DSA, digital subtraction angiogram with the contrast dye in the carotid and basilar artery is the gold standard diagnostic procedure for therapeutic, diagnostic as well as therapeutic procedures. So DSA. So then coming to managing protocols as well as protecting the airway, managing blood pressure, preventing rebleeding prior to treatment, managing vasospasm, treating hydrocephalus, treating hyponatremia and preventing pulmonary embolus. So for headache and neck pain is severe, mild sedation and analgesia are prescribed. So extreme sedation is avoided because it can obscure the changes in neurological status. Adequate hydration is necessary. So sometimes intracranial hypotension following aneurysmal rupture occurs secondary to subarachnoid blood, parenchymal hematoma, acute hydrocephalus, loss of vascular autoregulation, perilesional edema or infarct may occur after vasospasm. So managing raised ICP, you can manage the raised intracranial pressure by giving mannitol, hyperventilation, like other causes where we can reduce the pressure in stroke patients also. So then blood pressure management is very important. So most of the guidelines, American Heart Association and American Stroke Association tell that, so blood pressure should be less than 160 systolic because to balance the risk of ischemia and rebleeding. And Neurocritical Care Society states that extreme hypotension in subarachnoid hemorrhage should be avoided and suggest maintaining a mean arterial pressure of less than 110 millimeter of mercury. So vasospasm management can be done as previously. Very old drugs like nimodipine is the gold standard drug. So given 60 milligram per orally every 4 hours for 3 weeks. And managing hydrocephalus, acute hydrocephalus can be managed by external ventricular drainage and subacute by ventricular drainage also, and by chronic hydrocephalus by VP shunt. So role of steroid, so there is steroid, some guidelines are there regarding use of steroids, but there is no role of steroids in managing subarachnoid hemorrhage patients. So then coming to the interventional management nowadays, so early aneurysm repair prevents re-rupture bleeding and allows the safe application of techniques to improve blood flow. So induced hypotension and hypervolemia should symptomatic vasospasm develop, and aneurysm can be clipped by a neurosurgeon or coiled by a endovascular surgeon. So coming to the Hunt-Hess scale, so this is helpful in assessing the patient before deciding for interventional management. So grade 1 mild headache, normal mental status, no cranial nerve. Grade 2 severe headache, normal mental status, may have cranial nerve deficit. Grade 3 somnolent, confused, may have cranial nerve, mild cranial nerve, motor deficit. Grade 4 stupor, moderate to severe motor deficit. And grade 5 coma, reflex posturing or flaccid, GCS score 3 to 6 with or without motor deficit. So accordingly, you can manage, the neurosurgeons can manage. So coming to the surgical repair, it involves placing a metal clip across the aneurysm neck. So this is the aneurysm neck. So this is the metal clip. So, but immediately eliminating the risk of rebleeding. This approach requires craniotomy and brain retraction, which is associated with neurologic morbidity. And managing based on scale, it is very, so this is the endovascular techniques. So this involves placing platinum coils or other embolic material within the aneurysm via a catheter that is passed from the femoral. So these procedures are done by endovascular surgeons or sometimes by neuroradiologists also, and in some places also by neurologists. So they put the coils. So these coils causes thrombosis. So aneurysm pack tightly enhance thrombosis and over time walled off from the circulation. The benefit of endovascular therapy is durable. However, some aneurysms have a morphology that is not amenable to endovascular treatment. Thus, surgery remains an important treatment option. So this is the international subarachnoid aneurysm trial. Now the trial has been stopped because they found there is no difference between the coiling and surgery, and most of the patients died during this treatment and trial. This treatment has been stopped. That is the only comparison treatment between endovascular coiling as well as clipping. So management guidelines: bed rest, maintaining a clear airway, management of blood pressure adequate. 1/3 of patients are prone to develop rebleed, which can be effectively taken care by intervention and modality. Then clipping versus what is the importance of clipping, which is good. So clipping is associated with a higher rate of occlusion of the aneurysm and lower rates of residual and recurrent aneurysms. And coiling is associated with lower morbidity and mortality and a better post-operative course. This risk and benefits of each of these procedures must be thoroughly examined in each case. There is no good randomized control trial with more number of patients. So what are the recent advances in in stem cell research? This is still in the animal model test. So early findings in subarachnoid induced animal model suggest beneficial effect in mesenchymal stem cells, and outcomes is given within 2 hours and up to 6 days following hemorrhage. So mesenchymal stem cells appear to exert their effects at the cellular, morphological and functional level. So this may be a future perspective for managing subarachnoid hemorrhage, stem cell transplant. So then ultra early, what is the role of antifibrinolytic drugs? So previously,
Try to conclude.
Sir. So previously when we were students and Dr. Podhier was assistant professor, Dr. Professor CSA was my professor, we used to give a large dose of epsilon aminocaproic acid intravenously. So what was the result, we don't know, but nowadays this trial is going on. So this is the ultra tranexamic acid after subarachnoid hemorrhage, but the trial is not still complete and there is no result, they have not got any result. So another symptomatic to treat cerebral vasospasm after nimodipine, so nicardipine, verapamil, vasodilators like fasudil, then antispasmodics, papaverine, these are the drugs which are on pipeline, they are under trial. And tranexamic acid and aminocaproic acid are all on still trial basis. Then, so this is the main systemic, sometimes causes symptomatic complications like systemic inflammatory response syndrome. So this is mainly IL-1 and IL-6 mediated. So sometimes tocilizumab and anakinra IL-1 antagonist drugs are on trial also. So conclusion to sum up is, so subarachnoid is a neurological emergency. It is less common but an important cause of stroke, 5%. Saccular and Benny aneurysms rupture is the commonest cause of subarachnoid hemorrhage. Most common presentation is an excruciating headache which needs to be differentiated from other causes of severe headache including thunderclap migraine. CT scan is very helpful in making a diagnosis and differentiating it from other headache of severe intensity. If CT scan is negative but there is strong suspicion of subarachnoid, then one should go for CSF examination. If other CT scan and CSF are inconclusive, then cerebral angiography is the last resort. And complications include re-rupture, hydrocephalus, vasospasm and hyponatremia. So advances in neuroimaging has improved the simplified the diagnosis of subarachnoid hemorrhage and contributed to improving the outcome for patients having subarachnoid hemorrhage by allowing earlier and more frequent diagnosis of minor hemorrhage. Nimodipine and endovascular aneurysm repair are the only treatment based on high-level evidence. Thank you for patience hearing.
I will just take 3 lines. Interesting thing I will tell about the Caprostat we are giving. Caprostat, we half of our teaching career, 15 years, we gave Caprostat. Then book was written, it produces a clot. Caprostat, you are producing a clot. Then told clot causes spasm, so you are causing harm. Then we started giving nimodipine. We do not know the result. The summary of diagnosis of subarachnoid hemorrhage for physician is, if a patient comes with headache, with unconsciousness, without neurological deficit, with no fever or maximum fever that was defined earlier as less than 101 or 100, we clinically should diagnose as a subarachnoid hemorrhage. The patient should be in emergency. They are immediate and no question of doing an LP nowadays. Go for an imaging technique. If you diagnose subarachnoid hemorrhage, very easily can be diagnosed by modern imaging techniques. If you diagnose subarachnoid hemorrhage, immediately refer the case to a neurosurgeon. There is no second treatment for neurosurgery. But only thing, everything here is a if and but. There is no neurological emergency, there is no neurosurgical procedure, there is everything. We know a very good experience. Professor Dawai and anybody who was at Burla in 90s, they can tell. A VIP patient was admitted with a subarachnoid hemorrhage, diagnosed first as meningitis, then there was a problem, diagnosed as subarachnoid hemorrhage. Chief Minister sent an aeroplane. He used to be transported to All India Institute, but the person could not go, he became late to attending, he could not reach Sambalpur from Burla. There he attended late and there was a lot of complaints. So summary is, once it is subarachnoid hemorrhage, everything can be done. And in the emergency room itself, now emergency care must be developed, which is lacking in most of the hospitals in Odisha at least. I do not know. Casualty is not emergency. Emergency hospital is a big thing.
Running short of time. The thing is that subarachnoid hemorrhage is definitely, as Professor Sasiva was told, that it is a neurosurgical emergency, but all cases cannot be sent to neurosurgical units.
Yes.
If it is a very higher grade of unconsciousness, grade 3, 4, 5, 6, 5 up to 5 he has gone. So up to 3 maximum, they can be sent to neurosurgery. But 4, 5 cases cannot go because they are hemodynamically unstable. Then the question comes about treatment. About the treatment, he has told 2 things. One is clipping, another is coiling. Clipping, everybody is telling, as he has already mentioned, clipping, there is a lot of danger about clipping and mortality is high. Then comes coiling. My very recent experience within last 15 days is that in Apollo Hospital, I will not tell which place, a case was coiled. But after coiling, during coiling, the surgeon, the endovascular surgeon told me that the patient will develop big vasospasm and there will be a big infarction. Yeah. Then in the next morning, they did the MRI, there was a big infarct and they did craniotomy. Then after 7 days, the patient died. So this is the result of the endovascular coiling.
In experience, because they are learning now. Just like in ischemic stroke, sending a clot above. This also happens. So they are in a growing stage. So that problem is occurring now. It requires a lot of experience actually.
Yes, sir. Most of the endovascular surgeons are putting 3 or 4 coils. Is Bhubaneswar also there? Yes. But immediately the neurosurgeons are not doing the clipping surgery. That is why we need endovascular surgeons. They are coming from Hyderabad to do endovascular coiling. In Odisha, it has not developed so much. But many trials are telling that coiling is better than clipping, because in clipping we have to open the brain, craniotomy to be done, and most of the structures, brain structures, may be involved during surgical procedures. Sir? Coiling cost is more. Coiling cost is more. 7 to coiling cost is more.
What can one district hospital doctor, DHS level doctor will do if he diagnose subarachnoid hemorrhage?
No, he will diagnose subarachnoid by if the CT scan is available. If CT scan, there is broad CT scan definitely subarachnoid hemorrhage one can diagnose if there is a bleeding. Only all the fissure base of the brain there will be blood. So he can manage conservatively.
Call 108 ambulance, sent to SC Medical College, failed, go sent to somewhere hospital. Thank you all.
John.
Thank you, esteemed dignitaries, for your enlightening speeches. This brings us to the end of the session. I would request our chairpersons to kindly proceed to the memento podium for their felicitation. The next session is the API Presidential Address. I would like to invite the chairpersons on stage. Professor Gadadhar Ray, ex-professor of medicine, Cuttack. Professor R.K. Dalai, professor of medicine, High Tech Medical College, Bhubaneswar. Professor D.M. Tripathi, professor of medicine, High Tech Medical College, Bhubaneswar. Professor Siddharth Mishra, professor of medicine, KIMS, Bhubaneswar. I would request the chairpersons to kindly come on stage.
Good afternoon, everybody. And we are having the most important session, which should have been started as a tradition, but they have this time, Dr. Ponda has changed a little bit and he has sacrificed his talk for others because they have demanded to go early, and we are coming to the last phase of the conference, and Professor Ponda, who is the chairman of API, he is also the chairman of scientific committee in addition to Dr. Odisha, and he will be talking on the non-diabetic hypoglycemia. You know that diabetes is associated with hyperglycemia, but due to some drug reactions like oral drugs or due to insulin, you get hypoglycemia. But he will be talking on non-diabetic hypoglycemia. Dr. Ponda, please proceed on your topic.
Thank you, sir. As Professor
all three chairpersons are your teachers,
yes,
and we feel privileged and proud of you. The chairman's address is being done without the VA, but all your teachers are there just to encourage you, and you just don't take it. Whatever you will tell, that will be a message to the physician.
And let me say, you are the first postgraduate student of mine in Barampur, and I am proud that he has succeeded in every aspect.
Thank you, madam. Actually, today morning I was telling, we are so well groomed by our teachers that we wanted to lead the physicians. But we have failed to groom our coming generation, so we don't have youngsters in the hall. So we ourselves have proved worse teachers than our teachers. many of whom are here. Dipti ma'am is my postgraduate teacher. Professor Dale is my undergraduate teacher. and Professor Rai is a friend, philosopher, guide all throughout. So I thank the chairpersons. Actually, as Professor Rai has told, this should have been in the prime hour yesterday, and usually the session begins with the chairman's oration. But I'm also the chairman organizing committee, and we decided the organizing committee and the scientific committee chairman will not take talks. Professor Padhiyari was not willing. So we had to accommodate people who are respected and important sessions, and in view of the circumstances we have postponed, but I have to speak because it's customary that chairman's address will be given. But I'm just taking 10 minutes and I'll give the gist of the talk. I have revised my slides, and I'm sure the chairman scientific will take 10 minutes to speak his part so that we both of us take one session's time. So first of all, when we speak of hypoglycemia, all of you think of diabetes. We have encountered n number of times hypoglycemia in diabetes. But I have taken out that case story. I have presented a case of my ICU, which all my postgraduates and faculties know. A patient gave us 1 month time. We could not prove diabetes, and he died in hypoglycemia. Then we started working, and I have now 3 patients of non-diabetic hypoglycemia, and my chairman's address based on that particular case, and I'll give you an impression that hypoglycemia can also be in a non-diabetic setting. If that message goes, my presentation is done. I'll just take 9 more minutes. You know, less than 50 mg% is hypoglycemia. This is the definition. But adult and pediatrics, less than 57% in adult, but in infants it's 30 to 50 milligram per deciliter. And the neurologic and electroencephalographic depression in non-diabetic patients comes in a lesser level than the diabetic patients. 70 to 85 mg% in diabetic levels, and the 50 to 55 milligram per deciliter in the non-diabetic levels. And in pregnancy, in prolonged hypoglycemia, in patients who have fasting, prolonged fasting, the venous glucose can go still lower and you may not detect. So this is the definition. Remember about Whipple-Strad. It has been internationally advised, don't brand hypoglycemia without Whipple-Strad, which is very rational. There should be symptom, there should be a documentation, and there should be an improvement. The same thing as Koch's postulation. There should be symptoms of autonomic as well as neuroglycopenic. You should document it not in glucose monitor, but in a precise method, and after correction, the symptoms should go away. And the most important thing is knowing the diagnosis. Diagnosis can be fasting, can be reactive. The post-absorptive hypoglycemia is the fasting hypoglycemia, and the postprandial hypoglycemia is the reactive hypoglycemia. Remember, even after taking food, there can be hypoglycemia. And I'll tell you the mechanism. Fasting, it's obvious, but how postprandial? And it's a very interesting classification when the patient is well appearing, when the patient is ill appearing. Things are different. If patient is looking healthy, you think of drugs like insulin, alcohol, and the other drugs. I'll tell how alcohol causes. Many of my postgraduates asked, the alcohol has 7 kilocalories per gram. Why the person is having hypoglycemia? Because it blocks the glycogenolysis. I'll tell you. The accidental or surreptitious or malicious hypoglycemia, where patient has consumed exogenous insulin, the endogenous hyperinsulinism like insulinoma, functional beta cell disorders, the non-insulinoma, pancreatogenous hypoglycemia, and the post-gastric bypass hypoglycemia come under this category. We'll touch upon. And the insulin autoimmune hypoglycemia like anti-insulin antibody and anti-insulin receptor antibody, the idiopathic postprandial hypoglycemia. The drugs, when person looks ill, you think of drugs, insulin or insulin secretagogues, alcohol or others I'll discuss. Critical illness like hepatic, renal and cardiac failure, sepsis, the hormone deficiency, the cortisol, glucagon and adrenaline will touch upon, and non-islet cell tumors. This is the basic classification where you get a hypoglycemia without diabetes. Clinical presentation I'm not going, all of you know. This can be neurogenic, this can be neuroglycopenic, and neurogenic is mostly autonomic. The Endocrine Society has come with a list, what all we discussed. First is the Whipple triad, then is the drug, critical illness, hormone and non-islet tumors, then how to approach the patient we'll discuss in the subsequent slides. This is a very important slide when there is an exogenous insulin-induced hypoglycemia, which has not been given in history by the patient. You get increased insulin, decreased C-peptide and decreased proinsulin. When there is an insulinoma, you get increased insulin, increased C-peptide and increased proinsulin. This is the differentiation you can do by these investigations. When it's a OAD-induced hypoglycemia, again you get all three increased, so also autoimmune, anti-insulin antibody, you get all three increased. So this is what I told you in a nutshell, the apparently ill and the apparently well. So this is the drugs, critical illness, all we have discussed, the approach. Just in 30 seconds, I'll cover the diagnostic tests. Initial evaluation, history is very important. Whipple's triad I spoke you. Patients with hypoglycemia typically present with a history of spells. The ACTH level should be performed. It's a must. I'll tell why. CGM is mandatory in the people whom we want to prove the time of hypoglycemia, mixed meal testing, glucagon tolerance test, and the gold standard test in the evaluation of hypoglycemia is the 72 hours supervised fast. We recreate the situation where the hypoglycemia took place, testing for autoimmune hypoglycemia, C-peptide suppression test, imaging, and selective pancreatic calcium stimulation with hepatic venous sampling is a test. Most of the tests we can do in our setup, and you can diagnose the patient. Unfortunately, we failed and the patient died. Just 2 minutes regarding hypoglycemia causes. This all we have discussed. Drugs, critical illness, hormones, and non-islet cell tumor hypoglycemia. Drugs, the most important, ethanol. Ethanol is a drug, we are consuming for other reasons. It blocks gluconeogenesis but not glycogenesis. So glycogenolysis is not blocked. Glycogen depletion continues. Gluconeogenesis is blocked. So glucose supplementation is not there. That is the cause. Even if the alcohol contains a calorie, it's of no use because the storage is depleted. So the chronic alcoholics, the patient after a binge drinking, the storage is depleted and gluconeogenesis is the blocked. This is for the postgraduates. This is the mechanism why binge drinking, prolonged drinking causes hypoglycemia. You will be surprised to know drugs like ACE inhibitors and the beta blocker are in the list. Why ACE inhibitor? Because of the kinin, because of the bradykinin. And why beta blocker? It causes hypoglycemia unawareness. And the one drug you remember, pentamidine, which is used in the opportunistic infection, associated with the immunosuppression, is most common metabolic abnormality in 2 weeks' time, and almost half of the patient experience hypoglycemia. If you remember just 3 categories, the ACE inhibitors, beta blockers we are using very frequently, and pentamidine in opportunistic infections. Extensive hepatic destruction in CLDs, DCLDs, and other pathologies. And this is the situation we get increased cytokine production in macrophage, rich tissue such as the liver, spleen, and lung is affected. Hormones, the adenocortical failure, growth hormone deficiency, and adults with previously unrecognized hyperpituitarism. Not difficult to diagnose at your setup. Just remember these three hormones. Non-beta cell tumor induced hypoglycemia is not uncommon. So occasionally patients with large mesenchymal or epithelial tumors like hepatomas, adenocortical carcinomas, and the carcinoids. And the hypoglycemia due to overproduction of the incompletely processed insulin-like growth factor doesn't complex normally with circulating binding proteins. This is an important slide where the endogenous hyperinsulinemia because of primary beta cell disorder, typically beta cell tumor, antibody to insulin or the receptor, beta cell secretagogues such as sulfonylurea, or the ectopic insulin secretion. These are the causes of endogenous hyperinsulinemia. And the critical care diagnostic findings, remember just 4 tests: plasma insulin concentration more than 3 microunits per ml, plasma C-peptide concentration more than 0.6 nanogram per ml, plasma proinsulin concentration more than 5 picomole per liter, and plasma glucose concentration less than 55 milligram per deciliter. Just 4 to brand non-diabetic hypoglycemia. Accidental and malicious, ingestion of insulin secretagogue or exogenous insulin causing hypoglycemia with low C-peptide levels reflecting suppression of the insulin secretions. And the urgent treatment approach to the patient, I'll just summarize in 1 minute. This is the rule of 15, that's 15 gram of glucose, wait for 15 minutes, not responsive, repeat another 15 grams. And those who are unable to take neuroglycopenic, you have to give IV fluids and IV administration for the correction. Of course, glucagon is known to the house, all of you practice. So same rule of 15, dietary treatment, and those who have non-insulinoma, pancreatogenous hypoglycemia, the dietary intervention, frequent feeding, that helps. 4 important drugs you have to remember. Alpha-glucosidase inhibitors, which delays the absorption of carbohydrates, calcium channel blockers, vasodilators or insulin secretion inhibitors like diazoxide, and the somatostatin analog like insulin secretion inhibitors like octreotide. They are useful in this non-diabetic hypoglycemia. To summarize, you know about autonomic and neuroglycopenic symptoms. The hypoglycemia should be proved by the Whipple's triad. Initial evaluation includes to review the history, physical findings, think of drugs, think of critical care illness, think of hormone deficiency and non-islet cell tumors, and seemingly well individuals' differential diagnosis are narrowed down to drug-induced, accidental, surreptitious or the malicious hypoglycemia and endogenous hyperinsulinism, idiopathic postprandial hypoglycemia, and when a spontaneous hypoglycemic episode cannot be observed, you have to recreate the circumstances by fasting, by the situation which it started, and prolonged fasting test or mixed meal test, which is just a clinical testing. And this test can also confirm the endogenous hyperinsulinism and hypoglycemia induced by oral hypoglycemic agents. So I thank the scientific committee for this oration, which could practically took place before the valedictory, and the message is simple and clear. Without diabetes, somebody can have hypoglycemia, and we have to think of these situations, simple tests to prove, and active measures to save the life. Thank you all.
Thank you, Professor Panda, for excellent oration. And since this is a prestigious oration by Chairman of Odisha API, we cannot have any question answer session. Now we will straight go for validation, the presentation.
Thank you, sir. I would like to request our chairpersons to proceed to the memento podium for their felicitation. Next, we have the scientific chairman's speech. The chairpersons for the next event are Dr. M.K. Chhatrai, sir, Senior Consultant of Medicine, Apollo Hospital, Bhubaneswar. Dr. Manoranjan Behra, sir, Professor of Medicine, Bhimabhoi Medical College, Bolangir. Dr. S.C. Mohanty, former Professor and HOD of Medicine, Berhampur. Dr. S.C. Singh, Associate Professor Medicine, SCB Medical College, Cuttack. Dr. Sanjay Das, CMS, HOD Medicine, NCS Hospital, Talcher.
Well, all are in hypoglycemic state. We have now Professor K.N. Padhiyari. He is the scientific chairman and he will be giving oration on his topic is science and spirituality. Dr. Padhiyari is known to everybody. He must have spent sleepless night in preparing this scientific agenda, and he has accommodated so many national and state level speakers, and he has chosen very good subjects. Besides a doctor, he writes. He has got the best American award for his book, We Can Save the World and the Art of Saving. Besides that, he has also written 3 Odia books for general public. So he is always different from others, and his subject is science and spirituality. Dr. Padhiyari, please.
Respected chairperson and delegates and students. Now this is out of all the topics discussed for last 3 days, this is a typical topic. I think we should have some knowledge of spirituality. That is why this was given. Actually, this was thrusted upon me by Dr. Jayant Panda. He insisted that I don't want to speak because I don't want to take the time of others. But he insisted that you will tell. Even today, I offered this my time to Dr. Dhar. He was the last speaker of today. He also declined. No, sir, you tell. So anyway, science and spirituality. Now let us say, what is science? Now science is absolute truth, because it is truth everywhere. That means the same thing which is true here will be true in America, it will be true in Europe, and it will be true in Antarctica. Everywhere, law is same. And it can be experimented. A scientific fact can be experimented. You can do it, he can do it, the other one can do it. And it can be reproduced. Whatever comes out of it, it can be applied everywhere. That is why you can say that science and its effect is everywhere truthful. That is why it speaks of only truth. Then what is spirituality? Now it is difficult to say. For many people it is different. Spirituality has various meanings. You can say it is related to God and godly matters. You can say that. But for me, I have not seen God. Any of you might have seen. Sometimes in our life, probably we have appreciated that there is God. Sometimes we might have appreciated. So you may believe, you may not believe. Then second is the time. I'm just Kala. Mahabharat serial you have seen how the Kala Chakra was moving. It is observing everything. It in the flow of time, everything is being observed. What is its observing method and how it monitors, it is difficult to say. So you can say that spirituality is related to something, the mechanism decided by Kala or the time. Or you can say the smallest thing is the nature. Now this is very obvious. What constitutes nature? Sun, rain, the wind, the water, everything, they constitute the nature. And it is appreciable. We all have appreciated that nature exists. Nobody can deny that nature exists. So You can take spirituality at the natural level, you can take at time level, or you can take at godly level. But bottom line is nature. It exists and it controls all of us. We all are controlled by nature. Without sun, we cannot survive. Without rain, we cannot survive. Without wind, we cannot survive. But it can overthrow ourselves. One famine, suppose there is no rainfall, one drought is enough to cause famine, kill so many people. So that is the effect of the sun. And rain, heavy rain, heavy rain, heavy rain, all of you see what is happening throughout the world. We do not have control over the nature. And similarly, wind, you saw what the super cyclone did. What we could do? Nothing. And if you believe at the bottom line, we all have come from nature. We all will perish in nature. Every individual. That is the eternal truth. You cannot deny that I will not die. You will never. Nobody will escape the grasp of nature. So, bottom line, spirituality is, for me, it is a mixture of everything. And for me, the spirituality constitutes of everything, and at the bottom is the laws of nature. Nature has got its own laws, and that is the spiritual law, and the nature is governing us through its natural laws. Now let us see what are the natural laws. What happened? Now let me continue while the audio visual is being prepared. Now all of you know that there are some natural laws. Very simple law is, you can say all of you have realized that death is a must. Birth is uncertain, but death is must. Anybody who has taken birth, he will die. Can you tell that this rule does not exist? This law does not exist? Nobody can deny. So natural laws are there. Now it operates at many levels. Of natural laws, they operate at many levels. All non-living beings are governed by laws of nature. All living beings are governed by laws of nature. Now this is written in Tattva Upanishad. First, only 12th one work, I got an opportunity to read the whole Upanishad during the COVID, lockdown period. Now Parameshwara has made laws for every living being, for its own benefit, not for his benefit. He has made laws for the benefit of that species. And they should live according to these laws. Once they violate the laws of nature, there will be a problem. So I have told, so for me, I have already told that for me, it is the laws of nature, which means spirituality. Now let us see how it controls the non-living things. Atom. Every atom has got its own property. What we in English say, in science say property, spirituality say dharma. That everything has got its own dharma, vastra dharma, the properties of matter, every property. Hydrogen will only behave as hydrogen, it will not behave oxygen. Oxygen will behave as oxygen, it will not behave as anything else. And once they combine, they form water. It acquires new properties. Neither it will behave as hydrogen, nor it will behave as oxygen. It has got its own properties. So once things change, properties also change. And once the water molecule become mass, like a river, flowing river, it can further newer properties. And once it becomes very huge, like a ocean, it can further newer properties. Now these properties, even God cannot take away from them. Even God cannot take away from them the property which has been given for the benefit of everybody. So even God also, if it exists, cannot take it away. I will give an example that when Ramayana, when Ramachandra was in the seashore, he was not able to decide how he will cross the sea to reach Lanka, to fetch Sita. At that time, he brought out an arrow and told, I will dry out the ocean and I will go to Lanka. And then the sea god appeared. You see, you have given this property, that ocean is not dry. The day ocean will dry, creation will not exist. You cannot do that. If you do it, okay, you do it. Then he realized, no, I cannot violate the fundamental laws. The ocean will not dry. It cannot be kept dry. So what he did, he find an alternative method. You have got right to build dams across the waterland, but you cannot dry a waterland. You should not do that ocean. So this is the property, how it is so good that even the nature, anybody should not try to violate the laws of nature. Even God cannot violate the laws of nature. So this is how, in relate to now these rules, all these rules, science, I think, developed in the 14th century, 17th century, like that, Lavoisier discovered oxygen, all these things in the 17th century. Beyond that, do you think there was no science? There are no laws of nature? How the world existed? So there are laws, and these laws are eternal. So what I say, that there are many laws remaining. Yesterday somebody was telling that Newton told that what I know is a gravel. In the gravel in the vast sands in the shore of the ocean or sea. So in the other words, nature has got is vast. So it is total, science is part of it. If you can say the science is also truth, nature is also truth. Science is exploring the laws of nature. So what was there, it is there, still there, it will be there. Only science is exploring it. So this is about the, then what is the link between science and spirituality? Before science revealed these laws existed in nature. Plants are doing photosynthesis before science knew that these are the things required for photosynthesis. Not that photosynthesis developed later after. Before science knew that for there occurs fertilization, there occurs growth of the fetus, there occurs childbirth. That also existed before that. Before the science knew this. And before the science knew the requirements of germination of seeds, seeds were germinating. So science is a very late process of exploring nature. So if the laws of nature is a whole, science is a part of it, but both speak the same thing. That is absolute truth. Science is even less than the tip of the iceberg. This is what science link between the science. There are many more things in nature science has yet to explore. And now once you violate the laws of nature, I have given one example in non-living thing, that is drying the ocean. What will happen if the ocean is dry? For my gain, for my personal gain, if I do something unlawful, unnatural, in one day or other it will yield devastating result. That moment it may be pleasant. That moment one may be satisfied. But in the long run it will never exist. Now, I will give one example how unnatural things result in devastating things. That is the benign, bovine spongiform encephalopathy. Cows are basically herbivorous. That is laws of nature. Cows are herbivorous. Now to get more good quality meat and export to generate funds, the European countries, what they did, in a hidden manner, they added meat to their food and fed the cows. They grew all right, but after few generations, they developed the spongiform encephalopathy. That could have been transmitted to human beings. That is a prion disease. That is not even a virus is required. A protein particle can be infective. So this is devastating. Guy, or that is cow, is herbivorous. What told you to make him carnivorous? Don't try to do that. It will be devastating result. You know, lakhs of cows are thrown into the Atlantic Ocean. So this is what, whenever you try to meddle with nature, result will be devastating. Now, in relation to nature and human being, nature and human beings, stomach, for example, the food, water, and air is required for all living beings. Plants, animal, and human being, everybody require these three things. But resources are fixed. So how it will be distributed? Nature is distributed for generations together. Thousands of years nature is distributed. The same thing. Recycling, same thing. And it is kept us living. But now we have not understood the nature and we have learned the property problems. Now for science, what is food? Now food for science is protein, carbohydrate, fat, meaningless. These are not required at all. The people lived before these things came to be known. For spirituality, what is food? Now food is, now it is again in Upanishad written, Anna Brahma. Brahma means Bhagavan said it. Because Annat Bhavati Bhutani. Anna Jugo hi sabu jivan vanchi rahi. All are living because of food. So don't take food as such a light matter. Food is Brahma. Bhagavan has said it. You must see that whatever I am taking, it is food. So that is food. And if you are taking more, somebody else is remaining fasting, he is remaining without food. Because the food grown on earth is meant for all. And when we become knowledgeable, when we acquire knowledge, all these spiritual scriptures came to teach us that, then if you have read Bible, I have read Bible. In the Bible, when Adam and Eve were refused to take the fruit of this plant, don't take it. But out of curiosity, they started taking it, and that was the knowledge of, the tree was the knowledge of, tree of knowledge. And then that made him ignorant. Ignorant means, thereafter we are searching in favor of science, knowledge, we will never get it. That is what in relation to food, three things required. One is a solid thing, food, one is a liquid thing, water, and one is the air, that is the air. So three forms of matter, and we require all the three. Now food, what nature has done, now it has given a limited capacity to the stomach. Stomach capacity is fixed, you cannot take, fill and forget it. You cannot do that. That once I fill the stomach, I can live for 7 days, 10 days, 1 month. No food is required. No, nature is not given that. You have given a limited capacity. You can take food which will last you for 8 hours. That will last maximum of 6 to 8 hours. Then again you will require food. So you cannot fill it and forget it. So that means how it will decide? Hunger has given. He has given the hunger that this is the time you take food. And it also knows when to stop taking food. That is satiety. That you stop taking food. Your stomach is filled. Don't take any more food. Enough. Go. So this has got its own regulatory system. The nature has given the regulatory system, how much to take, and when to stop. We must understand this. If you are not hungry, don't take food. You really hungry, take food. That is the law of nature. Not that it is available to me, I will take it. No, that is not the law of nature. In relation to food, there are many things written in almost all the spiritual scriptures. This is very simple, but one thing that never take food. Science, if you combine, never take food if you are not really hungry. Be hungry. How will you become hungry? By working. So 8 hours work, be hungry, take food, enough, then again go out for working and become hungry, take food. That is the basic principle of taking food. So nature has given the food and water. Now similarly air. You cannot take excess air. But food and water are regulated. Air intake is not regulated. Because even in sleep, also you have to take air. But during sleep, food and water we do not take. So food and water intake is regulated. Air intake is not regulated. But there is some method. I will come to that. Laws of nature and human suffering related to food, diabetes mellitus, I have already told. Food recommended for it. About this, what our science says about food and eat. Now, our science says the food is the cereals. Do take so much of cereals. Nowadays, all the diabetes are there. Then what you will take? Take vegetables. Is it possible? Now, it is daydreaming. That take more vegetable, less cereal, it is simply daydreaming. Never it will be fruitful because the food grown depends on the climatic condition, depend on the soil, and depend on the waterfall, how much rainfall. So all these decide the food which is grown. So who are you to dictate that you take more vegetable? Is it possible to grow vegetables so easily? Food grains, that is the paddy or the wheats or these dry foods, can be preserved without any special device, can be preserved for several years. But you think how long you can preserve the vegetables? And you are telling that you take only vegetable this much, take cereal this much. Impossible. Never it will be successful. The law of nature, what says about food? You say protein, X, Y, Z. Nature says one thing. Bhagavata, Srimad Bhagavata, ahare bhalamanda nahi, jasthana jamanta milai. Nothing is good food or bad food. Whatever is available, whatever is produced in that particular area, that is the food. Eskimos take only animal food. You tell, go and take vegetable. Impossible. And you say, and as I told, for Arabian countries, Muslims, they take meat. It is good. It is good for them because these are grasslands. Only animal rearing is the only method of survival. So they will take meat. There is nothing wrong in it. In India, vast agricultural land. So many varieties of crops, cereals, vegetables, all things. So there is, we need not be non-vegetarian. We can enough to become vegetarian. So summary is, ahare bhalamando nahi, sir, should I stop? If I can stop, I will stop. So, ahare bhalamando nahi, jasthana jamanta medai. So, basic principle is that. Don't think any food is good food. And I told, food is Brahma. That is uniformity. And there are many other things I can tell. Only food I can talk hours together. I am not going to tell. Then about related to water, in relation to water, I will say, again, there will be no shortage of water. You see in the African, South African, there is ration on water supply. This is our approach to water. In fact, I wrote an article to Nature. In Nature about our method of utilization of water is wrong. There will be no deficit of water. And I went on posting that paper. Before final posting, it told that if your paper is accepted for publication, you have to pay 1,50,000 rupees. Then I stopped. I have not yet, it is already there, but I have not yet posted about how to deal with water, how men should deal with water. That is laws of nature. Now one thing, and all of you might have a aquaguard. I do not have aquaguard. I do not take water from aquaguard. What I take is an ordinary candle filter. Why? You might be asking why you take candle filter? Because I analyze the law of nature. That is how a cow is taking water, how a dog is taking water. And a cow is taking water directly, putting his head onto the pond and sucking it. And a dog is water from the footpath. Who is keeping them survive? How they are living? They could have extinct. Nature will never do that. I believe on the nature, that nature will not kill me. Nature, I do not require aquaguard water. My candle filter is enough to keep me safe. I do not take, in my house it is there, madam take, my children take sometimes, but I told them to at least you take 50-50. You take aquaguard water as well as filter water, 50-50. I personally do not take aquaguard water. So that is the law of nature. You need not be too much science. Do not add too much science into these essential things. And about the water, by law of nature, we are supposed to go to water, not water is supposed to come to us. That means ponds, the surface water supply, where the previous method of water supply was the right method of water supply. In a village, there was 1 or 2 ponds. Everybody was using, for generations together they were using. They were also surviving, there were waterborne diseases, but they also survived. So that method can be revived. It can be more rationalized. So there is no need of bringing water to us. So this pipe system, I made what is that? So that the pipes water supply has killed the water for other creatures. You might have seen videos how the squirrels are suffering for water. They are not getting. If there will be surface water, everybody could have used it. So about the water, then about the air, I will conclude here because in air, I will come to about pranayama, how it helps. I have written this article on your souvenir. Now, about the relationship between science and spirituality, science gives us knowledge, but spirituality teaches us how to apply knowledge. Now, when I will give 2 examples, one in the recent time, one from the past time. In the recent time, when atom bomb exploded in Hiroshima, Nagasaki, some of the students of Einstein went and asked to Einstein, sir, you see how men utilize your knowledge. Your knowledge is based on this atom bomb. And this is how men, Einstein told that if men would have used in this way my knowledge, I would not have developed this science. So this is how you utilize the knowledge. Einstein is not at fault. How you utilize the knowledge, it will only spirituality will take. Now I will, from in the ancient literature, I will say another example. That is the Aswatthama. Aswatthama and Arjuna, they were taught by Dronacharya. Dronacharya was the father of Aswatthama. And out of them, Arjuna deserved to learn Brahmastra, but Aswatthama was not capable enough to learn Brahmastra. But because of he was the father and he is the son, he started teaching him Brahmastra. Then what happened? What he did, he misutilized it. Misutilized where he had applied? Subhadra. That means on a child who is not a taken bath, a child who is not on the mother's womb. Subhadra's womb, Parikshita was there. Not Subhadra, Uttara. I'm sorry, not Subhadra, it is Uttara, Abhimanyu's wife. Then this is absolutely absurd thinking that Brahmastra to be utilized to a person who is not a taken birth. Why this happened? Because there is no fault of method of teaching, learning, but how you utilize it. He has poor spiritual understanding. Let my knowledge go to hell, but I cannot apply on a child who has not yet taken birth. So this is what the science and spirituality. Spirituality teaches how you utilize knowledge. Even today also, suppose we all are doctors. We have enough knowledge. How you will utilize knowledge to exploit people or to help people? It depends on spirituality. It does not depend on science. So this is other aspect of here. Then the relationship between science and spirituality teaches why we are doing this. Every work has got a karja karana. From behind every work there is a reason for it. So science might be teaching about this work, but spirituality teaches us why I am doing it. Very simple, a very simple example is Arjuna deciding not to fight in the war in Mahabharata. I will not fight. Why? Because I do not want to be king. I will not kingdom. No, you are not going to fight for that. You are going to fight because you have to establish you have to establish the virtue. That is the reason you have to fight. And then he understood that yes, I should fight. So that is the whole Bhagavad Gita. That a man who is confused, then he has to explain why you are doing this work. So behind every work, there is a reason. You must understand why I am doing this. So this is what about the spirituality teaches and what the science says. And about the pranayama practice, I will tell that to remain disease-free, summary is, first you become mitahari, I have already told, you take, mitahari means take less food. 50% of the stomach should be filled and 25% for water, 25% all the time empty, all the time. It should be kept, that is what Upanishad says. And water, I already told that some infection is better than no infection. Why I take a filter water? Let some infection get into my body, so that my immune system will remain active. If by taking aquaguard or many families, I have seen myself, father, mother, children, all are suffering from jaundice. You are taking, your school is providing aquaguard water, your house is providing aquaguard water. How you suffered from waterborne disease? This is because zero infection. So there is no immunity. So if you take some infection is better than no infection. That is my principle. That is my principle. You may accept, you may reject. And similarly, whatever air we need, as I told, at the entry point, water is regulated, food is regulated, but air is not regulated. That means all the time air is going into our body. All the time, even our sleep, it is going. So now question arises, are you utilizing it properly? Are you utilizing whatever air means oxygen? Are you utilizing the oxygen properly? Now, Mitahari I have told, now these are the references from Upanishad. So, there are many advantages. Brahmacharya, Mitahari, and Yoga Pranayama, they keep us disease-free. You can, Ashtanga Yoga are there, different type of asanas are there. These are things already described in the book. You can refer to the book. And yesterday about the sleep medicine, they were also touching. That is, adequately sleeping in night time is essential. And not sleeping in daytime. Day is meant to work, night is to take rest. So must follow this law of nature. And how, then how to pranayama practice? You take a deep breath, hold it like that, and exhale it. The ratio is 8:30:16. In that ratio, you take, hold it, and then exhale. That means as long as you can hold, it is good. That means you are practicing a state of not taking respiration, because it can be voluntarily controlled. So nature is given that respiration can be voluntarily controlled. And itself will take care during your sleep. So it is involuntarily controlling the nature. So it is your duty to control your breath during when you are conscious, when the respiration is within your control. So what is that? Now, whatever oxygen extra has gone, that will be completely utilized. So you are keeping an anaerobic environment within the body. So every molecule of oxygen will be utilized. Now, why it is to be utilized? Now, if the oxygen is excess, then it leaks from the mitochondria into, this I read from Goiton. I physiology gotten, I read complete, I purchased a new book and read it. Some molecule of atom of oxygen, they leak into this cytoplasm and they oxidize it. All of you know that out of the all negative radicals, after chlorine, oxygen is most reactive. And it can react with any molecule, biomolecule. And once it changes, its antigenic property changes. And it behaves firmly. It can attack the chromosome, it can attack all biomolecule, lipid molecule, all molecules it can attack. And it alters the character of their behavior. So these oxygens which has gone leaked out of the mitochondria can be drawn in and utilized if you keep the body in an anaerobic environment. That is your pranayama. So, and this is to be practiced at least 3 times a day, 8 hourly. That means, why 8 hourly? Now, don't allow the oxygen to be irreversibly attached to the molecules. If within 8 hours, it can be drawn back. If it is gone crossed more than 8 hours, it cannot be drawn back. So, you practice pranayama at least 3 times a day. Here says, that Upanishad say, it is ideal to practice 8 times in a day. But at least minimum is 3 times. Minimum is 3 times. So, you keep the body deprived from oxygen for some time. The other alternative is exercise. Do physical work. People who are working, people there together, they were working. And by that time, there was oxygen deficit. The body was going to a oxygen deficit state. So whatever oxygen is there extra, it is utilized during severe exercise. Because we are not doing severe exercise, we are not doing physical activities, for us, pranayama is mandatory. I advise everybody, I do every day. Whatever it is, even after returning from this conference, I practice pranayama. So I invite everybody to do practice. It is very good for your health. Autoimmune diseases, malignancies, aging, all can be delayed or prevented if you practice pranayama. So what is my summary is that what is the spiritual life? Sorry, I have spilled over my topic. That please do your duty perfectly. Never think. You can say, Bhagavad Gita, Niskama Karma. Go on doing your work. Whatever work you assign, do it perfectly. Not partly. It is perfectly. Whatever you know, do your work. So, who will gain, who will not, don't think about it. And whether there will be gain or loss, don't think about them. My summary of this world is, as I told, I don't bother whether these diabetologists are telling that you take so much of vegetable, this much of rice. I don't bother with them. For me, every food is food. One day science will prove that whether you take cereals, whether you take rice, whether you take other things, if you are able to 100% utilize it, there is no harm in it. Whatever you want to take. That is what our forefathers were doing. Whatever they ate, every molecule of food, they utilized it. Rather, they were starving. So there is no harm in it. One day science will prove this. I am giving now that science will prove this. So my rule is, the world is very simple. It is governed by certain eternal principles, that in all the laws of nature. Let us understand the laws of nature, and according to, let us live according to laws of nature, and world will remain simple. Thank you very much. I overstepped.
Thank you, sir, for your deliberation. So it is told that where science ends, spirituality begins.
Right.
Thank you all for patiently hearing. With this, I think we will conclude the session because of constraint of time. Let us go to another session. That is mixed basket. Thank you all.
Thank you, sir, for a truly enlightening speech. We now move on to the next session, a mixed basket. The session is chaired by Dr. Ashok Kumar Mahapatra, Senior Medical Officer, Government of India, Coimbatore. Dr. Rabindra Kisko, Assistant Professor of Medicine, SCV Medical College and Hospital, Cuttack. Dr. Niharajan Sahu, Assistant Professor of Medicine, MKCG Hospital, Berhampur. Dr. S.K. Swai, Associate Professor of Medicine, SJM College, Puri.
Hello. Good afternoon, ladies and gentlemen. We are coming to the end of the beautiful feast organized by Professor Jayant Panda and organizing secretary. In fact, it was a true icing on the cake, the last speaker on the science and spirituality. And with the end of the session, with the beginning of the, the end of the last session, I would request Professor Jyotiranjan Parida. He's known to most of all of us, and he would be talking on the backache, rational approach to the backache. As you all know, backache is one of the most common problem that we face in our daily OPD practice. And a rational approach to backache is necessary even now. Understanding and right approach would certainly make us
And before telling you how to approach it, I think all of you should know what are the pain sensitive structure in the back. This is not only about disc, or this is not about your joints. Starting from the skin, subcutaneous adipose tissue to muscle, joints, ligament, periosteum. And why these are important? Because there may be a small abscess which is causing all the pain. There may be irritation of the nerve because of herpes which is causing the pain. And you may be asking for a MRI to look at the joints and disc. I think that's why you have to clearly examine and take a proper history before moving towards your other investigations. And when it comes to rational approach, I have thought what I'll tell, what will be the most rational approach. I just sat for 2 minutes and think that these are three approaches that we are practicing. One is radiologic approach, because we are very busy practitioners. We don't have time. So whenever a patient complains of back pain, please ma'am go and do a MRI or X-ray, come back, then we'll see what is there, then we'll treat accordingly. Because this is very convenient. I also call this a very convenient approach. Second is, I don't have time for back pain. You refer to a physiotherapist or an orthopedician. This is not a physician job. And the third is, I feel the most accurate approach on how we should deal, because you should be able to sit with the patient, try to find out what are the red flags, and if you can rule it out, then with your history and examination, you can get most of the answers. And that is what I am going to tell you today. So this is the radiologic or convenient approach. There are many incentives actually. There is a feel-good factor for both the doctors and patient. Your radiologic colleagues will be happy with you. Your hospital will be happy with you. Sometimes patients are also coming and telling you, doctor, I want a MRI or X-ray. But I'll tell you, this is not only sometimes useless, that may do harm, and I'll tell you how it will do harm. Because when you are doing a MRI for a low back pain, you are having something called a street light effect. Street light effect is you have lost your key somewhere, but when you are searching where the street light is in the park, because that is the most focused area, that is the most lighted area. So that's how MRI and X-rays, they make more false alarms actually. The disc degeneration, the disc balls, they are so common in old age. The MRI will pick them up, and if you see only the highlighted area in the MRI, you may be actually losing the most common cause of back pain, which is arising from the muscle or something very superficial. So MRIs are actually very overrated, not only for back pain, for any musculoskeletal event. You see 72% with a shoulder slap showing in that labral lesion in the MRI actually doesn't have any pain. 80% of people who have degenerative changes in the MRI actually doesn't suffer from any pain. So this is actually very overrated. So this is not the end solution of everything. And this is what I call as a 10+ rule. You will see in a 20-year-old, if you do a MRI, there is 30% of them will have a disc bulge. And if at the age of 70 years you will have almost 80% will have disc bulge. And all these degeneration, balls, protrusion, facet joint disease, spondylolisthesis, they just keep on increasing with the age. And they are actually not very important because they are, like Sarah has told, this is part of the nature. When you're old, these things will be there and that will be picked by the MRI. But whether the pain arising out of her back for which the patient has come to you is because of those MRI lesions or they are a true alarm or a false alarm, that you have to judge as a clinician. So choosing wisely, this is an initiative by American Association of Family Physicians, and they have shown that most of the time these MRIs and X-rays are useless. And this is the referral approach I was telling. I have knowingly make it one part of the referral system, physiotherapist, orthopedician, neurosurgeon, and physician. Because most of the time, because we don't have time, patient doesn't get an answer and they go to alternative medicines, homeopathy, Ayurvedic, Unani, etc. So the best approach that I feel that you have to be very, this is not that back pain is always simple and benign. There are some red flags. Red flags are the clinical indications that if you find them, you have to be more serious. But that is the positive thing, that is only 1 out of 10. So once you find your red man, then you just keep them out or refer for a imaging, or you can refer to a proper person. All other 9 cases you can manage with 10 minutes spending with the patient. And these are the red signs. We know that there is a history of fever, trauma, or there is a neurological deficits, or sudden onset low back pain with spinal tenderness in an old lady. That could be osteoporotic fracture, or there is history of malignancy or infection and some non-spinal causes. So what to expect out of this talk? This is not a, because the time is also short. I will just tell you how I have come across 4 or 5 cases and what I think will sort out those 9 blue men that you have seen in that red flag sign. So this is case 1. This is a 22-year-old software engineer working in TCS. And he had came with low back pain in the evening and after prolonged sitting, like all of you have developing now. No early morning stiffness, also had a tennis elbow. No localized tenderness, SLR was normal, Faber test was, figure of 4 test was normal. So which test you should send for this patient? Vitamin D, because nowadays people are very, they're liking this fancy test, but I think this is non-specific back pain. So this patient or this boy doesn't need any investigation. And if you see the causes of back pain in a young, actually 80% has non-specific back pain. Only 10% of them will have some disc problem and 10% of them will have non-disc related pain. So when I am telling non-specific means it is not a wastebasket diagnosis. Non-specific means there is a back pain, definite back pain, but there is absence of any pathoanatomical etiology. Mostly postural. and mainly developed because of poor posture when sitting and standing and lifting weights. And there are several factors, many factors are related like overweight, smoking, high heels, vitamin D, poor posture, but actually these factors have not, they are not very evidence-based, they are just postulations. And the most important thing that I wanted to highlight is there are very small muscles called multifidus muscles in the back. And along with these transverse abdominis and pelvic floor muscles, they are the main stabilizer of the lumbar spine. And we don't realize actually involvement of these small muscles which fill the gap between your transverse process and the spinous process. They are actually a very, very important cause of this postural pain. That's why the physiotherapist always give emphasis on core strengthening exercise. Because if you do these exercises, these muscles will be very active and then you will not have any back pain. People have tried to see the MRI correlation of these multifidus muscle and they have seen that those having severe fatty replacement of these muscles are actually having more back pain. High heels, yes, the inches of heel will be more, now these are becoming more fashionable. So with each extra inch of heel, your body is bending forward and not only the back pain, you will have a lot of knee pain, heel pain, plantar fasciitis and all other physical disability. So be aware of these heels. But just don't leave the patient telling that there is nothing and this is postural pain. So in non-specific back pain, what you have to specifically look for is whether this patient is having scoliosis or kyphosis. And there is another condition called a benign hypermobility syndrome. We all of us know that there is a Baton score and most of these patients coming with back pain, there is no inflammation anywhere. If you do like this, even if the patient comes with a back pain, and if 4 out of 9 Baton score is fulfilled, then we call them as benign hypermobility syndrome. And these patients are very, very likely to develop back pain, wrist, elbow pain, and hand pain. The second case is a 26-year-old male taxi driver, severe deep packing, low back pain during movement and worse during standing and sitting. And patient is having a very severe tenderness here. Patient is pointing a finger towards that part. SLR is normal, Faber test is negative. So what is the diagnosis is there is a trigger point here. When we talk of myofascial pain or trigger pain, we always focus on our trapezius. But there is a muscle here called quadratus lumborum where you can have 3 sets of trigger points. So quadratus lumborum is a muscle which starts from the iliac crest and ends at 12th rib. And these are the points actually you will find point tenderness at this area. This may be sometimes pyelonephritis also, you have to be very, very careful that nothing is inside. But if it is only superficial muscular, then you have to be aware of this condition. Without knowing this, you can treat them. And sometimes they may radiate and the pain may be here in the buttock area. This is a very, very important syndrome, what we call a piriformis pain syndrome. The piriformis muscle actually starts from the sacrum and it ends at greater tuberosity, greater tubercle. And actually the importance of this muscle is the sciatic nerve just passes below this muscle. In 17% of people, actually the part of the sciatic nerve actually pierces through this muscle. And these are the individuals in particular, they are at very high risk of developing this syndrome where you will have pain while the patient is sitting or stretching, and you may be thinking that there is a sciatica, there may be lumbar radiculopathy because they will have a typical radicular pain, and you may be doing a MRI which will come always negative. So don't sit on the problem because if you sit, as you will become rich, your purse will contain more money, you are inviting more backache. So keep your money in the bank, not in the purse, because we also as doctors sit for long hours and we all may develop this postural difficulty and the spine may be bent, or else you also may develop this muscular pain which is called as piriformis syndrome. Number 3 is a 22-year-old female, low backache radiating to right lower limb, difficult in walking. SLR is strict. SLR is only 10 in the right and 30 in the left. Patient is not allowing to examine. You can see these pictures actually. Once my physiotherapist starts examining, the patient is telling, no, I can't move. So the answer is very straight cut, and this is the forward bending is very limited. The lateral bending is also limited on the left side. So this is what is typical PIVD, but just to mind you, PIVD is only consists of a very small chunk of the patients. We all know that what is a prolapse intravertebral disc. I am not going to detail. But prolapse intravertebral disc is a young age disease. That is one thing I wanted to highlight. That disc prolapse, usually it's a middle age 25 to 55 years. It is not a very old person who will develop this prolapse disc. So case 4, this patient was consulted multiple specialties because of back pain. Having on examination, actually bilateral sacroiliac joint was tender. So I was thinking this is okay, this is our domain, so this is sacroiliitis, but HLA-B27 negative. Still it can be spondyloarthritis, but when I have done an X-ray, there is nothing in the sacroiliac joint, but here you find something remarkable. There is a large transverse process which is communicating with the sacral ala. This is what is called a Bertolini syndrome, and this is not very uncommon actually. So the incidence is around 4.6 or 5%. So in a young patient, when you are evaluating back pain, and particularly if your figure of 4 test is positive, but still there is no early morning stiffness, please keep this in mind. And this is the garden variety of spondyloarthritis, because time is not there, so I am not going to detail. Early morning stiffness, patient has a family history. You can see the father is also having the same, HLA-B27 positive. Just so this is bilateral sacroiliitis. And for the students, now the nomenclature has become very simple. You don't have to tell undifferentiated spondyloarthritis. This is either the axial joint is involved, that is axial spondyloarthritis, or the peripheral joints are involved, peripheral spondyloarthritis. And these are the diagnostic criteria. But whenever you are telling spondyloarthritis, please, you have to be very, very sure that the age of onset should be less than 45 years of starting the symptoms. And we call them a radiographic axial spondyloarthritis when the X-ray is showing sacroiliitis. If X-ray is absent or X-ray is normal, if the MRI shows sacroiliitis or HLA-B27 helps in diagnosis, we call that non-radiographic. Why that is important? Because this is just like a, because you will have more female members nowadays, what we used to call as fibromyalgia, now coming to this.
Dr.
So what we have
if you
learned,
could wind
another
up.
one minute, one slide. So this is what we have learned from these things. Are most common cause of back pain are non-specific. Proper history taking and clinical examination has no substitute. And be very aware, because if you don't know what is piriformis syndrome, you can never diagnose what is piriformis syndrome. And these are the things in the history. Every time spend some time. Exclude red flags that you all know. And as a rheumatologist, I have to tell how to differentiate between inflammatory and mechanical back pain. Early morning stiffness more than 30 minutes. Improves with activity, relieves with rest, aggravate with rest, relieve with activity. That is what is inflammatory pain. At least, this will be my take-home message is, these 4 tests everybody should practice in the OPD. Then most of the cases you can solve. One is the classic SLR test, if that is there or not. That is a figure of 4 test or Faber test, piriformis stretch test, and another is looking for local tenderness. If the SLR is positive, most probably you are dealing with a disc problem. If the Faber test is positive, most probably the sacroiliac joint is at fault. Trigger points are there. It could be a myofascial quadratus lumborum trigger point. If the red flags are positive, then please send for imaging. All excluded, you can tell that this is non-specific back pain. But in a non-specific back pain also, you have to look for what the condition, why this patient has developed this postural pain. And order imaging only if red flags. Don't forget the yellow flags. There are certain things called as yellow flag in the back pain. These are the psychosocial things with the patient. Some patient will never do physiotherapy. They have a fear avoidance beliefs. They have anxiety, depression. You have to take care of them. Thank you very much, and my apology for taking those extra minutes. Thank you all.
Thank you, Dr. Parida. If there could be any question from the audience. Okay. Due to paucity of time, we'll move to the second year. Dr. Parida, you spoke very nicely, and I hope there are lots of messages for the doctor colleagues who also experiences a lot of back pain. And anything you would like to suggest to the doctor colleagues?
No, only the final message is there are certain things actually that even I have not learnt during my DM rheumatology days. When I've gone for a fellowship to UK, there I have interacted with the physiotherapists actually. They have learnt, they have taught me actually this piriformis disease and this thing. I think in a basic physician workshop and this thing, there should be more focus on this every day in and day out. We are talking of red flags. We are talking of inflammatory, non-inflammatory. So although being a rheumatologist, I tried not to focus much on sacroiliitis. I have tried to give a message that 90% of the back pain can be solved at OPD if you do this history taking and do these 4 or 5 simple tests. I think that is the simple message. Thank you.
Dr. Jyoti, come for the moment. Next speaker is Dr. Smita Mahapatra. She is the Associate Professor and Head of the Department, Transfusion Medicine, SC Medical College and Hospital, Cuttack. She is known for her work during COVID times. She was instrumental in making the plasma bank, fast plasma bank in Odisha, and she helped immensely during that COVID period. She has a number of papers published in Index International and National Journals. She is going to speak about blood products in laboratory, and this is very new. We should learn from her speech. Thank you.
Thank you so much for the kind words. Respected and esteemed dear senior person, my revered teacher, Padhiyari sir, and all the delegates, respected chairpersons, I should acknowledge my personal thanks to Jain sir for inviting me for this interesting session. Well, when I got this topic, so actually in our inventory and everything, we ask when we don't have any blood stock in our inventory, whether you have any exchange donor with you. So when the answer is a big no, so we also puzzle and we also think how to give him blood. And we tell blood is not available in any shop or any medical stationary things. So it has to be donated to supply blood. So with this, let's start the journey of this artificial blood. So basically, this blood cultivated in the inventory or the artificial blood is a product that is a substitute for any red blood cell. So with a true blood having different kind of functions, everything, the artificial blood is designed to transport the oxygen, the carbon dioxide throughout the body. So it can be produced very synthetically, with a chemical isolation, recombinant biochemical technologies. And the journey of the artificial blood production started long back from 1600, and still the search is going on for a suitable substitute. Now, phenomenally, with the increased number of surgical procedures, trauma, and various kind of accidents, rather, there's an increase in the demand of the blood for transfusion. To mitigate this disparity between the demand and the supply of the blood, so there's a difficulty in the storage of the human blood. So maybe this artificial blood is a promising option. And in terms of this, artificial blood is often interchangeable with a surrogate or the blood substitute, which are actually the misnomers. These are not the true facts. So it lacks attributes of the human bloods, like the total hemostatic processing, the typing, the immunological defenses of the body. And actually it serves to carry out important functions for transporting the oxygen and carbon dioxide throughout the blood. So actually the terminology of this artificial blood is red cell blood substitute or the artificial oxygen carriers. So it's a beautiful historical perspective of this thing. So it started over more than 150 years. The scientists they started thinking that maybe the milk, maybe the plasma can be a substitute for them. So it may be the energy booster. So this substitute started to be a very interesting zone for the scientists because they wanted to potentially, they wanted to cut short of the shortage of this donated blood. So in 1980s, the SEPTI was concerned regarding the HIV, that renewed the interest rather in finding the substitute. And recently, with the more of the battlefields, that has heightened this interest. And in fact, US is the one country where it has the most potential research in the blood substitute or the artificial blood, that because of this war and warfares. And it supports most of the own research and partnerships with this PPP mode. So today, with the search beginning, continuing with the safe, effective oxygen carrier, it can eliminate a lot of problems associated with transfusions, like there's a need of refrigeration in whole blood, the limited shelf life, there should be compatibility, the typing, the cross-matching, the immunogenicity, the transmission of the infectious agents, the transfusion-transmitted infections, and the shortages, of course. So since the RBC substitutes, these are the drugs actually, they should undergo extensive testing in order to obtain the FDA approval. So they can be abundantly supplied with a readily available use in the pre-hospital settings, battlefields, remote locations, can be stockpiled for emergency and warfare. There should be no typing and the cross-matching TDS work. It can be available for immediate infusions with an external shelf life. Yes, this is the gray zone. Still, the research is going on for 1 to 3 years. Can be stored at room temperature, free of bloodborne pathogens, and obviously at full of oxygen capacity. They do not prime the circulating neutrophils, so they reduce the incidence of this multi-organ failure. They can deliver the oxygen to tissue that can be inaccessible to RBC. They can be accepted by the Jehovah's Witnesses. There's a saint, the monk population, they don't accept blood from any other person. So they can be helpful. Could eventually, they can lead to the loss of these units of the blood. The cost may be minimized. With the current research on the blood substitute is focused on 2 areas, that is hemoglobin-based oxygen carriers and the perfluorocarbons. So originally developed to used in case of the accidents and surgery. So RBC substitute, until recently, they have fallen short of this meeting requirements of these applications. So in trauma, they can be used for this volume replacement and stabilization. In elective surgery, as a pre-operative blood conservation, or in case of the perioperative volume replacement, that we are also using with the whole blood in the autologous transfusion. In cardiovascular surgery, as a pump priming or the deep hypothermia, or the intraoperative replacement. In case of the perfusion in ischemic tissues, like any stroke in sickle cell disease patient, peripheral vascular disease, or even oxygenation of the solid tumors for increasing susceptibility to radiotherapy and chemotherapy. In fact, there are certain other uses also, like preservation of these organs during this transport for the transplantation, or as a cardioplasia, even as a drug carrier also, in form of this drug conjugated hemoglobin or perfluorocarbons, even treating the anaerobic infection, gas embolizing, carbon dioxide poisoning, and in fact as a contrast agents also. So this RBC substitute, despite years of the research, they are still not routinely used till date also. In South Africa, Mexico, and Russia, these are the countries where generally blood substitutes are approved for the clinical uses, but none still have received the FDA approval for the clinical use in United States, and generally they are in the phase 3 of the clinical trials. The hemoglobin-based oxygen carriers, they are focused mainly on the oxygen therapeutics. So they are very effective in immediate oxygenation until this medical or surgical intervention could be initiated. And when the early trauma trial started with the HemAssist, Hemopure, Polyhem for resuscitating the hypertensive shock. But still all failed due to the safety concern for the cardiac tissues and increased mortality. So the clinical trial still going on with that still they have progressed to the phase 2 and eventually to phase 3 clinical trials, but currently none have been approved for the use in human in the United States. In 2008, a meta-analysis of 16 clinical trials involving around 4,000 patients, they showed that there's an increased risk of the death and myocardial infarction associated with this hemoglobin carriers. And in 2008, the FDA put all the HBO's trials to hold because of this unfavorable remarks or the outcomes. Now first, it must be safe. The characteristics of any artificial substitute, that it should be safe to be used as a human blood substitute. So different blood typing shouldn't matter in that case. Neither the A group, the B group, the AB, the O. So it can be used in any type. And this has to be processed to remove all the disease-causing agents of the viruses and microorganisms. Then the design should be such that it should be able to transport the oxygen throughout the body and to release the oxygen wherever it is required. And it should have a self-life. It should be stable. So until this donated blood, which are stable for over a month, it can be stored for more than a year or more so. So, but this is in contrast to this natural blood. The trial still continues with a Hemopure or the Polyhem in phase 3 clinical trials in US and Europe. Hemopure was approved for the clinical use in South Africa in 2001 to treat this adult surgical patient who were anemic, and Russia in case of the acute anemia. So many of these hemoglobin-based oxygen carriers have been researched, many have been discontinued due to complication of the cardiac complication, toxicity, GI distress, neurotoxicity, renal failure, and moreover the mortality. But still the faith, and there's a third eye is in the scientists that the HBAs are said to be more promised than the perfluorocarbon. So the advantages being this They have a long shelf life with very stability, with no antigenicity, and there is no requirement of this typing procedure. But yes, they have a shortened intravascular half-life with a possibility of toxicity, and they have an increased oxygen affinity with an increased oncotic effect. So these are the different products of the HemAssist, Polyhem, Pure, Oxyglobin, HemLink, HemTech, all with a clean phase 2 or phase-free clinical trials. The perfluorocarbons, they are synthetically hydrocarbons. Where the hydrocarbons atoms have been replaced with this fluorine, they are chemically inert, excellent gas solvents. They carry oxygen and carbon dioxide by dissolving them. With a smaller size, they can pass through any vasoconstricted areas, can deliver oxygen to any tissue which are inaccessible to RBCs. Besides, these perfluorocarbons have been under investigation as a possible RBC substitute since 1970s. With this fluorosol approved by the FDA in 1989, but it has been removed from the market in 1994 with a clinical shortcoming and poor sales, and these have proceeded to clinical trials. So they have been used in Russia, Mexico, with oxysite, oxygen biotherapy, and Switzerland and Israel. So advantages being their inert, biological inertness, lack of immunogenicity, easily synthesis. But disadvantage being high oxygen affinity with adverse effects, retention in the tissues, requirement of the oxygen administration when infused, and the most important is the deep freezer storage temperature. So these are the perfluorocarbons with the oxygen, oxysite, all these things, which are also still in the clinical trials. Now the most interesting part is the tissue engineering or the RBC with the blood farming from the stem cell, so receiving attention, funding, then the blood substitute. So they have been cultivated in vitro successfully, but the limitation that one unit was very costly, and culturing of the stem cell with a unilineage production leading to the progress in vitro erythrocyte expansion with a generation of many erythroblasts can lead to the mature RBC, and a feeder layer is required in this blood farming. And there's an interesting thing, we can also form this type O blood group from type A and type B. That is also another interesting thing. So the future is that several companies are working in the production of this safe and effective artificial blood substitute with limitations, but still they can't last more than 20 to 30 hours in our body, whereas a whole blood transfusion or RBC substitute for 34 days, and they mimic the blood ability to fight diseases and clot, they do not mimic. So currently, the current artificial blood technology will be limited to short-term blood replacement application. So in future, maybe it is anticipated that new material to carry the oxygen in the blood will be found. So with this thing we should be keeping in mind that with the paucity of time, I am covering up that the upcoming dimension should be experimentation with the stem cells, with the transgenic hemoglobin, polyheme enzyme complexes, which can reduce the ischemic refusion injuries in stroke, myocardial infarctions, with a sizable volume of clinical trials, systemic studies. So the future research initiative for providing adequate quantity of safe, efficacious, commercially viable alternatives for lesser drawbacks, which will reduce the dependency on the donated blood and reduce the mortality due to transfusion. So the new avenue in the transfusion field will continue, and the recent hype and the media hype, recent that lab-grown blood, which had been given as to human for the world first clinical trial aimed at combating the rare disorders. So this was just in the November 7th of 2022. So they have cultivated from the stem cell and they've applied. So let's see and let's wait for the results. So maybe in future, we'll not be demanding any person coming with donors or not donors. We can also tell, ki yes, you can get the blood or you can get the unit from any pharmaceutical medicine shop or maybe available with us. So we can dream for those days also, and maybe the artificial blood will be the future of this present whole blood. The time will say. Thanks so much.
Thank you, Madam, for your enlightening talk. I think she has told everything about the artificial blood, fluorochlorocarbons, and all the blood products that are being on the pipeline. Let's hope these products are available in coming decade, so we can save so many lives. Madam, you can come and take your memento.
The next, I invite Professor Dr. Srikant Kumar Dhara for his topic on scrub typhus updated. Previous years, mostly scrub typhus present us as PO, which we had difficulty. Now of late, we are getting more number of cases and we are diagnosing and treating. So he will give a update. Dr. Dhara, please.
Thank you, API, for giving me participating in this podium. And I'm the last batsman, so to say, so don't expect good run from me. I'm not a specified batsman, you can say, because given the last chance. So sometimes last batsmen also is helpful for the team. So I'm giving a chance to put a word on scrub typhus. It may be helpful to you, what I think, because it has been given a opportunity in this vast academic fiesta. So before starting my topic, I want to have some brainstorming. Do you know what is the mass? These slides you have seen earlier, but I have to introduce with this. Do you know what is the maximum share taken by the segment of medication in international pharma industry? Probably this is oncology, international. But if you go to an Indian setup, do you know this is the data? It is anti-infective. So if you go to the last 2 years, probably you are dealing with a infection. You know you are dealing with so many infections, and infections are predominant. And if you see, the infection is the biggest reason for hospitalization, and you are in the best hospital of this state. So you know our bread and butter is infection. But sorry to say that if you see this conference, I have counted around 96 topics given, only 6 topics given to the infection. That is what is the pity, because we are not giving much importance to infection. Now you can see the top 15 brands. You can see the 4th one is Augmentin, anti-infective in India. Top selling drugs in India, Augmentin second. Means sometime like that, anti-infective. This is the scenario. You can see the anti-infective is growing like anything. So you have to put some words, put some mind, put something, your brain in infection. And you know, Lord Jagannath is also suffering from infection. Every year takes rest for 2 weeks. And we are the saviors. That is why I am being here to present about another infection, scrub typhus, because it is a common differential diagnosis in your clinical scenario. Now you know scrub typhus is a rickettsia disease, the pathogen Orientia susugamusi. It is an acute febrile illness caused by gram-negative rod Sepes cocobalis. So, it's small organism can cause havoc sometime if you missed it. That is why this is the Susugamusi triangle. You can see this is the geographical area where it is mostly found, not found elsewhere. Nowadays it has been found in the developed countries as well. It was first seen in Japan 1899, almost 1 million cases annually in this triangle, but nowadays other areas are also affected. It was first in India, then Second World War, the military people were affected. Nowadays, you can come to the paper, I can see so many papers are coming with scrub typhus. This is Times of India article I have collected. You can see in the Indian scenario, these two states, Himachal Pradesh and the Rajasthan, are the leaders in scrub typhus. And see about our status. Probably we are in the third state, where is Odisha. And this is the death. Because people are not going for death, probably we are underestimating. This is in the red flag zone, you can say, the scrub typhus. This is what are the publications so far. You can go to the internet and check. So many publications, most from KIMS and some from AIMS. And so to say, these are the number of cases they have shared, and most of the topics they have searched for with a IgM ELISA, which I am going to describe in my topic. Epidemiology, you know, rat is the source of infection and the route of transmission is trombiculate mites. Small organism can do havoc, and this is the area where it is. And the children and adults, everybody is affected. There is no sex determination. Animal, rats are usually affected, but humans are accidental host. There is no direct person-to-person transmission. This is the cycle. As you know, this is usually the small mammals are affected, but it can affect humans, so they are accidental host. And this is the larva. It's a size of 0.3 millimeter, less than 0.3 millimeter, so it's not visible. Sometimes it can bite and cannot know. So the bite mark is usually less than 30% or so visible. Sometimes you can say the XR is most predominant sign to diagnose a scrub typhus, but sometimes may not get. I will be showing in what we have got in our papers. Incubation period around 6 to 21 days. 2 weeks is probably the sign, and systemic vasculitis, that is why multi-organ dysfunction occurs. Fever is the predominant sign along with headache, pain abdomen. According to the age group, probably it differs, and lymphadenopathy is common in almost all patients. And gastrointestinal symptoms like nausea, vomiting, abdominal pain are common in children. We have published few of the papers. One of them, we can see this is what we have got. The pain abdomen, the headache and fever are the common features. Rash, which I was saying, and the SCR are probably not so common in our studies. You can see the organ involvement also. The fever was common, 100% patient. The splenomegaly, the anemia, these are the signs, and the complication renal failure was common. If you compare between the pediatric and adult cases, it differs. I will be comparing. This is typical SCR, which I was saying. You can say this is the cigar bone appearance. But you know, it can happen in so many other diseases. And these are the common site. You can expect that axilla is a common site, and these sites are the common site of this axilla. So whenever you are getting a SCR at this site, probably you may think of a lesion of the scrub typhus. These are the prototypical early involvement of a SCR. Gradually they can go to a bone cigar appearances. These are the few of my publications, those the pictures which I have put in my paper. And as I have shared, SCR has a high, the study says that more than 60% there is chance of probability. But in our study you couldn't get more than 30% in any of the cases. And sometimes it can present initially with an ulcer with a red areola. So at what stage you are getting, you have to suspect. But it is the most specific manifestation. So you should know in which stage you are getting a SCR, because it is a pathognomonic time. Now, some studies say that SCR is a poor prognostic indices. In the Indian study, they have found so. Few trials are there, but it is not been yet confirmed. This is a comparative study between the laboratory and profile of scrub type of different age group. We have compared between adult and pediatric cases, around 60 cases, which I was saying. You can say about the clinical features. The hepatomegaly or hepatic involvement was more common in pediatric patients. Renal involvement were more common in the adults. And if you can say the rash, it is more common in adults, not in pediatric patient. SCR, you can see it is more in children rather than in adults. So this is a comparative picture, you can say, in both adult and pediatric patient. It can affect almost all organs, because it can have vasculitis picture. And I have to say that nowadays we are seeing patients of HLS. So keep your mind open whenever your patient is deteriorating. One antibiotic can save, your decision can save the life of the patient. Now the investigation, what to diagnose book says that it should be the initial test. Will Felix test is like the typhoid test, the Widal test. This is most non-specific, you can say. So the test which is commonly used is IgM scrub typhus, but the gold standard is indirect immunofluorescence, which is not done in our institute and most of the institute because it is costly and cumbersome. PCR, we have done few of our cases and we have compared. I will be showing some of my papers which we have used PCR as the diagnostic modality and comparison. Gold standard, as I have said, immunofluorescence, which we have not done, and IgM ELISA is the diagnostic of choice. Now it is as you know, this can be found in other diseases also. This has got low specificity and sensitivity, so not been considered as a priority. So IgM ELISA is usually considered. We have also compared between two, like the Will Felix sent an IgM ELISA and published one article for that. We found that it is around 30 to 40% sensitive. So it should not be used as a primary diagnosis like you would do a Widal test in. So this is another paper. I am not a part of this, although I was a part of this research. My name is not there. They had a comparison between diagnostic performance between serological test, IgM ELISA versus PCR. We have taken about 100 odd patients and sent them for the PCR. At the same time, those who are IgM positive. We have sent around 30 odd patients of adult patient, but not included in this study. This is the outcome. We could say that the IgM ELISA, if you think this is 100% sensitive and specific, you are wrong. Probably according to this study, this is 40 to 50% sensitive. So keep your mind open whether you are dealing with a case of scrub typhus, whether it is with IgM positive. Now the genetic studies, probably it is a bouncer for me. I know that this is done in our institute. I am not a part of this, but these are the few publications from our institute. They have done the genetic assessment and they have published. They have found out some new genetic assortment in the scrub typhus. So these are the part and parcel of research. You know, every disease, every infective disease in this area can be the differential diagnosis like dengue, the typhus, the typhoid fever, and meningoencephalitis. If you are dealing a case of meningoencephalitis, just think of whether you are dealing a scrub typhus, because according to the protocol, you are not going to give a doxycycline to the patient of meningoencephalitis. But if you put a doxycycline at the onset of an suspecting scrub typhus, the second day patient will wake up. So that is what is the clue, but you are going for differentiation. The common differential diagnosis is probably dengue. The CMC people have developed 6 criteria how to difference between dengue and scrub typhus. The type 2 they have found to be most useful. 6 categories, 6 type of the parameters they have taken. You can go to the internet, you can know how to differentiate. How my journey has started from 2014. From the first case I was given, this is the first case which I was diagnosed as scrub typhus. This patient presented from Nayagarh with a history of 25 days of fever with hospitalization in the local hospital. With almost all antibiotic he has taken, and he presented with fever, headache, and inguinal lymphadenopathy. We have done almost all tests including bone marrow and CT, but couldn't find anything. Then our microbiology people were doing, for their research, were doing Will Felix test. They informed that this is Will Felix positive, and retrogradely we have done we have given doxycycline. Next day patient become afebrile and requested for discharge. But every day in the round, when Will Felix was positive, we are undressing him for SCHAP. Probably that was new for us. Only one paper from Apollo was there. So, but why I remember this case? After 7 to 10 days of discharge, the patient came to OPD to show this, whether this was the thing which you are searching for. No, said this is probably not the SCHAP, but I have kept the picture alive for this session. So let's concentrate about antibiotic. I have already said that doxycycline is the key answer to this the treatment. If you are going for a doxycycline treatment and patient is not becoming affable in next 48 hours, probably this is not a scrub typhus. So not that ceftriaxone is the only drug of choice in almost all fever. Probably doxycycline is a key agent, but you should open your mind sometime diagnosis the scrub typhus. The thing as other agents are also helpful like azithromycin, but in our papers we have found that azithromycin, the patient has already taken azithromycin before hospitalization. So this is a very responsive to treatment. As I have said, some study says that only single dose of the doxycycline can clear about 40 to 60% of clearance. So the drug of choice, oral drug of 100 milligram twice daily for 7 days. In case of complication, you can extend up to 2 weeks. In pediatric cases, they are extending up to 2 weeks. Tetracycline can be given, usually you are not giving azithromycin. Usually is given, but we don't prefer because of the doxycycline cost and the effectiveness. Azithromycin has been found to be resistant in most of the studies, so probably this has to be dealt with pinch of salt. Chloramphenicol alternative to tetracycline and other antibiotic like roxithromycin, and one tablet of some rifampicin, they said it may be helpful in case of scrub typhus. Fluoroquinolone should not be used in any of the cases, although some studies say that it is helpful, but few studies deny this. Now the prognosis, the fatality is untreated cases is 5 to 10%. So early diagnosis is the key, early instrumentation of doxycycline. If patient is severe, go for a doxycycline IV therapy, and we have published a paper of IgM ELISA as a prognostic marker. If you go for a higher IgM in a patient, probably there is more organ involvement. Death is not there, we have not counted. Probably there is more organ involvement in our papers of around 60 to 65 patients. Now, the vector control is the key, you know, because it is due to a trombiculate bite. So, sometime when you are going to a endemic area, chemoprophylaxis of doxycycline to be given 4 weeks prior to the area exposed, to 4 weeks after is the therapy. Every weekly you can give and chloramphenicol, but there is no protective vaccine yet. So concluding my topic, scrub typhus is a common differential diagnosis in acute febrile illness. We have gone through a topic yesterday. He was saying about this. This is a growing and emerging disease, grossly underdiagnosed due to its non-specific clinical presentation, limited awareness, and low index of suspicion. Early diagnosis and treatment are imperative to reduce the mortality and complications. Thank you again. This is just the beginning. This is the end of the academic fiesta, what Dr. Panda has given since last 3 days. But I think this is the end. It is just the beginning of the academics of API for this year. Thank you. This is my the paper which I have in API. Thank you all. Thank you for the participation, and thank you for this academic event.
Thank you, Dr. Dharo, for the wonderful deliberation. Now, please, we'll have the memento.
Thank you all the dignitaries for such an enlightening session. I would like to request all our esteemed chairpersons to proceed to the memento podium for felicitations. As all good things must come to an end, so does this Apicon Odisha 2022. It really was a scientific fiesta for all the participants here. It was really a rich, fulfilling learning experience. So we have a trailer of what has happened in the last 3 days. So let's watch it. would now like to invite Dr. Bhagyashree Panda ma'am for the vote giving speech. Ma'am, please.
Good afternoon, all. Thank you all. And I request Chairman API Professor Dr. Jayant Kumar Panda sir to come on the stage for the valedictory function. Now I request Dr. K.N. Padhiyari sir, Chairman Scientific Committee, to come on to the stage, sir. And now I request Dr. Niharanjan Mohanty sir, Honorable Secretary API, to come onto the stage. After so much of academics and fun-filled cultural event, now we reached at almost end of the session. But here is the cheering session for the young generations who have sportively participated in the paper presentation, in the poster presentation, and quiz competitions. All the presentations were too informative and flooded with new ideas. Participation is important, and keeping aside winning, we have attractive prizes for best paper and best posters and best OPJ original articles and best abstract, and for the winners of the quiz competitions. Now I thank all the organizing committees. I especially thank Dr. Prasanjit Mohanty sir, Dean and Principal SCB MCH Cuttack. I thank Dr. Lucy Das ma'am, Superintendent SCB MCH Cuttack, Dr. Siddharth Das sir, and I thank Dr. Jayant Kumar Panda sir for as organizing chairman, and Dr. PC Das sir, chairman reception. And I thank Dr. K.N. Padhiyari sir, scientific chairman, and I am thankful to Dr. Manoranjan Behera sir for conducting the scientific committee, and I thank Dr. Sarat Chandra Singh sir for catering committee, and I thank Dr. Sanjay Kumar Behera sir for travel and accommodation, and I thank my Dr. Namita Mahapatra ma'am and Dr. Sarita Behera ma'am for entertainment and inauguration, and I thank Dr. Vijay Kumar Behera sir for media and advertisement, and for souvenir I thank to the chief editor Dr. Sipasad Mohanty sir and co-editor Dr. Sunita Sethi ma'am. And industry and exhibition, I am thankful to Dr. Pramod Raut sir and Siddhar Panda sir. I thank ma'am, Dr. Amita Karkata madam, respected teacher ma'am, in this organizing committee. And I am thankful to Dr. Sudhanshu sir for a delicious treat, and for the as a chairman of catering committee. And also I am thankful to Dr. Aradhana Sahu ma'am for the scientific session, and also our SRs like Dr. Veda, Dr. Diptiman, and Dr. Tejaswini, and all the second year PG students and or other PG students, especially second year students for their cultural event, and third year students for in this study, in this peak of the study, they have already participated in this. And now I thank our delegates who have kept our invitation and came to this event. I request Dr. Sambhu Datta sir to come onto the stage and say some words, sir.
A very good afternoon. It is as the previous speaker told, it is end of the, not the end of the journey, just beginning of the journey. And I am here today because of the entire team Apicon Odisha, and my special thanks to Professor Dr. Jayant Panda, whom I met recently when he went to talk at ACP National Conference in Vizag. And then we talked, and I made my willpower very strong that somehow I'll come and deliver a speech, and I'm very grateful to Professor Jayant Panda and Professor Padheri sir, who was our teacher also, and our General Secretary sir, and all the delegates here. And this is definitely one of the finest Apicon, I can say. And I have, being in military service, I have attended many state Apicons I have attended, other than national Apicon. And also critical care, CM is national level I go. But what I felt that if you compare this standard of Apicon, this is almost equivalent to a national Apicon. So everything, including the scientific program, the contents, the kind of specialists and super specialists who came from across the country, and cultural events, including the food, including everything, the look after, and I am actually overwhelmed. And I now see there is no reason why under Professor Jayant's leadership we can't go for a national Apicon at Cuttack. So that will be our dream, and we'll pray Lord Jagannath that we should be doing the next or the fastest national Apicon at this place. Thank you again.
Actually, you must not be knowing, Dr. Shambhu is the only invited faculty who has travelled from Vizag by train. And then he'll return today evening by train. All others have travelled by air. And he attends almost every state API. And then he stays till end. And he's the only invited faculty present in the hall. The rest all have left. So please give a big hand. Thank you for the words.
Thank you, Professor Jayant, and we'll be definitely meeting more often. Thank you. And maybe I'll also try that, probably sometime you can have a remote, or distant API Odisha at Visakhapatnam. Definitely I will also do my level best to do that. In case you feel any opportunity, please let us know.
Yeah, next president is there, so Chairman sir will take a call. Thank you, Dr. Shambhu.
Now I request Dr. Ashok Mahapatra sir to come on the stage and say some words, sir.
Good afternoon. It's an honor and privilege to be with all of you. Thank you so much. In fact, this is one of the Apicon I saw with lots of uniqueness. And this is only possible because of all the efforts that all of you have initiated. So many good things that has been noticed in this Apicon, particularly the academic feast, excellent, with fine representation from all wings. Truly a medicine conference. Infection, yes, why not? Infection was also presented, and infection had its role, and those are the very unique organisms that were discussed in this conference. And we saw many delegates who have attended with full enthusiasm. And only thing is that I remember that in 1982, when I was a medico here, we had the first national Apicon conference. And then it is difficult, but now I can see that with the team together, it is possible that we will have Apicon as fast as possible. It is possible, sir. And
was in 63. 1963 hosted first Apicon by Professor B.B. Tripathi.
Okay.
He was the national president. And 82 was the second Apicon in Odisha by Professor R.K. Parda.
Absolutely, but then this is almost 50 years, and I think this is time that we should look for.
Third in series has to come.
Absolutely, absolutely. And thank you so much for making things so eventful, and it's really a pleasure with interacting with all of you. Thank you.
Thank you. Thank you, Ashok.
Thank you, sir. Thank you for your kind words. Now I think we are thankful for the support of pharma companies. I mostly thank you, USP, Microlabs, Lipu, Sun Pharma, Mayor Vitabiotics, Novo Nordics, Dr. Reddy, IPCA, Torrent Pharma, Medley Integrity in Medicine, Cystopec, Auris, Mankind, Lupin, Alembic, Juventus, Alchem, Servier, Indesmic, Intas, Pulse, Aristo, MCure, MMC, Eris Life Science, JB Chemicals and Pharmaceuticals, MacLeod's, Biofar, Santara, Abbott, Kors Pharma, Synergy, and Biotonic for their helping hands and for making this event so much successful. Now this is now the time is to declare the winners. We conducted a paper presentation competition, poster presentation competition, quiz competition. In paper there was 48 papers from different medical colleges of Odisha, AIMS, KIMS, SOM, and Bhimsar, and Barampur, and SCB. All the PG students, 48 presentations were there. We divided them into 8 sessions, and each session we have selected one best paper for as a winner. Now I am announcing the winners of paper presentation, and they will be getting a prize money of 5,000. Now I request Dr. Priyanka Panigrahi from SCB MCH Cuttack to come to the dais and collect the prize money.
Chotra and Professor Manoranjan Behra to join. We'll felicitate the students who have got prize.
Dr. Priyanka Panigrahi, SCB MCH Cuttack. He is the winner of session 1 in paper presentation. Give a big applause. I request Dr. Nikita from SOM, Bhubaneswar, as a winner of session 2 in paper presentation competition. I request Dr. Nikita from SOM. Okay. Next, I request Dr. Dibyendu Sahu from SCB MCH Cuttack for winning in the session 3. Yeah. For Dibyendu, yeah, Smriti. Dr. Smriti is coming to collect the come quickly. Huh. As a winner of session 4, I request Dr. Srija Sarangi from Bhimsar Bulla to come on the stage and collect the prize money. Dr. Padmini Priyadarshini Ratha, SCB MCH Cuttack. She is the winner of session 5 paper presentation. Padmini Priyadarshini Ratha, SCB MCH Cuttack, is a winner of session 5 paper presentation. Sir, Dr. Bishwajit Bahal, SCB MCH Cuttack, is a winner of session 6 paper presentation. Dr. Sarmili Misra, Bhimsar Bulla. She is the winner of session 7 paper presentation. Dr. Pallavi Das, SCB MCH Cuttack, is a winner of session 8 paper presentation. Now coming to the poster presentation, there was around 90 poster presentation in different from hematology, nephrology, rheumatology, cardiovascular, central nervous system, and all the infectious disease, endocrinology, gastroenterology. In all these poster presentations were there. They are very interesting, and we have selected each from each session one poster, one best paper is selected. From hematology, I called Debasri Debidatta Samal from High Tech Medical College to collect the prize money of 3,000 each. There will be 8 prizes for poster presentation. 8 poster.
So anybody, senior resident or faculty, I think Sanjay Jangid is the faculty, he can collect. She is there? No. Sanjay can collect for her. Please collect it so that it will be official, and all of you will get certificate towards this. It will be printed, and please collect within 7 days from the secretariat.
Debasri Debidatta Samal from High Tech Medical College, best poster in hematology, High Tech Raulkela. Then Mitranki Rathi from MKCG Medical College for presenting a poster in nephrology. Vaibhav Balakrishna Gowda from Bhimsar Medical College as a best poster presentation in rheumatology. Asima Kanti Meej from Bhimsar as a best poster presentation in cardiovascular system. Asima Kanti Minj from Bhimsar Medical College is a best poster presentation in cardiovascular system. Okay. Asima. Abhiram Panda from SCV Medical College is best poster presentation in central nervous system. Then Tom Geo James from Bhimsar Medical College is a best poster presentation in the infectious disease, poisoning and pulmonary part. Next, Sagnik Rai from SCV Medical College is a best poster presentation in endocrinology. And Chinmay Kumar Ball from SCB Medical College as best poster presentation in gastroenterology. There are yeah, Chinmay. No, poster sorry. Gastro Chinmay Kumar Ball, SC Medical College. Odisha, OPG. Best original article in Odisha Physicians Journal 2022. The article, best article is Clinico Microbiological Profile and Culture Sensitivity Pattern of Microorganism Isolated from Diabetic Foot Ulcers. Study from a tertiary care center. The prize goes to A. Gauri Shankar Rao, Aswastha Ashokran Nair, Pradeep Kumar Behera and KP Tripathi from KIMS. Yes, sir. And best case report in OPJ goes to aortoiliac occlusion with paraplegia in a young male, a rare case of catastrophic antiphospholipid syndrome. Author being Rajdeep Sarkar, Subhankar De, Pradeep Kumar Behera, KP Tripathi and Sudhanshu Shekhar Panda from KIMS. Quiz. Now coming to the quiz competition. Thanks to Dr. Niranjan Mahapatra sir, Assistant Professor, SC Medical College for conducting the quiz as a quiz master. There was he has given very interesting and little bit difficult questions, and it was adored by all the participants in the quiz competition. We have selected three winners, first, second, and third. In the third, there was tiebreaker, and among them, we have selected the best one as third prize. First prize goes to Dr. Ritik Kumar Das Mahapatra, third year PG, SC Medical College. He will be getting a prize money of 10,000. Second prize in quiz competition goes to Dr. Debasis Panda, second year PG, AIMS Bhubaneswar. He will be getting a prize money of 8,000. Third prize of quiz competition goes to Ankit Biswas, third year PG resident Bhimsar Bulla. He will be getting a prize money of 6,000. Now there was a clear quiz competition by MMC Pharmaceuticals. The winners are Dr. Jaspragya Praharaj, MKCG Medical College. She will be getting an interesting watch. Dr. Jaspragya Praharaj, Dr. Ravi Kumar G.N. Bhimsar Bulla, Dr. Annesha Mahanti, SC Medical College, Cuttack.
On behalf of Dr. Ravi Kumar, another student of his college is for Ravi Kumar, please hand over this.
Sir. Congratulations.
Yeah, you can read the third winner's name again.
Okay. Third winner is Dr. Annesha Mahanti, SC Medical College, Cuttack.
Please hand over.
You stay, you will have a group photo together.
Yes, doctor. Yes,
This is a very good smart watch and a good memento they are giving. Thank you, MMC, for academic activities.
thank you. It's our pleasure, doctor.
Thank
Give
you.
us an opportunity to participate in your academic event.
Thank you. Thank you.
And in fact, we are so much enthused that there were 80 participants. More were throwing it to our counter, which was a rare pleasure for us. It is in fact motivates us and encourages us to do such kind of activity again and again.
Thank you. Thank you. Thank you for the participation. Thank you. Almost all prizes are declared. There are two surprise. Sir, please stay back for 1 minute. Stay back. We have two surprise prizes for people who have worked for this conference very hard. I see invited faculties. I see faculties other than from medicine department. I see my postgraduates. I see KIMS, SHAM, High-Tech, AIMS, Bhimsar, MKCG, and then High-Tech, Rourkela, all participating in a big way. And then it's a pleasure that SCB has united everyone, so many papers, so many presentations, not only locally, nationally, it has created a ripple, and many people are happy in the event. So for the success of event, all have contributed. We cannot call everyone here, but each one, faculties, delegates, postgraduates, each one have contributed. But two particular persons I want to call on stage, and I request to get flower bouquet for them. One is Mr. Suraj Jena. You see, from stalls to hall, from press to market, one person is running for so many months. He is our event manager from the creative event who has coordinated the whole thing. And I recognize his service and want that he should be felicitated with a bouquet of flowers. And the second person or the second group of people I'd like to invite here is Mr. Shamim and team, who have done a very good work, and I'll also request Satya to Jayan. So it's a mixed type of thing, fusion type of thing from Torrent and the USB, who have done so much for the scientific, all the flow of the slides, all the presentations, all they have coordinated. Please give a big hand. Thank you. I'll also thank the HK Visuals, the projection people, and those who have done maximum for the conference, especially two teams. One is Lipur, who has conducted the registration, and Mr. Mithilesh is not here. I'll send special recognition to him, and Shanatra team. The Manotosh is not here. I'll spend special recognition to him. All the mementos are prepared by Shanatra, and all the registration is conducted by Mithilesh. So personally, I'll thank them, and then I'll send the mementos to them at their place. Manotosh is from Guwahati, and Mithilesh is from Gaya. So next, it's a pleasure. I request guests to be in seat, and then we'll have Team Raurkala, Professor Sadhanand Mahapatra and Dr. Keshi Mahanta. I don't think they are here. They have bid for the next conference. So it's customary that they invite all of you for the next conference, but on their behalf, because they had to start for the Raurkala, they have started. Only thing, the message goes, the dates has to be blocked, the organizing committee has to be formed, and the scientific committee has to start working. And as a principal, Professor Surendra Shwai, or President-elect, is the chairman scientific committee. That has been fixed. So organizing secretary, the GB has given responsibility to Dr. Keshi Mahanto. And then Shraddhanand Mahapatra has taken over as the chairman of organizing committee. And then you'll be happy that for hockey, very soon a airport is starting in Raurkala. We are thinking of utilizing Jharsuguda, but Raurkala will have a airport by the time we will have our conference. So it will be one of the great extravaganza. I'll see that this is better than that, because the Raurkala is the first metropolis town of Odisha, where the civic center, the Indo-German club, they are exotic places. And for workshop, IGH is competent. So I have discussed with them. We'll host it in Raurkala. Personally, I'll take the leadership in coordinating things, getting sponsors, getting the faculties, and that conference next November, December will be better than this, and I expect the same response from the whole team, the postgraduates, faculties, and every physician of the state to come, so that we'll continue the trend of doing successful events. Then the last part before we go for the national anthem is the elected body of 23. GB has elected them. We'll invite them on stage. We'll have a group photograph of the present team and the elected team together, and I have to give this most precious medallion. It's what doesn't go alone, takes all the responsibility from one person to another person, and this medallion transfer takes place in the valedictory. So I invite all executive committee members The chairman is here, Dr. Chotrai. I think vice chairman is not here. Lalati is not here. Okay. And Pradeep is here, the joint secretary of the EC. Please come on stage. Nihar is here, our EC. I request Sudhanshu, our treasurer, to join. Please join. Sudhanshu, our treasurer. Secretary is here. And regarding the members, we have around 7 members from the different presentation. Cuttack, Professor Dalai was nominated. I think he is not here. Barampur, Dr. Nihar, please come. Burla, we continued with Dr. Atanu Thakur. I think he has left. Bhubaneswar, we elected Dr. P.K. Mohanty, Umakant Mishra, I think. P.K. Mohanty, private practitioner. Umakant Mishra, he is not here. P.K. Mohanty from the private practitioners. From public sector undertaking, Dr. Amitabh Mohanty. And finally from Raudkala, Dr. Durgesh Shaw. They are not here. So, fine, we'll have a photograph together and the medallion transfer, and I request Dr. Santosh Swai to come on stage, and our important members of the SAB, Dr. Amita, the treasurer of the organizing committee, and Dr. Sanjay, the travel chairman, to join on stage, and we'll have this formal medallion transfer program followed by a group photograph and national anthem. Thank you all.
So good afternoon to all. The thing is that I am taking the baton from a very responsible and very dutiful person. I doubt whether I will be able to organize the same next year API in the same spirit and same magnitude. It's impossible because it seems like a national Apicon. And he has selected so many speakers from national famous, and he has he's be able to bring them to the one place. That's great. And the food and the scientific vista, everything is very nice. And because of his team, who is very tirelessly doing, and he has got a very good person as a scientific chairman, who is very, 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 very efficient. So I hope that next year he will be helping me, and his team will be helping me to carry out the Apicons, next Apicon. Thank you all. I invite you all to attend the next Apicon. Thank you if time permits. At Raulkala.
I'm already included in your team, sir, as past president. So we'll all work together. So let us put our best efforts to unite physicians of Odisha, and we'll be able to host the national conference. That's what is our destination. Thank you. Now we'll go for national anthem. I request all of you to please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
End of the conference, and thank you everyone for being with us. Take care. Get ready for the next year.